بسم الله الرحمن الرحيم. الصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. Respected colleagues, distinguished speakers and guests, it's honor and pleasure to welcome you today to the annual Saudi Lymphoma Myeloma meeting for 2022 and the Hematopathology Overview 2022. These two meetings are held annually. Today will be the Saudi Lymphoma Myeloma program, and tomorrow will be the Hematopathology Overview program. And tonight we also have sessions, satellite sessions from our sponsors, and you're all invited in the evening. It will be in the Pereira Hotel and Nakhil Mall. The program starts 8 o'clock. So we have actually, today we have, and tomorrow, we have wonderful programs that made by an elite scientific committee with distinguished speakers, great talks, and it's a mix of update and advancement in hematology, as well as experiences from local institutes and research. And that's what the Saudi Society of Blood and Marrow Transplantation has adopted to enrich and encourage and incentivize the local experiences and participation. So thanks to all those who participated as speakers and to our distinguished guests who traveled all the way to be with us today. And thanks to you all, our members, for being here today and for your participation. We have 26 speakers in total for the program. So please enjoy and interact with these talks. We have exceeded now 2,700 members in the SSBMT, and that's a great number. And thank you all again for your participation and your contribution to the Society's activities. Today we have also exceeded 500 participants, registrants, and again, thank you for your support. The SSBMT and the Saudi Lymphoma Group, who's organizing this meeting today, also embarking on enriching the educational activities, and there will be a number of courses held next year. Most of these courses will be focused on people in training and to help, again, our colleagues and younger and junior hematologists in their training programs. So without further ado, I would like to thank our sponsors, and particularly AstraZeneca and Roche for their generous support. Again, I wish you an enjoyable and fruitful program for today. So allow me to invite our chairs for the first session, Dr. Ayman Ibrahim, who's a consultant hematologist at King Abdulaziz Medical City of the National Guard Health Affairs in Riyadh, and Dr. Ahmed Al-Saghir, who is also a consultant hematologist at John Hopkins Aramco Healthcare Institute. So please, Dr. Ayman and Dr. Ahmed, if you come to the podium and start our program. Thank you. You may leave this bar, huh? Do they need it?
عليكم ورحمة الله وبركاته. صباح الخير جميعا. Good morning. Pleased to be with you, and شكرا دكتور أحمد Jaska for the invitation and for the leading committee. The first speaker, and both are very well recognized and known to us. Is Dr. Mohsen Zahrani, who's the senior consultant hematologist, and he's the head of the stem cell transplant cellular therapy. There is a brief introduction for him. دكتور محسن له من اسمه نصيب كبير. تفضل.
Assalamu alaikum. Thank you, Dr. Ahmed, for the nice introduction, and I would like to thank the organizing and scientific committee for inviting me to present in this conference. So my talk will be about the role of allogeneic stem cell transplant in lymphoma. I chose this topic because my main interest and my work actually in doing transplant, and we want just to review update about allogeneic transplant, because now we have new modalities of therapies, so the role of the transplant is becoming less, so we need to update ourselves about this topic. I'll talk about transplant for non-Hodgkin lymphoma, then Hodgkin lymphoma, then we'll talk about our experience at King Abdulaziz Medical City here in Riyadh. As an introduction, allogeneic transplant used to play a defined role in the treatment of lymphoma. With the advent of modern targeted molecular therapies, immunotherapies, CAR-T therapy, treatment standards, at least for B-cell lymphoma, have undergone significant changes, thereby questioning the traditional role of allogeneic transplant in these diseases. We will describe the current place and perspective of allogeneic transplant in rapidly evolving treatment landscape of non-Hodgkin lymphoma and Hodgkin lymphoma. Diffuse large B-cell lymphoma is aggressive type of lymphoma. Previously, allogeneic transplant is indicated for relapsed cases post-autologous transplant. Graft versus leukemia effect control the disease, as evidenced by effectiveness of immunomodulation post-allogeneic transplant and the use of FRIC regimen when we condition those patients before transplant. So we rely mainly on the GVL effect to control the disease, and we see some responses reaching up to 30 to 40% long-term remission or progression-free survival post-allogeneic transplant, indicating that there is some immunologic effect against DLBCL by doing allogeneic transplant. This is a large CIBMTR study, more than 2,600 patients of lymphoma undergoing allogeneic transplant. 63% of them received RIC conditioning and different types of the transplant. As you see in the left curves, the BFS was the highest for follicular lymphoma, indicating that the GVL effect is very good for follicular lymphoma, and the lowest for diffuse large B-cell lymphoma and Hodgkin lymphoma. Similar overall survival was the best for follicular lymphoma, followed by mantle cell lymphoma, so both low-grade lymphomas relatively for mantle cell, and the worst for diffuse large B-cell lymphoma. And we know the overall survival for the LBCL in those relapsed post-autologous transplant is very dismal, and in Scholar 1 study, it reached less than 20%. The relapse risk was high in DLBCL and Hodgkin lymphoma, and the lowest for the low-grade lymphomas like follicular lymphoma and mantle cell lymphoma. Also, in the same study, they try to correlate between those patients who develop the GVHD and the risk of relapse. We see the very good effect of GVL in mantle cell lymphoma and follicular lymphoma. If you see in the left figure, those patients who develop acute graft versus disease, acute or chronic, they have the lowest risk of relapse compared to those who never develop acute or chronic GVHD. And the same thing for follicular lymphoma. We know CAR-T is becoming standard of care as a third line, or for those who relapse post-autologous transplant in DLBCL, and this already changed our algorithm for managing DLBCL for those who relapse post-autologous transplant, and making the allogeneic transplant in the lower scale in the algorithm. There is no randomized study between allogeneic transplant and CAR-T therapy, but this is one of the retrospective studies from Heidelberg, Germany. They reported the outcome of patients who underwent allogeneic transplant and those who underwent CAR-T cell therapy. As you see, there is a trend of survival benefit with CAR-T compared to allogeneic transplant. We have to consider in this study the follow-up was short for CAR-T. So we need longer term follow-up to see if this benefit in survival will continue. So conclusion for DLBCL, allogeneic transplant remains an indication for advanced DLBCL when CAR-T fail or it's not available. So traditionally now we consider it in CR4. Future role of allogeneic transplant may change or diminish in the future because we have other options like bispecific and the CAR-T also now used in the second line. Follicular lymphoma, it appears it's a low-grade lymphoma and appears to be the most GVL or graft versus lymphoma sensitive disease among all indications for allogeneic transplant. The 5-year relapse is less than 20% in many studies for follicular lymphoma, so indicating that if the patient undergo allogeneic transplant, they have a GVL effect, they will have very low relapse rate. The number of allogeneic transplant, however, in this subtype is decreasing since several years, making follicular lymphoma the least frequent allogeneic transplant indication for in the 4 entities that we mentioned before. And this is a study from the EBMT from 2018. They looked to all patients who underwent allogeneic transplant. And as you see, the lowest number of cases or diagnosis was for follicular lymphoma because we have many options now. We can manage follicular lymphoma patient with them and to avoid the toxicity of allogeneic transplant. So reason why number of allogeneic transplant is decreasing for follicular lymphoma, number one, indolent course of the disease. The high efficacy of standard first-line treatment with chemoimmunotherapies and CD20 antibody maintenance, so many patients may stay in remission for years. The availability of a broad effective salvage options like Revlimid, targeted therapies, autologous transplant, and now CAR-T is also approved. The high transplant-related mortality post-allogeneic transplant always offset the benefit of low relapse rate in this disease. So conclusion for follicular lymphoma, patients who are resistant, it's indicated for those patients who are resistant to less aggressive approach, especially those who relapse early after salvage autologous transplant or similar intensive regimen. Patients who we plan to do for them autologous transplant, but we cannot do transplant because either they fail mobilization or they have bone marrow involvement, or they have myelodysplasia, or they have exhaustion of hematopoiesis represented by cytopenia. So allogeneic transplant can be considered in these cases. Now we'll shift the gear to mantle cell lymphoma. It's again a type of non-Hodgkin lymphoma. Mantle cell lymphoma is sensitive to graft versus lymphoma effect as evidenced by decreased relapse after allogeneic transplant using REC regimen and the sensitivity to DLI. DLI is the donor lymphocyte infusion, which we use post-allogeneic transplant if the patient is having a mixed chimerism or showing early signs of relapse. So we take a donor lymphocyte and we infuse it to the recipient to trying to control the disease relapse. As you see in the study on the right side from EBMT, also 118 patients, they look to the patients who underwent allogeneic transplant for lymphoma and subsequently they received DLI. The blue bar is indicating those who achieved CR. So you see high CR in follicular lymphoma and mantle cell lymphoma and peripheral T-cell lymphoma compared to DLBCL. So this indicates this disease is sensitive to GVL or to the lymphocyte effect. Also, the mantle cell lymphoma, they enjoyed the longest duration of response post-DLI. This is another study, mantle cell lymphoma, also from ABMT retrospective study, looking for those patients with mantle cell lymphoma who relapsed post-autologous transplant and underwent allogeneic transplant. So if the patient did not go allogeneic transplant compared to those who received allogeneic transplant, we see clear benefit of allogeneic transplant for this group of patients. And this benefit is more remarkable for those who relapsed more than 12 months post-autologous transplant. The ESMO guidelines put the allogeneic transplant in the algorithm of managing mantle cell lymphoma post-autologous transplant as a consolidation of second-line therapy in fit patients. We know autologous transplant is the standard of care to consolidate first CR in mantle cell lymphoma. If the patient relapses post-autologous transplant, they will receive second line. So in ESMO guideline, they put allogeneic transplant as an option to consolidate the response. We know we have many new effective therapies for mantle cell lymphoma, like BTK inhibitors, lenalidomide, bortezomib inhibitors, CAR-T, BI3K inhibitors, venetoclax, monoclonal antibodies, BiTE antibodies, antibody-drug conjugates, very effective, many of them approved, and these new drugs will limit the utilization of allogeneic transplant in mantle cell lymphoma also. This is very nice publication recently by Dr. Mubarak al-Mansour. He put algorithm for managing relapse mantle cell lymphoma. And as you see here, in fit patients, as a second line, typically we use BTK inhibitor or bendamustine or lenalidomide. But in the third line, we see allogeneic transplant there competing with CAR-T. Of course, if CAR-T is available, we will go for the option of CAR-T, and this will push the allogeneic transplant to the fourth line. So conclusion for mantle cell lymphoma, the place of allogeneic transplant in treatment of algorithm of mantle cell lymphoma is changing and can be considered in the fourth line, or patients who are refractory to CAR-T therapy. We shift the gear to peripheral T-cell lymphoma. A standard treatment approach for peripheral T-cell lymphoma is especially ALK negative or ALK positive anaplastic large cell lymphoma, angioimmunoblastic T-cell lymphoma, and peripheral T-cell lymphoma none otherwise specified. So usually we treat them with CHOIP chemotherapy for 6 cycles, and we consolidate the first treatment, first line by autologous transplant. We expect to have 5-year PFS 35 to 45%. This disease represents unmet need, and they have usually a dismal prognosis if they relapse. GVL effect, or graft versus leukemia or lymphoma effect, is visible in peripheral T-cell lymphoma, similar to follicular lymphoma and mantle cell lymphoma. Peripheral T-cell lymphoma appears to be quite susceptible to GVL effects, as indicated by survival plateau around 50% after allogeneic transplant across numerous studies. Efficacy of DLI, as I show you one study, to control the disease relapse. RIC regimen or conditioning provide outcomes in BT cell that are at least similar to that observed after myeloablative conditioning. This prompted the exploration of allogeneic transplant in the first line consolidation. We have this study. It's the only randomized study for allogeneic transplant in lymphoma in general. So it's a phase 3 trial looking for the benefit of allogeneic transplant as a consolidation of the first line treatment, comparing it with autologous transplant. So it is a nice study. Around 104 patients were randomized to autologous transplant or allogeneic transplant. So the patients will receive CHOIP, then DHAP, then will undergo transplant, either autologous or allogenic. As you see in the upper curves, there is no statistical significant benefit of allogeneic transplant compared to autologous transplant regarding BFS, EFS, or overall survival. However, if you see in the lower curves, the left side, the relapse rate was 0 after allogeneic transplant compared to autologous transplant. Unfortunately, this very low relapse rate was offset by the high mortality or transplant-related mortality that we see with allogeneic transplant. This is why this study was actually a negative study. What about allogeneic transplant as a consolidation of second-line therapy in peripheral T-cell lymphoma? This is another retrospective study from SSBMT, 240 patients who relapsed and underwent either second-line, then autologous transplant or allogeneic transplant. Here we see a clear benefit in survival of allogeneic transplant compared to autologous transplant. So peripheral T-cell lymphoma, when they relapse, you give them second line, you go ahead with allogeneic transplant, not autologous transplant. Conclusion for peripheral T-cell lymphoma, autologous transplant is a standard of care as a first line. Allogeneic transplant can be considered in consolidation of second line therapy. We can consider it as a first line in selected orphan subtype, such as hepatosplenic T-cell lymphoma. We know this subtype is very aggressive. It acts like acute leukemia, so preferable to do allogeneic transplant. As a final recommendation from this Dr. Peter Drager in this paper, he put his recommendation: large B-cell lymphoma, allogeneic transplant considered as a fourth line after failure of induction or failure of both autologous transplant or CAR-T therapy. For follicular lymphoma, if there is early relapse after salvage autologous transplant or similar intensive regimen, or if there is emerging exhaustion of hematopoiesis or myelodysplasia. In mantle cell lymphoma, it's considered as the fourth line after failure of induction or BTKI and CAR-T therapy. And peripheral T-cell lymphoma and relapsed refractory disease. For Hodgkin lymphoma, ESMO guideline in 2020, they put it as an indication for patients who failed autologous transplant. If we do allogenic transplant for Hodgkin lymphoma patients, we expect in many studies the BFS is around 30% and long-term overall survival is around 60%. However, from SEP study looking to the number of Hodgkin lymphoma undergoing allogenic transplant, we see a trend of drop in the utilization of allogenic transplant over the last few years. Despite there is significant improvement in survival curve in the last era compared to previous decades, indicating that there is improvement in the conducting transplants, selecting patients, supportive regimens. So allogenic transplant in Hodgkin lymphoma indicated in relapsed cases post-autologous transplant, and in those who are double refractory to checkpoint inhibitor or brentuximab vedotin. This is SSBMT 2022 guidelines for allogenic for transplant of different types of diseases, including the lymphomas. So they put the indications for matched donor, match unrelated donor, mismatched donor, autologous, and CAR-T. If we look to the diffuse large B-cell lymphoma, so GNR indicate generally not recommended, CO indicate clinical option, and S is the standard of care. We see standard of care more for autologous transplant and CAR-T compared to allogenic transplant in DLBCL. For follicular lymphoma, it is a standard of care if there is relapse post-autologous transplant. For mantle cell lymphoma, it's a clinical option, but autologous transplant is a standard of care in first line, and CAR-T is a standard of care if there is a disease relapse. Peripheral T-cell lymphoma, it's a standard of care in chemosensitive relapse in CR2. And for Hodgkin lymphoma, standard of care post-autologous transplant. And the remaining part of the presentation, I will present our experience in doing allogenic transplant for lymphoma. So our center here in National Guard or King Abdulaziz Medical City, we started our transplant program in 2010. So far, we did more than 1,200 cases in general, all diseases. We do allogenic, autologous transplant, all types of the transplant, and we have all options of the donors. Our guideline for indication for transplant allogenic in Hodgkin lymphoma, relapse post-autologous transplant, plus not in CR post-checkpoint inhibitor. High-grade non-Hodgkin lymphoma, relapse post-autologous transplant or post-CAR-T. Burkitt lymphoma, relapse or refractory to first line. So we consider allogenic transplant, not autologous. Peripheral T-cell lymphoma, relapse post-autologous transplant. Other T-cell lymphoma as a first line in hepatosplenic gamma delta T-cell lymphoma. But in general, peripheral T-cell lymphoma, relapse post-auto. And other low-grade lymphomas and relapse post-autologous transplant and more than CR2. So in total, if we look to all our cases of lymphoma who underwent autologous allogenic transplant, 25 cases, majority male 68%, median age is 25, but we did up to 52 years old. 15 patients, they have the Hodgkin lymphoma, and 10 patients non-Hodgkin lymphoma. The median number of previous lines of therapy, 5, but some patients received up to 8 lines. 76% of patients received previous autologous transplant. And before allogenic transplant, 48% of patients, they were in CR, 48% in BR, and 4% they were having refractory disease. These are the subtypes of lymphoma: 15 Hodgkin lymphoma, all of them classical Hodgkin lymphoma, 10 non-Hodgkin lymphoma, 5 high-grade B-cell lymphoma, 2 diffuse large B-cell lymphoma, 1 Burkitt, 1 primary mediastinal, and 1 plasmablastic B-cell lymphoma. And 5 T-cell lymphoma, 2 angiomoblastic, 2 anaplastic large cell lymphoma, and 1 TLBL. We did not do any low-grade lymphoma allogenic transplant. Transplant characteristics, majority of donors match-related, 16, 2 match-unrelated, and 7 haplo. In the haplo, there are 2 in the non-Hodgkin and 5 in the Hodgkin group. Almost all cases underwent peripheral blood as the source for stem cell collection. Conditioning regimen, 20 male ablative conditioning and 5 RIC. Additional therapies, 10 patients post-allogeneic transplant received additional therapies in form of checkpoint inhibitors, BV or DLI or radiation therapy. Disease response, 48% of the patient achieved CR post-transplant, 1 BR, 40% relapsed or disease progression, and 2 patients, they were not evaluated yet, 1 early death in the first month and 1 not due for evaluation. There was no difference in the CR rate between Hodgkin and non-Hodgkin lymphoma. Mortality, we have 7 mortalities, 28%, mainly from relapse, 16%, and transplant-related mortality, 12%. 64% of the patient develop GVHD. Interestingly, and those who have continuous CR, they have higher rate of GVHD, 75%. So this may contribute to the maintaining the CR in this patient. The median follow-up was 16 months. Event-free survival was median 44%. Overall survival 64%, which is very acceptable in a group of patients who have multiple relapses, and majority of them underwent autologous transplant. If we look to the difference between Hodgkin and non-Hodgkin lymphoma, there is no difference in the EFS and overall survival. Survival based on GVHD, there is statistical significance in favor of those who develop GVHD. They have longer survival. There was a trend to reduce the relapse and progression-free survival, and this may contribute to the improved survival in the group who developed graft versus host disease. So in conclusion, allogeneic hematopoietic stem cell transplant is still an important therapeutic option for the lymphoma. We should not ignore that. The order of allogeneic transplant is changing, and the algorithm of managing lymphoma is changing or becoming less frequent in some subtypes, especially in the presence of the new novel therapies. Exception of this is T-cell lymphoma. I don't think until now there is any change in the recommendation for allogeneic transplant, but we will hear today also from Dr. O'Connor his presentation about T-cell lymphoma management, and if there is new agents that can change the algorithm of management of T-cell lymphoma. We have to recognize that allogeneic transplant until now is the only curative option for many diseases, including lymphoma. In our center data, we saw favorable outcome, and this could be related to many factors. Higher rate of patient received myeloablative regimen, higher rate of GVHD, subtypes of the lymphoma, majority were Hodgkin and T-cell lymphoma. Our transplant cohort is recent in the last 10 years, and we know from many registry reports the recent years of transplant was associated with less transplant-related mortality because of improved supportive care, better selection of the patient, better selection of the conditioning regimen. And 10 patients out of 25 received additional therapy post-transplant. Thank you very much.
Thank you, Dr. Mufti, for the excellent talk and information time. I think we can have the question now, if there is any question from the audience. Ahmed Said.
Shukran, Dr. Mohsen, for this nice experience. So I see you transplanted 25 patients, 15 of them were Hodgkin lymphoma. So I have 2 comments. Your GVHD is 64%. So did you look into the impact of checkpoint inhibitors in these patients in regard of GVHD? And the other point, I noticed that you use mostly MAC. Do you think if you use REC in Hodgkin patients, this might improve also the outcome?
Yes, so in general, there is no increased rate of GVHD in those patients who received checkpoint inhibitor post-allogeneic transplant. We have to make sure that the patient doesn't have GVHD.
They use it usually pre.
Yeah.
Post auto.
We don't use it, but some patients who show early signs of relapse, or maybe the primary treating physicians think this patient is very high risk for relapse. He started him checkpoint inhibitor. We did not look into details why they were started in checkpoint inhibitors, but we did not find there is increased risk of or developing more GVHD in this subgroup of patients who received checkpoint inhibitors. For the other question, yes, MAC, but it is not like it's. We use fludarabine. plus fludarabine plus melphalan in majority of the cases, and fludarabine basalfan. Sometimes we give basalfan 3 days. So it is like reduced toxicity, not fully myeloablative regimen.
Mohsen, what would be your prediction or this data on the effect of CAR T-cell refractoriness on the outcome of allogeneic transplantation? So these are not the same patient that we used to refer for allo-BMT.
Yeah.
Do you think that this will have an impact on the outcome?
Yes, we don't have data, of course. As I show you, there was like this randomized, not randomized, the retrospective study from Germany, where they looked to the two groups. There was trend to having like better effect of CAR T compared to allogeneic transplant. But those patients who were refractory to CAR T, I'm not sure, but this patient represents unmet need, and especially if they have diffuse large B-cell lymphoma and we are not able to control them with CAR T, I assume the prognosis will be very poor in this group of patients. But again, we need to look into studies to this group.
Any more questions?
Thank you.
Second speaker, Prof. Riyad Dada. He's a well-known to all of you, and Prof. Dada, he has completed his medical school and training in Germany, and he has been like since 2011 employed as a senior consultant at the university in Germany, and he's in well-known journals, and Prof. Dada is going to present outpatient fractionated ICE protocol in relapsed refractory lymphoma.
Thank you, Dr. Ibrahim. And thank you, Dr. Ahmed Al-Askar, our senior, all of the respected. And thank you for the organizing committee for the invitation. So, chemo, this is something and step back. So we are speaking about allogeneic and CART and BITES and I don't know what else, but the fact is all of us, we are dealing with chemotherapy. We cannot cure our lymphoma patients without chemotherapy. And I was requested to speak about our experience at King Faisal Hospital in dealing with lymphoma patients, and this is our last work, what we have recently published. It's about using outpatient fractionated ICE protocol in relapse and refractory lymphoma. And when we speak about lymphoma, we're speaking about Hodgkin and non-Hodgkin lymphoma. That's why the next few slides will be splitted. So introduction, maybe diffuse large B-cell lymphoma, as you know, is the most common type of lymphomas. Half of the patient, more than half of the patient, they are 60 years old and older. Majority of the patient, they will come to the physician, to the oncologist with advanced stages. Hodgkin lymphoma, median age is 38 years. The 5-year relative survival is 86%. And most of the cases, they are coming to their doctors in early stages, unlike the diffuse large B-cell lymphoma. The outcome with conventional chemotherapy, we know that we can cure around 50 to 60% of diffuse large B-cell lymphoma. And unfortunately, there are some patients who are primary refractory. 10 to 15% of the patient will be primary refractory. And of those who went in complete remission, around 70 to 80% will go in complete remission. Out of these patients, around 30 to 40% will eventually relapse. And the standard of care, of course, for eligible patients is the autologous stem cell transplantation. And with the autologous stem cell transplantation, we can cure around 50% of the patient. But we have first to bring the patient in remission in order to go for transplantation. In Hodgkin lymphoma, the data look similar in some extent, especially in patients who are going for autologous stem cell transplantation. Only 50% of the patient will be cured with the autologous stem cell transplantation. And if we have a patient who is relapsing and we think on transplantation, or even some patients who are not eligible for transplantation, what are the options in diffuse large B-cell lymphoma? And I listed here some of protocols, and there is no one standard of care. There are several protocols that can be used from the hospital to hospital. It's different according to your training and what you are familiar with. You could use RISE, DHAB, whatever you use. The response rate is in the range of 50%, 50 to 60%, in some papers 40%. The patients who you will able to and succeed to transplant is in the range of 50%. The 3 years progression-free survival is in the range of 30%. In Hodgkin lymphoma, situation is a little bit better. The regimen what I listed here are not including any of the novel agents, because we are here looking to chemotherapy in our outpatient fractionated ice regimen. And I listed only chemotherapy regimen. I didn't list the brentuximab and nivolumab and pembrolizumab data. The regimen listed here, in general, overall response rate we could see in the range of 60%. The complete remission rate is in the range of 30%. So, and the very important question is, what about the status pre-transplant? Is it important in diffuse large B-cell lymphoma? Because this is for our data also important. A complete remission rate, according to this study, might be not necessary, and there is any partial remission patient can go also for transplant in diffuse large B-cell lymphoma. But we have, there are different degrees of partial remission. I think every experienced physician will know this very well. There is obviously, according to this trial, retrospective trial, there is no difference between the outcome between patients who went in complete remission to autologous stem cell transplantation or in partial remission. In Hodgkin lymphoma, again, here the situation is different. Patients who have a complete remission prior the autologous stem cell transplantation have a better outcome than those who has partial remission according to the data. And now we are coming to our protocol, outpatient fractionated ice. And this is, again, he is not dealing with a specific subtype of lymphoma. It's dealing with all lymphomas who are going for transplant, are some of our patients who, including in the study, who are not eligible for transplant, also Hodgkin lymphoma and non-Hodgkin lymphoma. What's the rationale for our data? The outpatient fractionated ice is not a new invention from us. It's we modified a little bit on that. It has been reported earlier. We implemented this since maybe 7-8 years. We are treating our patient with outpatient fractionated ice because, as I listed here, the quality of life of the patients, especially Hodgkin lymphoma patients, they are young and they don't want to be admitted in the hospital. Ifosfamide is going over 24 hours, and in many hospitals, the patient has to be admitted for the classic ice regimen. And one of the strongest reason why we try to implement this protocol is the increased beds, the increased demands on beds. We have, the medical oncology has 15 beds and we are treating more than 1,000 patients per year, and there is really a huge pressure on the beds. That's why that was one of the main drivers why we looked at these protocols. So the one above up is the classic, the conventional eyes from GCO Moskovitz, which is including ifosfamide, 5 gram per meter squared, giving over 24 hours, together with Misna and carboplatin, 5 EUC, and etoposide, 100 milligram per square meter. So if you look to the regimen below, this is our regimen. So carboplatin and etoposide we didn't touch on. The ifosfamide, we split the dose. Instead of giving 5 gram per meter squared over 24 hours, one shot, we split the dose to 1,500 milligram per square meter to be given in D1, D2, and D3, each over 2 hours. So these are the patient characteristics. The median age of the patient is 30. Majority of the patients, they had Hodgkin lymphoma, maybe because Hodgkin lymphoma in Saudi Arabia is more than other lymphoma subtypes. Around maybe 60%, I would say, they were Hodgkin lymphoma. Many of the patients, they were in advanced stages. And time from end of initial therapy to relapse was just 4 months, which means we are dealing here with a population of patients who are not easy to treat. Again here, the distribution of primary refractory, non-primary refractory, vast majority of patients, they had a primary refractory disease, 64%, 63% had primary refractory disease, around 40% had extranodal disease, and the stage at relapse, also when the patient relapsed, the vast majority of the patient, they had high risk and having advanced stage 3 and 4. Patients percentage was 87, 88%. So before we go to the results, the factors which, as you could see, which might affect the results is that the significant number of patients included in this retrospective data analysis, they had a primary refractory disease, as a 63%, they had advanced stages, 88%, and many of them, they had extranodal disease. But despite that, the results were not very bad. The overall response rate was 48% among all patients, primary refractory and non-primary refractory, with complete remission rate in the total population of 21%. Looking to non-Hodgkin lymphoma, the overall response rate was 47%, which is in the range to what we have seen. And in Hodgkin lymphoma, 49%. 75% of eligible patients proceeded to autologous stem cell transplantation, as among those who are eligible to transplant. Looking to the patient who are primary refractory and non-primary refractory, the situation here looks really interesting. How outpatient fractionated eyes is doing in non-primary refractory. This is really good results. The overall response rate was 63%, with interesting complete remission rate of 42%, complete remission with outpatient fractionated eyes. However, primary refractory patients, they are not doing very well, but somebody can tell me which chemo protocol is highly effective in primary refractory patient, which is known
to be very difficult to treat. The overall response rate in that population was 36%, but still we do see some patient who went in complete remission with 11%. The event-free survival rate was 14.5 months, and the overall survival rate was around 90 months. This is the outcome, primary refractory versus non-primary refractory in terms of overall survival. You can see that complete remission and partial remission patients, they are doing much better than those who reach stable disease. Included in here are also those patients who are not eligible for transplant and didn't go for transplant. And again, non-primary patients, non-primary refractory patients, they did a little bit or better in terms of long follow-up. They are doing clearly better than primary refractory patients. With regard to the IAs, 3 and more, hematological toxicity were documented in around 20% of the patients, neutropenia in 10% of the patient, thrombocytopenia 9% of the patient, febrile neutropenia 6%. This is all grade 3 and 4 IAs. There is some limitation here in documentation of the IAs. This is a retrospective data, and many of our patients who are not located nearby the hospital, it was very difficult to get lab tests for them. Therefore, I think the data of the safety has to be taken in caution, with caution. So my conclusion, our study included the largest number of patients treated with outpatient fractionated ice in the literature. We had 90 patients included in this trial. Outpatient fractionated ice regimen has favorable safety profile. The outpatient fractionated ice regimen is a reasonable replacement for classic ice if you decide to give your chemo, to give your patients chemotherapy rather than novel agents in Hodgkin lymphoma patients. However, patients with primary refractory lymphomas, they are not doing very well with the outpatient fractionated ice, which is reflecting the nature of the disease as well. With that, I would like to thank you, and I would like to invite you to our upcoming conference, the 7th Best Highlights of the ASH, which is going to take place in January in Jeddah. Thank you very much. I'm happy to take questions.
Thank you for Dada. It's very interesting talk and excellent results for the explanation. Of course, this has huge impact on the quality of life for these patients, and
Agree.
associated with availability of treatment and costs. There's any questions from the audience?
Thanks for a great talk. Having been a fellow at Sloan Kettering when Craig and Joe Bettina were doing all the ice studies, I've probably written hundreds of orders for ice. The dogma at the time, and it may not be right, was the ifosfamide was given as a continuous infusion to reduce the probability of encephalopathy. And so that's been a well-recognized feature of ifosfamide. So I'm wondering, in your change of the schedule and dosing of it, did encephalopathy pop up as an issue more frequently in this regimen than we've seen historically in the continuous infusion?
Yeah, exactly. That was our concern when we started to implement the regimen. Luckily, we did not observe any side effects as a neurological side effects among our patients. Thanks God. And all of the patients, when they come to our treatment area, they will be evaluated for that. Luckily, we didn't observe any side effects in this regard. And the number of patients is not small. We have around 90% treated accordingly.
That's great.
Thank you. Very interesting question.
Thank you, Dr. Dad. Excellent presentation. A question about the primary. I mean, I've seen the refractory. The percentage is higher compared to literature. So, I mean, we've seen like a 10 to 15% now. I think most of the 66% in this study are primary refractory. So, any explanation? And the other thing is about, are you changing this protocol for those patients, given the lower overall response rate? I mean,
Yes, yes, of course. Also, especially for Hodgkin lymphoma patient, we don't use in primary refractory now the outpatient fractionated ice, and this is the beauty of analyzing the own data. I think I can advise all of us to look to if you use certain approach, review it. You should have the time to review it, and I think you will learn from it. Of course, in classic Hodgkin lymphoma, who are primary refractory, we don't use the outpatient fractionated ice anymore. We're using the novel agent, brentuximab, with chemo. With regard to the second question is...
a higher percentage of the primary refractory in this study.
This is not the percentage of patients what we have. So this is not the percentage, just to avoid misunderstanding. Not 60% or 66% of our patients are primary refractory, but those who are included in the trial, as a 66%, 63%, they were primary refractory. So I must say that this regimen was used not only in our own patient, but those patients who we get from outside King Faisal Jeddah.
And the response was CT-based or PET-based?
The response at the first era was CT-PET, as many of our patient was CT guided as of 2015 until maybe 2018 CT, and thereafter later on we are using PET scan.
Just to clarify, the refractoriness is based on the ice response, or is it based on the primary disease prior to the
No. So when we speak about primary refractory patients, those who are primary refractory to initial treatment.
Yeah, so do you have a data on chemosensitivity to the ice? Because I was intrigued by the CR, patient who had CR,
Yeah.
and probably those who were chemosensitive, so it would be really interesting to see the chemosensitivity response.
We have the overall response rate, as you could see here. The overall response rate is around 50% in all patients. In patients who are non-primary refractory, it was higher, 63%.
Can I see the survival curve? My question is about the survival curve and the chemosensitivity. If you have this data, it would be interesting, because then you would analyze further.
Yeah, you can see here, patient who reach the patient who are sensitive to chemo, as a complete remission and partial remission, they are doing much better than those who have a stable disease. And this is reflecting, I think, the sensitivity to ice.
Sure. If you combine these two groups and look at the chemosensitivity with survival, you have this for the total group.
This is for the total group.
Yeah, no, primary refractory and non-refractory.
To merge them together. I think there is in the publication, there is one curve which I didn't include, but it's similar, not far. If you can see here, primary refractory and non-primary refractory, as after 60, until month 60 or 80 even, they are not far from each other. That's why the data are also not very bad.
Any further questions? Do you use for all your patients, or you have certain criteria to choose for the patient who's going to have outpatient?
At that time, we gave it to vast majority of our patients, I must say. Vast majority. It was born from the need of pets, honestly speaking, and not because we like the regimen.
There's elderly people and the side effects, delayed allergies.
Yeah. Yeah.
To have outpatient therapy.
Yes.
So you don't have certain criteria to give.
No, there is no certain criteria where we say this patient is fit in outpatient eyes. Of course, he has the normal evaluation of each physician for patients with to put him at risk of neutropenia. This is always was considered, of course.
No further question, we move to the
Thank you.
third talk. It's a great program. It gives you a great Professor of American Cancer Society Research, Professor of Medicine, University of Virginia, Comprehensive Cancer Center, Professor of Microbiology, Immunology, and Cancer Biology, University of Virginia. Prof. O'Connor his talk is about the novel treatment in T-cell lymphoma. Please, Prof. O'Connor.
Yes, this one is the laser and Thank you so much. This is the second or third time I've had the privilege of speaking to you from this very podium, and I thank the meeting organizers for yet another opportunity. So I'm going to talk to you a little bit about T-cell lymphoma, and some of what I'm going to say has the potential to be practice influencing. But a lot of what I'm going to say, I hope, is going to be more rethinking the paradigm and paradigm changing. Because we'll talk a little bit about the unfulfilled promise of chemotherapy in T-cell lymphoma, and I'm going to try and make the case that what we've been doing for the last 20, 25 years or so, being somewhat addicted to CHOP-based chemotherapy, may be somewhat flawed if we look at that historical record and the evidence in support of it. We'll talk a little bit about the drugs that we have at our disposal, but unfortunately, some of those drugs are under attack, at least in the United States, where romidepsin, widely regarded as a very good drug for the disease, was recently pulled from the market for patients with peripheral T-cell lymphoma, really diminishing what we have at our disposal for these patients. I'm going to talk a little bit more about novel combination platforms. That's the work that I do in my laboratory, and we translate that to the clinic. And I'm going to try and share with you that maybe how we think about this disease with regard to our addiction to chemotherapy versus our stimulating our innovative instincts to develop new regimens that are not necessarily predicated on chemotherapy may have its merits. And so I start with this famous paper from our good friend Rich Fisher and colleagues, published back in 1993. And you all know this paper because it's the paper that compared CHOP against other dose-intense regimens, MACOP-B and Embicod and Promacytobam. And the title of the manuscript, as you can see, is Advanced Aggressive Lymphoma, non-Hodgkin's lymphoma. In reality, this became the standard of care largely for all B-cell lymphomas and, by extension, T-cell lymphomas. And what you see from the paper is the well-known conclusion that everybody knows, that other dose-intense regimens were no better than standard CHOP-based chemotherapy. But I'll argue the point here that the classification scheme used back then for this study was actually the working formulation. And how many people, I'm just curious, besides all the old guys, how many people remember the working formulation? Could anybody here cite the working formulation?
Only you.
Only me, that's right, because I'm one of the oldest. And so that's probably almost right. And the working formulation back then used this classification of thinking about the clinical behavior of lymphoma, low grade, intermediate grade, and high grade. Now I'm going to ask another question. How many people, and you've all read this paper, I'm sure Mubarak had you read this paper 100 times in various settings as fellows. How many of you actually knew that the national high priority study that established CHOP as a standard of care used the working formulation? And the working formulation had its limitations, and if you look back at the paper, you see patients with all these different subtypes of lymphoma were classified as aggressive. So they were included in the study. And that would include today people that had Burkitt's, aggressive mantle cell, transformed lymphoma, large cell lymphoma, and peripheral T-cell lymphoma. And I beg the question, where's T-cell lymphoma? I've read this paper at least 25 times. I cannot find the word T in the paper except in the use of the word the. That's it. There is no discussion of peripheral T-cell lymphoma. But for some reason, we as a community said, this is our standard of care. And I'll challenge anybody to say, is it possible that a methotrexate-containing regimen isn't better in this setting? It's possible. And I will argue that we've spent a lot of time, 20 years, taking CHOP-based chemotherapy and using it in T-cell lymphoma, and then we argue chemo's not very good. I'll argue maybe chemo has some value, but maybe we're not using the right one. And the greatest innovation we've been able to muster in this disease for 20 years has been to add drugs to CHOP-based chemotherapy. And I'll talk about two, brentuximab and romidepsin. Arguably, the two best drugs people think of when they think about T-cell lymphoma. And we've taken this historical paradigm and just added new drugs to CHOP, thinking, oh, let me add one good drug to 4 bad ones and I'm going to make a great 5-drug regimen. So that's what we've been doing. So when you say it like that, everybody scratches their head. And in fact, Echelon 2, which uses brentuximab, we heard a little bit about brentuximab, and in this particular case, brentuximab, you know, was studied in patients with peripheral T-cell lymphoma. But in Echelon 2, more than 2/3 of the population actually had anaplastic large cell lymphoma. Happens to be the subtype that is known for CD30 expression and the highest single-agent response rate to brentuximab. And the company notes that that was done to satisfy the European regulatory agencies. And in that study, there was clearly an advantage on the entire population for those that got brentuximab. But what's clear is if you look at this data and you look at the breakdown, and this has been one of the things that has come out really interestingly, is that when you look at all the other PTCL that are not anaplastic large cell lymphoma, only anaplastic large cell lymphoma benefited. Patients with other peripheral T-cell lymphomas did not benefit from Echelon 2-based therapy, did not. Now we know that the expression of CD30 in the non-anaplastic large cell lymphomas is much more diverse. So the trial had a requirement that you had at least 10% expression of CD30. When the FDA saw the data, the US FDA said, well, it's pretty hard to quantitate CD30, so as long as you're CD30 positive, irrespective of quantity, they'll approve the study. So Echelon 2 is approved for all patients with PTCL, even though the statistical benefit of the regimen is in patients with only anaplastic large cell lymphoma. And so for those who like to challenge me and say, well, you know, Owen, chemotherapy isn't all that bad in T-cell lymphoma. Well, I like to point to this great data from the British Columbia Cancer Agency up in Vancouver. And what they did is they went back and they looked at all patients with T-cell lymphoma and asked the question, what is your second progression-free survival and your second overall survival? You know that if you have relapsed anything, your prognosis is better in first relapse than it is in third or fourth, right? So this would be the best outcome you could possibly expect for any patient with relapsed lymphoma because they're looking at you in your first relapse, not your third or fourth or fifth, which is where we study all these drugs. And so in fact, the second progression-free survival is 3.7 months. The overall survival from your first relapse, 6 months. This now makes T-cell lymphoma worse than acute myeloid leukemia. It's amazing. And in this setting here, what are we using to try to salvage these patients in relapse? It's chemotherapy. It's all chemotherapy. So if chemotherapy is so great, then why is these data so bad? And in fact, if I sort of look at the evolution of what we've been trying to do in T-cell lymphoma over 2 decades, we got the famous Fisher paper. You see a cluster of studies where a lot of people said, oh, let's add Campath, let's add Verinostat, let's add Denileukin-Difitok, let's add everolimus to CHOP chemotherapy. All of these studies, negative studies. And in fact, arguably the 2 best drugs we have in the disease, brentuximab and romidepsin, also negative studies, except in the case of Echelon 2 in ALCL. So our evolution in terms of what we're doing in T-cell lymphoma, we're not evolving. We're in stagnation. And so I'll argue that this line is somewhat contrived. I drew this line. It's got more of a slope than I think it actually deserves. And look at the ROCHOP data. Everybody, I was involved in this study from the moment it became an idea. I was involved in romidepsin when it was still FK whatever. And here's the romidepsin study. God rest his soul, Bertrand Coiffier spent 3 years of his life doing the phase 1 for the ROCHOP study. 3 years. I was at meeting after meeting after meeting where he said, we don't have the final dose yet. It's very toxic adding another drug. But what oncologist in this room doesn't know that adding a 5th drug to a 4-drug regimen is a problem because you're going to get toxicity. And in fact, they did it, no difference, none whatsoever in adding romidepsin. So if we take our 2 very best drugs, brentuximab and romidepsin, and we add them to CHOP-based chemotherapy and they both fail, should we be rethinking the paradigm? And I'll argue we need to rethink the paradigm. And you know, we're so stuck in our ways. Guess what the follow-on study is for this? Anybody know? The sixth drug, exactly. CHOEP. They want to add romidepsin to CHOEP. Oh, because we forgot the etoposide. That's why it didn't work, right? That's how creative we're getting in the field. And I'll argue we have to change ways. And this would be how I think about the field today. We've done this for a long time, right? It has a lot of advantages. It can be fast and patients get a known regimen, but there's a lot of disadvantages. The logic of adding one drug to 4, one drug to 5, I don't know. I don't know what it is. It's often very toxic, and we've had two decades of negative studies. But if we think about using some of the novel drugs that we have, and every time I give this talk, somebody always says, well, we need new drugs in T-cell lymphoma. Yes, we need new drugs for every disease we're fighting. But there may be advantages here because a lot of the new drugs we'll talk about are lineage specific. They only work. Pralatrexate, romidepsin, brentuximab, belinostat, chitomide. They only work in T-cell lymphoma. And I'll argue, you know what? We got some good drugs at our disposal. We're just not using them very well. And so there are some advantages. Those drugs may respect biology. They build on positive findings. There's some disadvantages because we're kind of starting from the beginning. But what I want to talk about is this as a potential paradigm-changing opportunity for us in T-cell lymphoma, and to try to resist the seduction that comes with just adding yet a 4th or 5th drug to a regimen we don't think works real well. And so this is just our effort from a paper that Dr. Markey and I published years ago, and admittedly, there are no home runs here. We got drugs, but there's nothing that's like knocking us out of the park. These are FDA registration studies with Romi, Belino, Prala. They're 30%, 25, 30% drugs. And so yes, we need new drugs, but if you look at what our friends in multiple myeloma have done, they've totally changed the paradigm. Gone are the days of melphalan, in are the days of proteasome inhibitors and IMiDs and daratumumab, right? They've taken the new drugs they had. Steroid, for God's sake, was the most active drug they had. They've changed the natural history of the disease by using what they've got. And in fact, when we start looking at combinations of these drugs, look what happens. We've taken Aza-Romi, my group, and Prala-Romi, based all on lab work. I'm not going to go into too much lab work, showing you 80, 90%. Somebody said we couldn't cure T-cell lymphoma without chemotherapy. I agree. But maybe we can cure them with these drugs. I've treated a lot of patients with Aza-Romi. I have 5 patients with angioimmunoblastic T-cell lymphoma that got azacitidine romidepsin in their 5th year after failing everything under the sun, disease-free. Are they cured? I resist using the word, but it's certainly suggestive. And so I think there may be settings here where we can build on what we've got to try to create something better. And in fact, where I like to always start in thinking about how to develop a new drug regimen for a disease is with biology. Because if we're just picking chemotherapy out of the air and throwing it against the wall, we're just hoping for something good to happen with something that's potentially noxious. How do we target underlying biology? So the classifications, and many of you have seen this from Iqbal, the gene expression array can help us in classification. But what's the problem with this gene expression array data to date? The problem is it has not given us any hard clues about biology to go after. I can make the case pretty reasonably. The biology at play that we need to target in T-cell lymphomas is epigenetic biology. Unfortunately, epigenetic biology doesn't pop up in any gene expression array. And so how do we now merge our understandings of the molecular biology via gene expression array with other complex pieces of biology like understanding the epigenome? So my lab years ago, we do a lot of high throughput chemical screening and high throughput genomic screening. And we asked the question back then, show me all the drugs on the planet that synergize with romidepsin. And remarkably, guess what 2 drugs popped up? We screened thousands of drugs, pralatrexate and azacitidine. So you might look back and say, well, Owen, you didn't need to spend $50,000 doing high throughput chemical screening. I could have told you those 2 drugs would work. Well, we did it in an agnostic way, asking the question. Let the data drive us what we do. And in fact, here's the data we did with Prala, and I won't go through all the detail, but this is looking at Prala plus Romi at half the maximum tolerated dose. And herein lies a value of what I'm talking about. If we identify synergistic drug-drug combinations, what is the clinical benefit of synergy? I get to use the IC10 or the IC20 of a drug in combination, but be able to magnify the response rate. In theory, rather than adding a fourth or fifth or sixth drug to CHOP at the maximum tolerating dose and then discovering, oops, I get a lot of toxicity. What if I took a pharmacologic principle like synergy and said, well, let me use drugs potently synergistic, so this way I get to use lower concentrations of them, avoid the toxicity seen in combination while magnifying the benefit. That's the platform. And lo and behold, that's exactly what happened. MTD of Romi, MTD of Prala, the combination produces a survival advantage. We take it to the clinic. And when we did the synergy analysis, guess what? We only did it in T-cell lymphoma. I was not interested in developing a drug regimen for large cell or follicular. So we only did it in T-cell lymphoma, and we asked the question, show me the combinations only synergistic in T-cell. And so that's exactly what we got. The overall response rate, 57%. In B-cell lymphoma, 30%. In T-cell lymphoma, 70%. So from the very beginning, from its inception, we wanted to start out finding drugs active in T-cells, set the platform, and in fact, that's what we did. Now, the other combination we looked at, azacitidine. There's a lot of preclinical data, and I'm happy to answer questions. But we did the exact same thing with azacitidine. And some of you are thinking, that's not so clever, Owen. They're both epigenetic drugs. You made the case it's an epigenetic disease. Yes, but it's good to have the data. But look at this. A response rate in T-cell lymphoma, 73%, B-cell lymphoma, 10%. Has anybody ever seen a drug regimen have a better response rate in T-cell lymphoma than B-cell lymphoma? This is the first, right? This is very, very unusual. And in fact, this is experience from the phase 1. And in the phase 2, we treated patients who were treatment naive. I won't have time to go into the data, but we did study, and there's a very good paper from Dr. Ma from my group, where she did a historical retrospective survey of over 250 patients we treated with T-cell lymphoma with chemo and new drugs. And she asked the question, show me, and I say this because of the great transplant talk that we heard a few moments ago. We said, ICE, I'm not so impressed with ICE and T-cell lymphoma. In fact, all the data says it ain't so great. So she compared 10 patients we had with that got AZA and Prala-Romi prior to auto stem cell transplant with like 40 or 50 patients that got standard ICE chemotherapy. Of the 10 patients that got Prala-Romi or AZA-Romi prior to auto versus the 50 that got ICE, 30% or 25% of the patients that got ICE were alive at 2 years. 100% of the patients that got AZA-Romi or Prala-Romi were alive at 5 years. Does that suggest that maybe we should be rethinking this paradigm? And rather than pushing the chemotherapy option, begin to get creative and ask, well, what happens if we treat treatment-naive patients? 70%. So we see pretty good response rates. What's real interesting is this real high signal of activity in the T follicular helper lymphomas like angioimmunoblastic and TFH. And there's a real reason to think why these could be sensitive, but this continues to emerge as a subtype that's very sensitive to the combination. And in fact, this just shares the swimmer's plot. You can see some pretty long responses. We got a bunch of patients out 5 years following this regimen, and a very favorable waterfall plot with a lot of patients in CR. But this is the curve I love to show the most. Because has anybody seen a curve where the progression-free survival with any regimen in T-cell lymphoma is better than the progression-free survival in B-cell? And in fact, we haven't. And so this is the progression-free survival for T-cell lymphoma. It's about 9 to 10 months versus B-cell lymphoma. And one of the great limitations of developing drugs in T-cell lymphoma has always been the progression-free survival of Prala, Belino, Romi, Chitamide, and brentuximab is only like 2 months, 3 months. That's like the progression-free survival I just showed you from the paper from Mac, which was 3 months. One could reasonably argue we're not doing anything to improve the progression-free survival of these patients. And so changing the natural history of the disease by changing this progression-free survival interval, I think is key. And it's something we need to evaluate prospectively. Look at the overall survival curve here for patients that were treated on the phase 1. And again, this is the same story from the phase 2, reinforcing everything else I just showed you. And so this data has been received well by the US FDA. They've actually asked us to do a randomized study, so we got a huge grant from the FDA where we're doing a randomized study of azacitidine using oral plus Romi versus investigator's choice. This study is now ongoing, and if positive, could begin to pave the way for how we think about developing new combinations. And we've already built on this. Dr. Markey will be presenting at ASH the patients with oral aza, romidepsin, and pralaromi getting checkpoint blockade, pembrolizumab. And in that study, there's a real logic to add checkpoint inhibitors, and in those studies, the response rates are pushing 100%. So what else is on the horizon in T-cell? And I have to tell you, the horizon looks pretty blurry to me, but there's not a lot of new drugs out there. But there is one, and I want to use this as an example to underscore the point I just made about combinations. This is a drug called talinipant. It's been studied in PTCL and CTCL, as I'll show you. It's a very interesting drug. It started out as an inhibitor of apoptosis, a CIAP inhibitor. But it turns out it has lots of immunologic effects inducing immune response against the tumor. The biology is fascinating, the pharmacology super complex. But Dr. Zanzani and colleagues presented an update on talinipant. We were very much involved in this study, looking at it in patients with PTCL and CTCL. And this is really your classic single agent drug, another new drug in T-cell lymphoma, looking like all the others, right? You look at this and you say, oh hum, right? It's got a response rate of maybe 20 to 25%. Here's the swimmer's plot. Okay, oh, and it looks just like a lot of the other drugs. And this drug is promising because I've treated patients with PTCL that are in remission 3-4 years later on this drug. So there are these really phenomenal responders, but it's certainly not everybody. So in the laboratory, what did we do? We screened talinipant against all our different cell lines and found some cell lines are incredibly resistant, T-cell lymphoma. Some cell lines are very, very sensitive. And then we asked that question I shared with you before. Show me drugs that synergize with talinipant in T-cell lymphoma. And what popped up? What popped up was decitabine and azacitidine. Now, for some reason, I think there's an emerging theme here. You know, the French studied azacitidine. They're going to report data at ASH that's only so-so on the single agent. But the synergy that we've seen with talinipant and decitabine is off the roof. It's off the roof. And it turns out that there's an oncogene, we're going to call it, it's called RIP kinase 3. And RIP kinase 3 plays a very important role in governing the sensitivity to talinipant. So if I go back and I take these resistant cell lines and I incubate them with talinipant and decitabine, they're all now super sensitive. Because it turns out RIP kinase gets hypermethylated. And by using a hypomethylating agent, I now can render all these T-cell lymphomas super sensitive to the drug by looking at the combination. And so now we're about to begin a national study looking at the combination of talinipant with hypomethylating agents. And for me, it simply makes the case, we gotta stop thinking about adding stuff to chemotherapy. People are adding all sorts of things to ICE and T-cell lymphoma, but we should be thinking about how do we replenish the drugs that are getting pulled from the market underneath our noses? And how do we think about these clues coming along, like talinipant? How do we make them better, like our friends in multiple myeloma have done? And this is the unfortunate history of romidepsin, a pretty good drug. 25% of people respond, but if you respond, your response can last way over a year. That makes it a pretty interesting drug. But because of that phase 4 study that I showed you where they added romidepsin to CHOP and it was negative, the FDA says, no, you're no good, off you go. And what's the problem? The problem is my colleagues said that was the best study to do to show unequivocally the benefit of romidepsin. And I was at all those meetings saying, no, I wouldn't do that. I would get creative. But we did it. And guess what happened? The FDA said, that was your choice. You did it. Now you pay the price. And the price is the price the patients will pay because now we don't have the drug. And so in my lab, I'm a chemist by training. And so I love chemistry. And wherever I could talk about chemistry, I like to. We went back and we said, well, the heck with this. We're going to go back and we're going to create a new portfolio of drugs in T-cell lymphoma. We're going to start with romidepsin because almost every drug I combine with romidepsin in T-cell lymphoma, I get profound synergy. So we made a nanotherapeutic polymer of romidepsin. And this is all the data. It's as good or way better than what we see with naked romidepsin. And instead of giving romidepsin, how many people here have given romidepsin? Is it approved here? You don't have it? So it's a very popular drug in the United States and Europe. It's a 4-hour infusion once a week for 3 weeks in a row. And it has got its issues with the infusion. These kinds of formulations of the drug, we can give over 30 minutes once a month or so. So we're now using these polymers and embedding in these polymers. We're putting all sorts of other drugs like azacitidine, like tolinapant, like other drugs. And so within these complex chemical nanoparticles, I can create new combinatorial therapies that we're starting to create now for patients with T-cell lymphoma. And so that's just a flavor of what I think is coming and how I think we should be thinking about it. So the evidence regarding the merits of CHOP or CHOEP plus studies, for me, continues to be pretty disappointing. The vast diversity of these diseases, it's been hard to identify common pathogenetic themes, like what's the gene or biology we should go after. I think the epigenome between the data with hypomethylating agents and HDAC inhibitors is certainly rising to the top. All these single new agents, and you know them, duvelisib, the JAK6 inhibitor, EZH2, they're all identical. None of them are home runs, none of them. And in fact, the PI3 inhibitors are getting killed by the FDA these days. And so how do we leverage these suboptimal drugs? Because if we're all sitting at home waiting for Owen or Mubarak to generate that next 90% single agent drug, you may be sitting at home for a long time. And so I think we got to take the clues we have regarding these drugs that work and think about how we might leverage them to be better. Combinations, in my mind, are the way, and novel combination trying to circumnavigate a lot of what we're doing with CHOP. And here's just a simple mathematical calculation. Here are all the classes of drugs I've identified as active. ADCs, hypomethylating, HDAC, EZH2, PRALA, PI3, checkpoint. All of these drugs by themselves are like 30% drugs. And if we start thinking about all the ways we combine doublets or triplets or quadruplets, rather than thinking about, what study can I do as a young investigator? Can I do something and add it to ICE and add this drug to CHOP and add this drug to GDP? I would say, sure, you can do that. But the opportunities here, I think, are much greater. And if we can understand these things biologically and look at the evidence for combining them, I think the combinatorial aspects with new drug combinations far exceeds anything you can envision with combination therapy. So I work with a remarkable team now down at the University of Virginia in Charlottesville, where Tom Loughran is the guy that discovered LGL at the Hutch. This is an amazing team with chemists and biologists, and my team funded extremely well from the NIH and American Cancer Society, FDA. We just got a $6 million grant to create an orphan blood cancer research program, which is now underway, and that's what's funding a lot of the new drugs that I'm telling you about. So I think the future is bright with collaborations like this, and if you've liked anything I've had to say, you can join us at the T-Cell Forum in beautiful La Jolla. We had the pleasure of having Mubarak there last year, where he gave a great presentation. And if you have an abstract or something to say, personally send me an email with what you'd like to talk about, and I will do my best to get you an opportunity to share that data with this international forum. So with that, thank you so much. Did I go over?
No,
Good.
Many thanks for this fascinating talk and these difficult disease to treat. Any questions from the audience about Oscar?
Well, brilliant talk, Owen, as usual, and very, inspirational in terms of, innovative and exploring those options. And I just, to start with, I would just, make a request. And that will be further discussion, and we'll discuss it further. And we wanted to be part of these activities and part of the studies, including the phase 1 and phase 2. And something we discuss later and with the group, I guess.
Yeah. Absolutely. So we have started a group here, and we're now trying to create, I was just telling Mubarak this morning, a small company to try and develop these drugs and get the money to fund that company. And we have as an ambition because, believe it or not, pralatrexate was just approved in China last January. I think romidepsin was never approved in China. And so my really big concern is that the companies that have these drugs, and because these drugs are an orphan diseases where they don't make a lot of money, they make strategic decisions. Well, I'm not going to go to China, or I'm not going to go to Saudi Arabia, or I'm not going to go to South America, because it costs money to do these things. And I think what we need to do is create international groups. We're trying to do that. And we need to get investment dollars behind companies that can actually say, sure, we want to do this. We're going to make this a priority. Because I would argue that if we can be successful as an international global community getting drugs approved, and the studies that I do in the US are pretty rigorous. And for EMA, they're pretty rigorous. So, and I spend a lot of time talking to regulatory agencies all over the world. And I couldn't agree with you more. If we can get on the same page as a global community, think how fast we can do these studies, right? Romidepsin had 25 years before it got pulled as a drug that the FDA said doesn't work. What if we can make these decisions in 2 to 3 years and do all those combinatorial things plus whatever's on the horizon? I think then we can make a real dent in the disease.
Absolutely. And I would add to that, it would be cheaper.
Yes,
Regardless.
that's right.
No need to do it here compared to other.
And if you had the global rights to the company, if your company had global rights or partnered with other companies around the world, I would argue that that's a reasonable revenue to be able to fund the mission, and I think that's important.
Another question, so is this hydrogen, does it come with surprises to be working in T-cell? Given, the history and what we know about high-dose RSC and its effect on the T-cell
Yeah.
lymphoma in general, where is the high-dose RSC as well in cooperation into this as well?
Yeah, we've not really looked at high-dose Aracy with regard to the hypomethylating agents. You're right. It's not intuitively obvious that drugs like decitabine or azacitidine should have single-agent activity. Many of you may remember a few years ago the study from the French group where they published this data showing higher response rate in angioimmunoblastic T-cell lymphoma. It turns out that was a blip. It's not going to turn out as a single agent to be all that great. They just finished a randomized study. But what we have found in the lab that is very, very interesting to me is across the T-cell lymphomas, we see remarkable patterns of synergy with drugs that have T-cell lineage selective activity, so prala, romi, tolinapant. And that level of synergy is profoundly greater in the T follicular helper lymphomas. So we finally reached a point where I think we should be doing the next trial in a subgroup specific or subgroup defined set of PTCL. Normally my position would be do all PTCL, but if you have a signal that's now turning out to be as robust as this in just AITL or TFH, I would say go for it. Because even if we can improve that subset, that represents the majority of patients with T-cell lymphoma. So I wouldn't want to encumber the regimen's future by tacking it across all lymphomas, but go after those where we see the signal now, and I think we're almost there where that's happening. And certainly that's there with the tolinapant story and by adding checkpoint blockade.
Can you elaborate more on the concept of combining hypomethylating agents? You kind of alluded to it in the presentation.
Yeah.
Would adding a third hypomethylating agent making it even better?
So exactly right. So I don't think adding a third. So we do a lot of work on high throughput genomics to try to understand what's the contribution of one drug in the regimen, right? So there's no great additional contribution of adding another hypomethylating agent. So one of the things we see is in these regimens, I didn't show too much laboratory data, when we add hypomethylating agents and HDAC inhibitors, the genes that get enriched are genes around immunomodulation. So we see an explosion of cancer testis antigens on the surface, and we see a gamma interferon signature pop up, which is a good thing. And all of the Th2 type lymphocytes, which we know is a bad prognosis in T cell, get shifted to Th1. So So what we've begun to do is use that data to say what logic does that create to add next agents to it. And the first logic is checkpoint blockade. And so that's what we're starting to do, is add checkpoint. The third thing we're doing is adding another epigenetic drug, which is the EZH2 inhibitor. So the EZH2 inhibitor, tazemetostat, people you know, and they're being developed. There's a company in Japan developing one. They have pretty good 30% type response rate in T-cell lymphoma. When these things get started, everybody's, cheering and wow, this is it, this is the breakthrough. It's not the breakthrough, but it's a good drug that targets biology. Now, we don't know much about EZH2 mutations in T-cell, like we do in follicular, but our strategy is now to do exactly what you just said. We do the screens. We're going to take these doublets, Romi-Aza, Romi-decitabine, Telinapanticitabine, Romi-Prala, and then ask, what's the third drug that complements that regimen or that combination? And then rationally build on it by getting the data. So we're interested in doing that. We think that by adding checkpoint blockade to any of these doublets, that we have a regimen we could take to the front line. That's an idea. I just was in a meeting in Rome with Dr. Zinzani, the father of gemcitabine and T-cell and other things. And I asked him, I said, if I'm developing all these regimens and somebody says, Owen, what chemo would you add to your novel combinations? And I asked him, is there a chemo you would add? Thinking he might say, of course, gemcitabine. He said, no. I would stay away from chemo I would not add chemo to these novel combinations. I would continue to play with the biology. And the next step, I think, is to play with the immunobiology, right? What are the antibodies? What about adding brentuximab? What about adding pembrolizumab? What about adding a novel NKT engager? So I think that's how I would think about it, rather than adding more small molecules, because Coiffier taught us, add more drugs to more drugs, you get more toxicity. So the biologics, it seemed, we can add with near impunity. So if I take these regimens that are very well tolerated and begin adding biologics, maybe we change that paradigm a little bit more and create 4 drug regimens that can go on and challenge CHOP. So that's the idea.
Dr. Khan, thank you so much for a very fantastic presentation.
I see you. I'm half blind, but I can still see you.
So I have 2 questions. The first question is about the safety of PD-1 inhibitors in T-cell lymphoma. You mentioned that 3 combination, including PD-1 inhibitor. I'm not sure if some studies were terminated because of disease progression, except in NK cell, other type of lymphoma. There was an issue of disease progression. This is a question number 1.
Should I address that first? So the hyperproliferative response, which was described in HTLV1-ATLL, a virally mediated disease, and Nora Benani from the Mayo Clinic had a case report or something that she published in New England Journal. So this has been, we have this topic come up at the T-cell forum all the time. And I have to say my impression is, yes, we have seen this event. Although I have to say the cases I saw from Dr. Benani at Mayo Clinic, I wasn't convinced that it was all due to the PD-1. I think it was just bad T-cell lymphoma that was resistant to growing out. The cases where I do believe it's a real thing is in HTLV1-ATLL, where the hyperproliferative response has been seen. That was published also in New England Journal of Medicine on 2 cases. So in our experience, where we've added now PD-1 to the hypomethylating combination, we've treated maybe 18 patients. We've not seen anything like that. So the theory that we would invoke to explain why we wouldn't see it is that when you're using, and I think this is the caution we need to think about, when you're using these drugs as single agents, they're different drugs. When you're using these drugs in combination, they're different drugs. And I would argue that using a combination like Prala-Romi, Aza-Romi, whatever, where you're getting very rapid cell kill, and now you're trying to use the PD-1 to come in and stimulate the immune system to clean up what's there, we're superimposing a strong apoptotic influence on those cells such that whatever the mechanism of the PD-1 that was driving the hyperproliferative response gets mitigated. And so I would be surprised if we see it, even in ATLL, which we haven't treated in ATLL yet, but I would be cautious that what you observe with a drug like that as a single agent may or may not be true when you study it in combination.
So the second question, what's the duration of therapy for Aza-Romi?
Another great question. So in all our studies, we have kept patients on, and usually for a minimum of 2 years. And so some patients have come off earlier. Some patients have wanted to stay on longer, but we didn't know, so we just stopped it at 2 years. If you look at a lot of this data, it's all over the map in terms of how long people are on. But the longest we've treated people is up to 2 years. Some of those patients that survived, and I have one guy from Chicago, came to me after he got chemo and all that stuff, had angioimmunoblastic T-cell lymphoma in his liver, got this regimen for 2 years. He was flying into New York to get this regimen. And not everybody can do that. And he got into a complete remission at 4 or 6 months. And then at 2 years, he's back. He says, I love you, but I want to stop seeing you like this. And so I said, all right, you've met 2 years. I said, I don't know what's going to happen, but let's stop. And I email him periodically, and he's in remission 4 or 5 years later. So that's really what you just asked is very important, is how long do we give these therapies? And the answer is I don't know. I'm trying to work with people like Ahern and the folks in Japan to try to look at minimal residual disease and look at liquid blood biopsies to see if we can use that as an endpoint. But that's a very interesting question. I would be cautious with 2 drugs. Maybe when we get to 3 and 4, we'll have a better idea. But that's an unknown.
Last question.
Thank you very much, Professor, for this intriguing talk. I was really glad to see genetics, epigenetics, and molecular biology of the disease in your talk. I'm a scientist, I'm not a physician, so that was really nice to see. My question is, did you look at Notch signaling in T-cell lymphoma? We know that Notch1 is mutated in more than 50% of TLL, and also it's a poor prognostic marker in T-cell lymphoma.
Yeah.
So did you look at the clinical pathology link with Notch and T-cell lymphoma?
Yeah. So I had the pleasure of working with my good friend Adolfo Ferrando, who worked in cloning Notch. So it's kind of hard to have him as a friend and not look at Notch. So yeah, we've looked at broad genetic analyses, and we've not seen any correlation with anything that would portend response. So Notch was on the list, but it didn't pop up as something that was predictive of response or prognosis. What did pop up when we did those analyses turned out to be not just mutations in TET or IDH or DNMT, but it turned out to be global mutations across the epigenome. So if you met whatever the statistician defined as the term for having, we looked at maybe 25, 30 epigenetic genes. And it was actually mutations across any grouping of those epigenetic genes that would render you more likely to respond to the regimen. So I think, a lot of people keep asking me questions like this, right? Oh, did you look at the TET2 population? Because TET2 is so important. Yeah, TET2 never pans out. IDH never pans out. DNMT3 never pans out. But it turns out that if you look at all of those epigenetic genes in their totality, there's a signal that does pan out. And so again, I go to the same issue, right? What you see with pembrolizumab in T-cell lymphoma may not be what you see with pembrolizumab in combination. What you see with TET2, Teresa Palomero showed, TET2 will cause T-cell lymphoma in these models, angioimmunoblastic. But I think we got to start opening our view of what's happening, and it's not a singular gene, it's a network of genes. And I think in this case, nobody's really ever looked at the repertoire of epigenetic genes and correlated it. We did that in the blood paper, and I think that's what we're going to use going forward. I think you're going to have to look at repertoires of genes that fall into certain categories that are influenceable by the drugs that you're giving them. Every answer just gets more questions. That means I'm not being too clear.
We'll have 30-minute break before we start the second session. Very thankful. Thank you.
I could stay here all week, so don't worry.
For your experience was very excellent about the BDI positive.
The which one?
BDI receptor positive, whether they more response to BDI initiating management who have negative or very negative treatment. And the same question for the patients who have CD8 positive, whether they respond more than to infliximab, we don't
Yeah.
have CD8. So what was the impact for
No correlation. No correlation with CD30 expression and response. None. And I can explain why. That's right. Yeah.
mostly local experience about treatment of disease and use of certain mobilizing agents. So the first talk is going to be about the local experience in managing lymphoma and myeloma from Prince Mohammed bin Nasser Hospital in Jizan. The presenter is Dr. Fahad Bahkali, who is a consultant hematologist at Prince Mohammed bin Nasser Hospital in Jizan. So Dr. Fahad, please.
Assalamu alaikum. Thank you for this nice introduction about me. And actually, I'm very happy to be today to be with you and to give me the chance to present the local experience of managing lymphoma and myeloma at Prince Mohammed bin Nasser Hospital, Jizan. This is an introduction. As you know, Jizan is located at the south region of the kingdom with more than 2 million citizens and only one hematology oncology center in the city, which is Prince Mohammed bin Nasser Hospital. Previously, patients used to travel outside the city to be treated in the higher centers. We started to treat few number of oncology patients in the beginning, and with time we gained more trust from the patients in our center, and most importantly, we trusted in ourselves to treat those patients. Nowadays, most of the patients with malignant diseases are treated locally. Upfront referral is uncommon. The total number of patients that I'm presenting today is 183 patients, including Hodgkin lymphoma, diffuse large B-cell lymphoma, and multiple myeloma. I believe that the number of patients that we managed and treated in Jizan is much higher, but due to the lack of documentations, and unfortunately some files are missing at the time of this data collections. Starting with lymphoma, this is what we did for newly diagnosed patient with lymphoma. We do the basic labs, as all of you know, and we do bone marrow aspiration and biopsy for all patients to be reviewed locally. And we do echo and band CT for staging. Now for selected patient, we do CMYC by FISH, plus minus FISH, for BCL2 and BCL6, especially if high CMYC expression by immune histochemistry. And for some patients, we do PET CT scan before starting chemotherapy. And sometimes we do BFT, and also sometimes we send the slide and blocks for second opinion if the diagnosis is not confirmed. For the follow-up for lymphoma patients at the time of treatment and shortly after treatment for diffuse large B-cell lymphoma, we do interim PET scan after 2 cycles if we plan for 4 cycles of chemotherapy, and we do after 4 cycles if we plan for 6 cycles. And definitely, also we should do at the end of therapy a PET scan for assessment. For Hodgkin lymphoma, we do interim PET scan after cycle 2B, and if the patient in molecular remission, then the next PET scan will be at the end of therapy. Otherwise, a repeated PET scan should be done after cycle 4B for assessment. For any lymphoma patient who need radiation therapy or BMT, we send them outside the city for higher centers. And very important point to highlight is that all our lymphoma patients diagnosed after Feb 2022, we give them 2 doses of EvoShield as a COVID-19 prophylaxis. The medications available for lymphoma at Prince Mohammed bin Nasser Hospital include chemotherapy, anti-CD20 monoclonal antibody, anti-CD30, PD-L1 inhibitors, immune-modulating therapy like lenalidomide. We do have also BTK inhibitors and BCL2 inhibitors, venetoclax. The number of patients that I will present today for Hodgkin lymphoma diagnosed and managed from 2015 to 2022 include 63 patients. This is like a summary of how we are treating classic Hodgkin lymphoma at Prince Mohammed bin Nasser Hospital. We divided the patient into limited stage and advanced stage. For limited stage favorable, we give 2 cycles of ABVD plus radiation therapy or 4 cycles of ABVD. We give chemotherapy alone for female and age less than 30. For limited stage unfavorable, we give 4 cycles of ABVD plus radiation therapy or 6 cycles of ABVD. And again, we give chemotherapy alone for female and age less than 30. Any patient with limited stage, either favorable or unfavorable, who is fit to go and to be treated based on the Rathel study, we treated them based on the Rathel study. For advanced stage, we treat the patient based on the Rathel study followed by radiation therapy to the bulky site. For nodular lymphocyte predominant Hodgkin lymphoma, if the lesion was totally removed at the time of diagnostic investigation, we just observe the patient. Otherwise, we give radiation therapy to patient with limited stage, and we give chemotherapy to patient with advanced stage. This is the sex and age distribution for patient with Hodgkin lymphoma. As you can see in the right side, female 40% and male 60%. And most of our patients, almost 80% of them under the age of 40 at the time of diagnosis as Hodgkin lymphoma. 87% of the patient has classic Hodgkin lymphoma, and 12% of the patient had nodular lymphocyte predominant Hodgkin lymphoma. And for the histological subtype of classic Hodgkin lymphoma, the most common is nodular sclerosis, followed by mixed cellularity type. Almost 50% of the patient, they have a limited stage disease, and 50% of the patient, they have advanced stage disease. The most common chemotherapy given for our patient was ABVD in 82% of the patient. And the second most type of chemotherapy is ABVD plus rituximab. We are giving ABVD plus rituximab for patients with nodular lymphocyte predominant Hodgkin lymphoma with advanced stage disease who need a chemotherapy. But also we do give some patients with classic Hodgkin lymphoma with CD20 positive. Sometimes we are giving them ABVD plus rituximab. This is the response after first-line chemotherapy. At the time of this data analysis, 60% of the patients, they achieve complete remission, and we have another 10% still on active therapy. We have collectively almost 20% of the patient, they achieve only partial remission, or they are refractory to the first-line therapy, or they relapse after achieving the complete remission. And this is for the number of patients that, as I mentioned, they achieve only partial remission or relapse or refractory. Some of them, we send them for radiation therapy, and some of them to higher center for salvage, followed by autologous stem cell transplant. And the percentage of patients among them is 20% who is successfully salvaged and given autologous stem cell transplant. At the time of this data analysis, 80% of the patients with Hodgkin lymphoma is still alive, 80% is still alive, 10% died, and 11% lost follow-up. The estimate overall survival is 63.1 months. The second part of this presentation will be about the high-grade non-Hodgkin lymphoma in Prince Mohammed bin Nasser Hospital, diagnosed and managed between 2015 and 2022. Total number of patients, 78 patients. And this is again how we treat diffuse large B-cell lymphoma at Prince Mohammed bin Nasser Hospital. For patients with age-adjusted IBI of 0, we give them 4 cycles of SHOP plus rituximab, followed by 2 cycles of rituximab based on the FLIER study. For patients with limited stage non-bulky and non-fit for FLIER study, we give them SHOP, rituximab for 3 cycles, followed by radiation therapy, or we give SHOP, rituximab for 6 cycles. Any patient with limited stage bulky or advanced stage, we give them SHOP, rituximab for 6 cycles, plus minus radiation therapy to the initial bulky site. The sex distribution of the patient with high-grade lymphoma, high-grade non-Hodgkin lymphoma in Prince Mohammed bin Nasser Hospital, 46% of the patients are female and 53% of the patients are male, and almost more than 80% of the patients above the age of 50 to 60 at the time of diagnosis. Most of the patients, they have diffuse large B-cell lymphoma. However, we do have other patients with other lymphoma like Burkitt's lymphoma and plasmablastic lymphoma and primary mediastinal B-cell lymphoma. In the left side, as we said, 70 of the patients has diffuse large B-cell lymphoma. The most common subtype is DLBCL NOS. And the most common, the cell of origin was identified in 40% of the patient as germinal B cells, in 10% of the patient as activated B cells, and unfortunately in 40% of the patient we are unable to identify the cell of origin. The stages of the diseases at the time of diagnosis, most of the patient, they have advanced stage disease, more than 60% of the patient. This is the initial chemotherapy given for them. As we said, most of the patients are giving SHOP plus rituximab. However, we do have other patients. We give them mini SHOP because of comorbidities. Some patients will give them only CVB because of underlying cardiac disease. Some patients we give them dose-adjusted EPOC, and we have one patient we give him Codox-M for Burkitt's lymphoma. At the time of this data analysis, 50% of the patient, they achieve complete remission to the first-line therapy, and we have another 10% of the patient is still on active therapy at the time of data analysis, and we have collectively 25% of the patient, they achieve only partial remission, or they are refractory to the first-line therapy. For patients, we decided that they need to go for a second-line therapy. We have only 13% of the patient achieve a complete remission too, and we have 13% of the patient is still on active therapy at the time of this data analysis. We lost to follow up to 30% of the patient, and 40% of the patient, they did not respond to the second-line therapy. At the time of this data analysis, 62% of the patient is still alive, and 7.7% lost follow-up, and almost 30% of the patient, they died. The cause of death in 70% of the patient was death at home of unknown cause. Some patients, they attended the hospital and they died from septic shock or ischemic heart disease. The estimate overall survival is 56 months. Now going to the last part of this presentation about the multiple myeloma. This is how we investigate our patients with multiple myeloma. We do basic labs and we do beta-2 microglobulin and immunoglobulin quantitation. We do bone marrow aspiration and biopsy for all patients to be reviewed locally. We send FISH, multiple myeloma panel, and SBIB immune fixation and serum free light chain as a send-out lab. We do echo and skeletal survey for all patients. And for selected patients, we do spine and pelvis MRI or whole body MRI. For follow-up, we do SBIB, immune fixation, serum free light chain every 1 to 2 months as a send-out labs. And we do bone marrow biopsy when the patient achieves at least partial remission before sending him for BMT. Any patient who needs BMT or radiation therapy will be sent outside the hospital to higher centers. Now again, I want to highlight this point that all patients with myeloma diagnosed after Feb 2022, we give them 2 doses of EvoShield as a COVID-19 prophylaxis. Medications available for multiple myeloma at Prince Mohammed bin Nasser Hospital. We have chemotherapy, dexamethasone. We have immune modulating agents like thalidomide, lenalidomide, and pomalidomide. We have proteasome inhibitors, first generation and second generation, and we have monoclonal anti-CD38 antibody. The total number of patients with plasma cell diseases diagnosed and managed from 2015 to 2022 was 42 patients. This is how we treat multiple myeloma at Prince Mohammed bin Nasser Hospital. Simply, we divided them into transplant eligible and ineligible. For patients with transplant eligible, we give them Velcade, lenalidomide, and dexamethasone for 3 to 4 cycles, followed by BMT and then lenalidomide maintenance. And we give Velcade maintenance for patients with high-risk disease. For patient transplant ineligible, again, we give them Velcade, lenalidomide, dexamethasone for 8 to 12 cycles, followed by lenalidomide maintenance for standard risk disease and Velcade maintenance for high-risk disease. The sex distribution of the patient, female 33% and male 66%, and almost 80% of the patient under the age of 75 at the time of diagnosis with multiple myeloma. The most common ISS stage is stage 2, and most of the patients, they have multiple myeloma. However, we do have other patients with free light chain disease, plasma cell leukemia, wildenström macroglobulinemia, and solitary bone plasmacytoma. Most of the monoclonal immunoglobulin is IgG, and most of the free light chain is CABA. We are able to do FISH testing for 24 patients out of the 42 patients with myeloma. And what we found here is that high-risk cytogenetics was found in 10 out of 24 patients that we did for them FISH, almost in 41% of the patients. The first-line chemotherapy that we give in 85% of the patient, we give them Velcade lenalidomide dexamethasone or Velcade cyclophosphamide dexamethasone. We have some patients, we give them first line as radiotherapy for solitary bone plasmacytoma, and one patient we give him dexamethasone, Velcade, and rituximab, followed by rituximab maintenance as a diagnosis of full denominator macroglobulinemia. We have 9 patients, they achieved good remission and they went for autologous stem cell transplant followed by maintenance. And we have another 6 patients, they went for maintenance without BMT because they are ineligible for BMT. The second line therapy, we do have, we give Velcade, cyclophosphamide, dexamethasone. Other patients, we give them monoclonal antibodies. We give some patient carfilzomib. This is the response after first line chemotherapy. Collectively, 60 to 70%, they achieve at least partial remission. And we have 11% of the patients, they are refractory to the first line therapy. Fate of patients who achieve, it's not a complete remission, it's a good remission, including partial remission, very good partial remission, and complete remission. The fate of those patients is that 60% of them is still in a good remission. The percentage of patients who successfully proceeded for autologous stem cell transplant is only 20% of the patient. And this is, I think, is a very important point. As I said previously, almost 80% of the patients under the age of 75, and they should go for BMT, but we do have some patients who is ineligible due to comorbidity, some patients ineligible due to nationalities, unfortunately, and some patients, they just want to continue their management locally and they don't want to go to any place, even for BMT. At the time of this data analysis, 47% of the patients are still alive and 16.7% lost follow-up, and 35% of the patient died. The cause of death from the congestive heart failure, from COVID-19 infection, and actually we had a very bad experience with multiple myeloma who get COVID-19 infection with a high mortality rate. Some patients, they died from septic shock or cardiogenic shock. The estimate overall survival for all plasma cell diseases in Prince Mohammed bin Nasser Hospital is 53 months. And this is the estimate overall survival by the stage of the disease. As you can see, for the ISS stage 1 is 52 months, for ISS stage 2 is a 58 months, and for ISS stage 3 is a 45 months. In the last few slides, I will just mention the limitations that we faced at Prince Mohammed bin Nasser Hospital. Unfortunately, we don't have a BMT service. We don't have a radiation oncology. We don't have molecular and cytogenetic. We don't have PET scan. And some patients, they are ineligible to some of the novel medications and new medications, especially for multiple myeloma. What we did to overcome those limitations, we established the send-out labs to Bioscientia, Centogene, and sometimes to King Faisal Specialist Hospital through the Saudi Diagnostic Lab. We do PET scan and radiation therapy in KFSH Dammam, and we do BMT in a higher centers. This is a special thanks to the team that I'm working with, including all the consultant specialists and residents. And thank you so much.
Well, thank you very much, Dr. Fahad. It's great news to hear that you've been treating, although you have really big limitations,
Yes.
but you have treated a good number with fairly good outcome. We can take 1 or 2 questions before we go to the next speaker. If not, Victoria, please.
Thank you, Dr. Fahad, for the nice presentation. So, I don't want to speak about Hodgkin lymphoma. Maybe Dr. Martin will ask about Hodgkin lymphoma. So, non-Hodgkin lymphoma, I can see the outcome is inferior to what we know. I'm trying to understand this, looking to the EBC patient, 11% in the range, what should be. Advanced stage is also in the range which it should be, and in other parts of the world. Maybe you have more double hit and triple hit than the normal world you did an exam? Or what's your explanation?
No, no. Actually, yes, yes. We don't have much patient with double hit or triple hit to contribute to this bad outcome in our patients, but I think there is like 35% of the patient they lost follow-up. We send them for salvage and auto, and maybe they achieve good remission and proceed for autologous stem cell transplant. And also we do have some patients, old patient not eligible for intensive chemotherapy, some patient not eligible for novel medications, some patient non-Saudi they lost from follow-up. Maybe this is the reason behind this outcome.
Yes, thank you.
And the same thing for Hodgkin lymphoma, the overall survival remission 63%, which is significantly inferior to what we see and reported in general for Hodgkin lymphoma. Any explanation for that?
I believe it's the same point. We have many patients they simply lost from follow-up, especially for non-Saudi patients, unfortunately. Maybe this is the reason behind that.
But you should not compromise mortality of patients.
Actually, Dr. Mohsen, what I want to say here is this. If I allow me to go back to this one. This is for the Hodgkin lymphoma. Actually, it's the estimate overall survival by the months for the whole duration of observation from 2015 to 2022.
Yes, we can.
Coming from Medina and looking at design experience, what comes to mind is the impact of the health services hurdles. So the delay in diagnosis, the challenge with confirming the lab information, the availability of immunohistochemistry, and the supply chain problems during COVID and post-COVID. And really, I'm in front seat seeing some really impressed with what's available in Jazan. And I would really encourage you to look more in depth of the impact of these factors, the delay in diagnosis, for instance, for people who are eligible or ineligible to the service, on the outcome. Because this probably will explain, in my experience in Medina, lots of the outcome.
Yes, thank you so much for this nice comment.
Yeah.
Thank you.
Thank you. Dr. Anas, last question.
Yeah, it's a great presentation for my colleague, Dr. Fahad. And I will answer Dr. Riyad about the data that we have submitted. There are some patients we could not give them fully managed R-CHOP for non-Hodgkin lymphoma because of ineligibility under MOH service. We could give them CHOP only, and we know that rituximab era before it was very poor response rate. So we lost one patient or two patients because of suboptimal management received. Maybe this is also can affect our facilities. Some patients we could not detect their histopathology was the CMIC immunohistochemistry was not available and not mentioned in their report. This was before 2017 and even in 2019 sometimes you would not have CMIC. And this is the sometimes the suboptimal reported even from private sector. We have suboptimal we could not get reach of either germinal cell or meningeal cell agency. So this is one of the difficulties that we could not connect it very well.
Oh, thank you, thank you. I guess because of time we have to conclude this talk. Thank you very much, Dr. Fahad. Our next speaker is Dr. Ahmed Saeed, who's the consultant in adult hematology and blood and marrow transplant, deputy chairman of Princess Noura Oncology Center, and he's an assistant professor in hematology at King Saud bin Abdulaziz University. So his talk is going to be about autologous peripheral blood stem cell transplant, mobilization and collection of patients with lymphoma and multiple myeloma, a single center experience using the pre-support preemptive approach. Dr. Ahmed, تفضل.
Assalamu alaikum wa rahmatullah. Good morning, everyone. Shukran, Dr. Ayman, and thank you for the organizing committee for the invitation to share our experience from Princess Noor Oncology Center, King Abdulaziz Medical City, Jeddah, about the autologous peripheral blood stem cell mobilization and collection with lymphoma, in patients with lymphoma and multiple myeloma using a preemptive approach using plerixafor. So as you know, lymphoma and myeloma among the commonest hematological malignancies, and using high-dose therapy and rescue with stem cell transplant is commonly used in the treatment of lymphoma and myeloma, either as a part of upfront line or most commonly during the time of relapse. And adequate mobilization and collection of peripheral blood stem cells are important for autologous stem cell transplant outcomes. And currently, the main strategies for routinely used for peripheral blood stem mobilization, either cytokine, mostly GCSF-based mobilization, or what's called steady state, or chemotherapy-based stem cell mobilization. The common mobilization regimen, as you know, either GCSF alone or combined with plerixafor, or cyclophosphamide plus GCSF in myeloma, chemotherapy, disease-specific chemotherapy plus GCSF in lymphoma, and preemptive plerixafor can be used with both either GCSF or chemotherapy or cyclophosphamide plus GCSF. The current minimal threshold of CD34 positive cells for successful transplant is about 2 multiplied by 10 to the power of 6 of CD34 positive cells per kilogram for a single transplant. And although the mentioned regimen for mobilization and collections are effective, but still we could see about 15 and in some reports about up to 20% of patients who go for a poor mobilization, and this definitely would affect on the outcome of transplant. What is poor mobilization? Who are the poor mobilizers? There is no consensus definition. There are multiple definitions. Failure to achieve target level of at least 2 multiplied by 10 to the power of 6. Or this is after collection, or pre-collection having a CD34 absolute level of less than 20 mil per microliters, absolute count, need for apheresis sessions, use of plerixafor if the cell count is less than 10, or yield of collection on day 1 apheresis less than 1.5. So these are considered also definitions, but the most and the best predictive factor is the CD34 cells level at the maximum peak of stimulation. If the CD34 positive cells is more than 20, you would expect to have a successful mobilization, and the borderline poor mobilization if their level is 10 to 20, and clear poor mobilization is less than 10. Plerixafor is a chemokine receptor inhibitor which can be added to both mobilization strategies, and it has been shown to increase CD34 cells yield and improve mobilization and transplant outcomes. The challenges and limitation of using plerixafor is its high cost, and there is lack of consensus guidelines how to use plerixafor in mobilization and collection. So in many centers, it's mostly limited to patients who fail to reach a sufficient number of CD34, so are poor mobilizers, and it is used as based as a preemptive use or approach. Suggested indicated for preemptive plerixafor, either as we mentioned, poor mobilizers, whether with having low CD34 pre-apheresis or low collection on day 1 apheresis. So our study and primary objectives is to review assessing our mobilization efficiency in our center, and reviewing and assessing efficiency of preemptive plerixafor approach that we used in our center. This was in all patients who received auto transplant in our center from 2014 to August 2021. This is a retrospective studies. It was the medical record-based collecting data and data clinical and disease-related in relation to this issue. And data were evaluated for the overall cohort, disease entity, peak CD34, and need for preemptive plerixafor. Briefly about our mobilization regimen. So chemotherapy mobilization, these are the following, are the most common chemotherapy regimen, cyclophosphamide, ESHAB, GTP, and others. And GCSF was given daily of 5 to 10 microgram per kilogram, 1 to 3 days post chemotherapy. And the CD34 monitoring was started when leukocyte count were more than 1 multiplied by 10 to the power of 9. And if CD34 was more than 15, then we start apheresis. If CD34 was on the borderline level from 10 to 15, then we have a dynamic approach based on the goal and patient by patient. For example, if you have a patient who is for tandem transplant, of course, is different from a patient who is for single transplant. If it is less than 10, we continue GCSF, and if there is no further improvement, then we go for plerixafor. For GCSF mobilization, we use GCSF as a usual dose, and we do CD34 on day 4. And if it is more than 8, we go for leukapheresis next day. If it is less than 8, we give plerixafor and go for leukapheresis next day. So the preemptive use of plerixafor, as I mentioned, in chemotherapy-based regimen, it is used if CD34 is less than 10 at the maximum stimulation. And in GCSF base, it's used if the CD34 is less than 8 on day 4. And this is the usual dose. We use 0.24 milligram or 240 microgram. It's giving 9 to 12 hours before leukapheresis. Usually we give it at 9:11, and we do our pheresis 8 to 9 a.m. next day. So the results of this study, we had 215 patients, and 70% of them were lymphoma and 30% were myeloma. And as mentioned earlier, previous presentation, Hodgkin lymphoma represent maybe in most of our centers the #1 indication for auto transplant in our community here. We have 2/3 of our patients, 67%, are male, and 1/3 is a female. And if you see, this is interestingly is maintained even in disease specificity, not only for the over, but even for each disease, they are the same. We treat 2 to 1, male to females. Patients' age, the median age is 40 years. We do see much younger patients in Hodgkin lymphoma and older patients in multiple myeloma. And regarding the non-Hodgkin lymphoma, most of the indications is a diffuse large B-cell lymphoma, but there are other types of non-Hodgkin lymphoma. We used chemotherapy mobilization in about 71% of the patients, and GCSF was used in 29 of the patients. And most of our chemotherapy cyclophosphamide as expected in multiple myeloma patients, and we use ESHAB previously more in lymphoma patients. And GCSF was used in 62 patients, and if you see, most of them are Hodgkin lymphoma, because for the last few years, our salvage for Hodgkin lymphoma is brentuximab, bendamustine, and we use mobilization with G-CSF after 2 cycles of bendamustine brentuximab. So regarding the outcome in regard to our objectives, so 80% of our patients reach more than 20 CD34 positive cells. And we had 9 persons who were in the borderline from 10 to 19 persons, and 11 persons of our patients were had clear poor mobilization. The median CD34 was 61. It was much higher in multiple myeloma patient, and the lowest was in the Hodgkin lymphoma patient, as expected. And 83% of patients collected with one leukapheresis session. Regarding the preemptive efficiency of preemptive plerixafor administration for poor mobilizers, so preemptive plerixafor was used for 13% of the poor mobilizers, so 29 patients. And this was in regards of mobilization strategies. It was used only in 10% of chemotherapy, of patients collected with chemotherapy, and more, it was used more in patients who are collected with G-CSF. And regarding the disease entity, of course, the poor mobilizers were more in Hodgkin lymphoma patients compared to non-Hodgkin lymphoma or myeloma patient. So in regard to mobilization outcome, all patients with clear poor mobilizers, they were candidate for preemptive plerixafor. So these are the patients with less than 10 CD34, and in patients with a borderline, we had 20 patients with borderline, and only 5 patients of these 25, which represent 25% of borderline patients, they required preemptive plerixafor. Most of the patients on the borderline, they didn't require preemptive plerixafor. So 5 patients failed preemptive plerixafor, and with this, 98 with preemptive plerixafor approach, 98% of our patients, 210 out of 215, collected with the first attempt. And this improved of course, if you do next attempts, it has its own impact on the resources, on the patients, so with using this approach, we were able to collect 98% of our patients with the first attempt. The 5 patients who failed the preemptive approach, they went for the second attempt, and 3 of them, they were recollected with additional plerixafor, and 1 patient, he went for chemotherapy or mobilized with chemotherapy, and there was only 1 patient who failed the collection with the first and second approach. So only 2 persons, which is this 1 patient who required second. So with this, as I mentioned, with using this approach, preemptive approach, more than 99% of our patients collected, 214 out of 215 patients collected with the first and second attempt. So there was only 1 patient who failed to be collected. So in conclusion, preemptive plerixafor during initial mobilization is almost certainly better for patients than remobilization with G-CSF plus plerixafor, since it's avoid delay of transplant, anxiety about possibility of failure of second attempt. And our data suggests that plerixafor is not needed if peripheral blood CD34 is more than 15 on predicted day of leukapheresis. So this is now our proactive intervention to rescue mobilization. If CD34 is more than 15, in the EPMT guidelines they use 20, we, in our institution, we use 15, then we go for apheresis. If the CD34 is 10 to 15, we go for dynamic approach, case by case. And if it is less than 10 for chemotherapy mobilization or less than 8 for GCSF mobilization, we go for a preemptive plerixafor. And with this, I come to the end of my presentation. I'd like to thank our patients, family, our clinical team, nursing team, our lab staff, and specific thanks to Ms. Mona Najib, is the stem cell therapy and cellular therapy stem cell lab supervisor, who contributed, had a major contribution to this project. And thank you.
Thank you very much, Mr. Ahmed. Good data. We're short in time. I have too many questions in mind, but I mean, good outcome with this preemptive, cost-effective, I guess.
Yes.
Using this plerixafor, if you compare that to using GCSF alone for everybody, you will be using at least double the cost of the mobilization. But what do you use for myeloma? Do you use, it seems that you use mostly cyclo-G, but for which patients do you use G alone? And why do you use cyclo-G? Is it just to limit the cost, or is it because of the notion that cyclophosphamide is effective in myeloma?
Yeah, we use cyclo-G. Recently, we use cytarabine in some patients who were expected to have poor mobilization. So we use cytarabine, but mostly we use cyclo-G. This is the standard of care in many centers, and we thought maybe using cyclo-G will minimize the use of plerixafor. If you use G alone, maybe you will need more plerixafor.
All right, we can take one question because we have Jummah prayer coming up. We have to go. Dr. Riyad.
So I have noticed one thing, which may not very related to the plerixafor story. The median age of myeloma patient was 53. This is horrible.
No. Correction. Median age of transplanted myeloma.
Yeah, I know. Even transplanted patients.
No, but you are taking a big chunk of patients who are older out of the equation.
And the range is up to 69.
But the question is it reflecting the numbers in Saudi Arabia or just in your center because you're getting
No, we see older patients, but this data about the transplant eligible patient. So for transplant eligible patients, you would expect them to be younger patients.
All right, thank you very much. We conclude the session. Thank you very much.
Thank you.
We have Jummah prayer coming up, and then the next session will start at 1 o'clock in the afternoon. Sharp. Please be here at that time. Thank you.
session will be addressing very important topic in lymphoma field with an excellent selection from the scientific committee for this topic. So with our delay, we will introduce our first speaker. Is Professor Owen O'Connor. Is with American Cancer Society Research Professor. He's Professor of Medicine, University of Virginia Comprehensive Cancer Center, Professor of Microbiology, Immunology, and Cancer Biology, University of Virginia. He will be talking about cutaneous T-cell lymphoma, new therapeutic option. Prof. Owen, the floor is yours.
Thank you. And I hope everybody had a good lunch. So what I'm going to try and do over the next 30 minutes is tell you a little bit about where CTCL is going from the point of view of what's happening on the therapeutic landscape. So first point to make. The CTCL are not like what I just talked about with peripheral T-cell lymphoma, where we have really not a lot of great options, and we're in the midst of trying to figure out what's the best way to treat our patients with minimal marginal drugs. CTCL is the opposite. Even though CTCL is technically a peripheral T-cell lymphoma, the definition of a peripheral T-cell lymphoma is a post-thymic mature T-cell lymphoma that has undergone gene rearrangement of the T-cell receptor. So by definition, the CTCL are really a subtype of PTCL. But the CTCL, as I'll discuss in a moment, have a lot of different therapies, and the strategy to manage these diseases is unlike the strategy to manage any other kind of lymphoma. You treat many forms of lymphoma, aggressive lymphomas, with combination chemotherapy with a hope to cure. In the case of the CTCL, they're more like indolent lymphomas, and many of the paradigms change as a function of the disease. And so we'll talk about how, within the context of CTCL natural history, you may have very indolent forms of the disease that may take you down one therapeutic route, and you may have very aggressive forms of the disease that take you down a distinctly different therapeutic route. So what I'll try and do is just underscore some of those clinical considerations that you use in your mind to think about prognostic subsets of these diseases. And we'll talk about two drugs approved in the United States. I don't know if they're approved here in Saudi Arabia, brentuximab and mogamulizumab. So we'll talk about some of the data from these two trials just because they're approved and they're highly effective therapies. They're randomized phase 3 trials, so their benefit is clearly established. And this is not meant to intimidate you in any way, but there are a lot of other new agents. And we'll just talk about some of those new agents, touching on them. These are not necessarily approved other than, say, romidepsin, but I'm just going to touch on some of these therapies. And the point I will emphasize is if you look at these new therapies, you're going to be hard-pressed to find chemotherapy as the standard, right? So how this disease has changed, and I hope this is how PTCL changes, is we start establishing the basis for using a lot of these other novel precision-targeted drugs or immunotherapies to sort of rewrite how we think about the disease. And if you look at this slide, it sort of presents the T stage, the tumor stage, of different types of T-cell lymphoma, of different types of patients with cutaneous T-cell lymphoma. And so very much like what we do in solid tumor, we use the T&M classification. We don't really use that in other blood cancers, but it is used here in CTCL. You can see that patch disease, where you have patches or plaques covering less than 10% of the body surface area, T2 having more than 10%, tumor stage, T3. These patients here, I don't know if you've ever seen them, but in my career, those patients coupled with the gamma delta subpaniculitic T-cell lymphomas represent some of the most horrific forms of lymphoma you can possibly take care of. And then, of course, the Sézary T4 types, and this is the follicular tropic. So what you see here is at survival, 10-year survival as a function of the T stage. So if you have patch plaque disease limited to less than 10% of your body surface area, you have absolutely the same survival as somebody that had no CTCL. So it's a very, very indolent course, and it's treated as such. But you can see how, as the T stage advances, your 10-year survival goes down dramatically. And in fact, when you integrate all the other elements of the staging, and I'm not putting this up for you to memorize it here, but I'm putting it up to make the case that it's very similar to what we see in solid tumor. You have T stage, N stage, M here is very general, visceral involvement, and of course blood stage to pull out the Sézary syndrome. And so when you look at this prognostic category, this T and M classification, you can actually define the stage of the disease. The stage of the disease here is important because it helps establish what the prognosis of those patients happen to be. And so just as you look at overall survival, it's an absolutely perfect overall survival stratification. Patients with early stage disease have pretty good long-term survival. Patients with stage 4 disease generally very poor. If you look at the risk of progression, it's the exact mirror image. The risk of progression goes up as a function of that stage, and likewise overall survival by various risk groups. So when you think about your patients with cutaneous T-cell lymphoma, very, very important in your head is to understand exactly where they sit with regard to their clinical stage of disease. And the algorithms for this disease, I'm not going to belabor the details here. I'm simply putting them up to underscore some points. So first is thinking about all of these elements of stage, comorbidity, symptoms. Symptoms are an extremely important feature of this disease. And for those of you that take care of it, you know that patients will come in itching and have lots and lots of pruritus and lots of symptoms. And we'll talk about response criteria and how one evaluates response, but it's not that common that these kinds of quality of life scales are built into our assessment of response, right? And so depending upon the stage and the need for symptom control, there's a whole variety of regimens. And they're really, you know, while different centers and different doctors may have their own algorithm in their head in terms of how they proceed, there's really not one unified algorithm in terms of going from skin-directed therapy to external beam to total skin electron beam. There's no real algorithm out there. So it's really left to the doc to try to decipher which of these therapies at any given moment in time is sufficient to control the symptoms and deal with the stage of the disease. When you look at patients that have advanced stage disease all the way over to patients with large cell transformation, these are the patients that can develop tumor stage disease, and these large cell transformations are extremely difficult to manage, extremely difficult. And you can see that this would be the one scenario where encouragement to get on a clinical trial or combination chemotherapy is in order, even in some cases autologous stem cell transplantation. So the algorithm is actually tailored to the clinical scenario, and you need to actually understand that clinical staging system with regard to understanding the risk of the patient. So it's very clear there's a lot of new drugs. I won't belabor all of these. We're going to talk about some of them. But this table is unlike what I would share with you for PTCL, where we don't really have all these different kinds of agents. So there's a lot of drugs out there with very unique mechanisms of action. You'll see chemotherapy is not prominently featured. But the Alcanza study was actually a very important randomized clinical study looking at brentuximab against dealer's choice. And here, dealer's choice was actually methotrexate or bixarotene. All these patients were treated that had to have CD30 positive mycosis fungoides or primary cutaneous anaplastic large cell lymphoma. We can talk about the anaplastic large cell lymphomas, but you need to, in your mind, distinguish them from the systemic anaplastic large cell lymphomas. How many types of anaplastic large cell lymphoma are going to be in the next iteration of the WHO classification? I'll say a number, you raise a hand. 2, 3, 4. My God, you guys. 4, we see a 4. 5. All right, you're very quiet, or you've got postprandial narcosis. The answer is it's going to be like 5. So there's ALK negative systemic, there's ALK positive systemic, there's, what else? Breast implant associated, right? There's primary cutaneous. But guess what? In the world of ALK negative anaplastic large cell lymphoma, the DUSP22s, you know that ALK negative has an inferior prognosis to ALK positive. So because the DUSP22s are considered now to be a favorable subset of the ALK negative, WHO has pulled it out as a separate entity. So in the case of systemic ALK negative anaplastic large cell lymphoma, we've always thought of those as bad players. having a prognosis intermediate between ALK positive and all the other PTCL. The DUSP22s have a prognosis like the ALK positives. So now 5 types of anaplastic large cell lymphoma. It's so critically important for you to know that, because you will see patients that have systemic disease. Maybe they show up with a skin lesion. You'll see patients with a skin lesion that might show up with a node lesion. You really need to spend time to figure out what kind of anaplastic large cell lymphoma they have, because you will treat them differently. Sorry for the diversion, but it's an important point. And so we'll talk about the endpoints of this study, but what I want you to pay attention to in this randomized study is they used a primary endpoint of overall response rate 4. And I don't know if you're familiar with that, but it's the first study, and right now the only one, that's used this as an endpoint. We'll talk about it. The CTCL field is in a state of controversy about trying to define what the right way to assess response is. When you look at the overall toxicity of the regimens, it's pretty well tolerated. And therein lies point number 1. When you're developing regimens for CTCL, most of the therapies tend to be monotherapies that are well tolerated. So the platform is not to think about combination therapies or very toxic forms of the drug. We'll talk about one of those drugs in a moment, pralatrexate, which was studied as a monotherapy, but the dose we use in PTCL was deemed to be too toxic for those docs that take care of CTCL. So studies were done to back off on that dose to see where the right level of toxicity and activity exists. In the case of brentuximab, this is what you would exactly expect. You see a very low incidence with methotrexate and bixarotene. You see a significant percent of patients having grade 3-4, having any grade toxicity, but here in green, the grade 3-4. Most of these other toxicities are actually fairly manageable, though there is a little bit more toxicity associated with brentuximab versus the other 2 drugs. And when you look at the waterfall plot, you don't need to be a cutaneous T-cell lymphoma doc to realize that brentuximab, in this case, looking at the patients with MF versus primary cutaneous anaplastic large cell lymphoma, have much deeper and better responses across the board. Look at the patients with primary cutaneous anaplastic large cell lymphoma, essentially almost all of them doing very well. Remember the anaplastic large cell lymphoma as a group, including those breast implant forms of the disease, all are notable for gross expression of CD30. Basically, those cells have 100% CD30. It's where you get into the other types of T-cell lymphoma that the CD30 positivity can fall off. And again, you can see the differences with a marked superiority for the waterfall plot seen with brentuximab. When you look at the overall response rates, again, we can look at overall response rate 4. What ORR 4 really means is what percent of patients are maintaining that response by the 4th month. So historically, how a lot of this was determined is you just look at overall response. Did you respond? Did you not respond? And so that's why that number is a little bit higher, 67% versus 56% of patients who held that response by the 4th month. You can see over here with regard to the physician's choice, those numbers are 13 versus 20%. So a very clear therapeutic advantage in the intention to treat population. And again, just as I alluded to earlier, when you look at mycosis fungoides as a function of stage, you'll actually see what you always try to look for is that those response rate that you see in the intention to treat population or in the low risk stage population, you like to see those response rates carry through to the high risk patients. And in fact, that's what we see. You see the patients with stage 1A to 2B disease having pretty good response rates, certainly a lot better than what you see in the investigator's choice. And here, of course, the numbers get very tiny, so it's awfully hard to say anything, but amongst those patients with those high-risk forms of CTCL, they tend to do pretty well. And again, when you look at the progression-free survival, there's a highly statistically significant advantage for the patients that got brentuximab versus dealer's choice. So these are the data that actually gave rise to the approval of brentuximab. Now, Miles Prince from Melbourne gave a great talk at the T-cell lymphoma forum talking about response criteria in CTCL. And he made the case that the current use of MSWAT, the current way of assessing response, has its limitations. And he's trying to sort of increase the dialogue and the narrative around how should we be looking at response going forward. So he clearly made the point that MSWAT will demonstrate drugs that have clear biological impact, though there are a lot of deficiencies in MSWAT that may not be apparent to you when you're in the clinic or reading about it. How many people here, don't be bashful, how many people here have used MSWAT in the assessment of CTCL responses? Nobody. What do you use? Do you see CTCL? What do you use your nose and say, smells like a response? That may work a little better than MSWAT. From the pathologist tells them if they have a response?
Yeah.
Say?
After failure of third line.
Ah, dermatologist. Ah, I see, yes.
They refer for either
I see.
Vedotin, rituximab, or for the
Yeah.
DLI inhibitor.
I got it. And that can be an issue, right? Because dermatologists can be very chemo nervous and averse, right? And so I've always, I don't mind managing these patients, and I get a little nervous when dermatologists start prescribing chemotherapy. But there are differences in terms of how people approach the disease. So in the case of the MSWAT deficiencies, there's differential weighting of patch versus plaque versus tumor stage disease. Evaluating response by MSWAT gets very difficult if you have erythroderma. It gives no insight into whether there's meaningful, durable impact, hence overall response versus ORR4. And importantly, MSWAT does not address benefit if patients do not meet PR. And so what Miles presented the case for was not just looking at MSWAT and these kinds of criteria, but actually looking at time to next treatment as sort of one of those benchmarks to pay attention to in terms of evaluating the response. And so just to drill home that point around the ORR4, you can see here head-to-head comparison. So of course, those patients achieving a CR or PR lasting 6 months versus a patient that had a CR/PR lasting only a few months, this patient would not be counted as having had a response in Alcanza, but this patient would, for example. And so it's just an important detail that as you read these studies and you try to cross-compare the data you've seen with Alcanza versus the data you see with other drugs, just keep in mind now that a lot of these trials may be using different endpoints to assess the benefit. So I'm not going to belabor that. Now, the second drug approved for the disease is one that targets CCR4. And this is one we got involved with way, way long ago when CCR4 began to emerge as an important target. And so we know that there are ways to target CCR4. So mogamulizumab, which is a humanized defucosylated monoclonal antibody with enhanced ADCC. So what all that means is the ADCC part of the FC domain, the antibody-dependent cellular cytotoxicity, it has been shown that removing the glucose residues from the FC domain of the antibody, so it's the Y, so it's the stem of the Y on the antibody, makes the antibody much, much more efficient at facilitating ADCC. And that's obinutuzumab, it's ublituximab, it's other CD20s. Rituximab is not that. So these class of antibodies tend to be referred to sometimes as glyco-engineered. So the manufacturing process takes these sugars, the most common would put on is fucose. It takes those sugars off the FC domain and gives the antibody much, much better antibody-dependent cellular cytotoxicity. And so all of that is symbolized here. We know that CCR4 is expressed on malignant T cells. Mogamulizumab is a humanized antibody targeting CCR4, and it's approved in Japan for the treatment of HTLV1 ATLL. And so the clinical trial that gave rise to the approval of MOGA was Maverick. And Maverick was also another randomized phase 3 clinical trial looking at mogamulizumab versus vorinostat. Now, the casual observer could say, vorinostat? Is vorinostat approved in Saudi Arabia? No. So vorinostat, I helped develop vorinostat way back when at Sloan with Paul Mark. So vorinostat was one of the first histone deacetylase inhibitors to get into the clinic. It's an oral hydroxamic acid that was approved for the treatment of cutaneous T-cell lymphoma. People looking at this trial could reasonably criticize the selection of the control arm. Vorinostat was a good drug. The FDA at the time said, well, there's no data that it's any better or any worse than any other drug. So it was established as a reasonable comparator for regulatory purposes at the FDA. Patients with histologically confirmed MF or Sézary syndrome and failed at least one prior systemic therapy without evidence of large cell transformation were eligible for the clinical trial. And so if you look at the Maverick data, the progression-free survival, again, highly statistically significant, 7 months versus 3.1 months. The hazard ratio, 0.53. When you look at patient-reported symptom reduction, so this has become pretty important in conducting a lot of different CTCL studies. So are you not just improving the disappearance of the disease, but what are you doing for the symptoms? And I'll tell you, when I was I was the first person to give vorinostat to any patient. And one of the first things I saw, God is my judge, was treating patients with Hodgkin lymphoma. And when you saw patients with Hodgkin lymphoma, you know those patients that have bad itch, they just say, "Doc, I want to die tomorrow because I can't deal with the pruritus." So we had a lot of patients that got vorinostat. And the first thing they told me after starting the pill, my itch went away. And so it was sort of very, very interesting. And of course, around that time, romidepsin was emerging from the data at the NCI and CTCL, and that's what prodded us to think about pursuing vorinostat and CTCL. So the early experiences with the drug are very interesting. But what you see here is the symptom improvement scale, everything favoring the outcome with mogamulizumab. The progression-free survival, 7 months for mogamulizumab, better response in blood over lymph nodes. That's another interesting feature for many drugs studied in CTCL. They may have better compartmental effects. They're not the same across the board. And the median time to worsening was 27 versus 7 months. So a lot of data, both symptom data as well as response data, demonstrating the superiority of mogamulizumab. When you look at the safety summary, you can see here, in general, a pretty well-tolerated drug. Rash tends to be one of the more common side effects of the drug, and here you can see all grades. The good news is only about 5% of those tend to be grade 3 or 4, and you can see that that is higher than what we see with vorinostat, both with regard to total grade skin toxicity compared to vorinostat. Everything else has a little bit worse incidence here in terms of all grade, but when you look at the grade 3, 4, it's not that much inferior. So let's talk briefly about a number of the new drugs. And again, I'm not going to go into too much detail. I just want to sort of put these things on your radar so when you read about them in the literature or you hear about them at ASH, you'll say, good, I knew this was coming along. It's nice to see that we got more data. Many of you know that targeting the IL-2 receptor, CD25, like the ONTAC, you remember ONTAC, the CD25 diphtheria toxin? And so it's become still a very important target in the field of CTCL, and a drug called E777 is a fusion protein targeting the IL-2 receptor. And so this is a small study, about 21 patients, the efficacy population here, 18. You see the overall response rate, not bad, about 44%. The overall population over here, 31. Only one patient achieving CR. So interesting response rate, not exactly a great complete response rate. You can see the waterfall plot here. So you see the majority of patients have some downward deflection, but a minority of those patients go on to actually have meet the criteria for response. This was a phase 1 study, so there were patients getting lots of different doses of the drug, which may account for some of the noise over here. But nonetheless, there are patients that did have pretty dramatic responses. As you can see in this picture here, this is a very dramatic response, and by the PET scan. When you look at the waterfall plot, again, this is looking at changes in the tumor volume. This is including patients with PTCL and CTCL. And so the patients in PTCL here in blue, CTCL in orange, still shows a pretty not terrible response rate. I don't view it as any better or worse than anything else in PTCL. So the overall response rate was 36%, 41% in PTCL, 31% in CTCL, extremely small numbers. Here you can see some of the evidence for the progression-free survival. This is on the horizon. This is data that's evolving. I think we'll need more time and more patience to be able to understand whether this is the kind of drug that's going to have a role. Pralatrexate, you know, is a drug that I both invented and developed. It was the first drug to be approved in PTCL in the United States back in 2009. When we began thinking about trying to explore it for use in CTCL, the first thing that we had to do was sort of revisit the dose and schedule. The drug can be associated with some mucositis. Otherwise, that's the big toxicity. And so we actually did sort of a reverse phase 1. You can see here cohort 1, and then we moved on. So here we're kind of starting with the MTD dose that we had in PTCL. So 2 patients, 100% response rate, both of them responded. But because of the issue related to toxicity, we began a program to dose reduce. And this is one of the interesting features of this drug that still astounds me today, and we've made new versions of this drug that I think will be even better. In that, establishing a dose response for this drug has been really hard, because we do see responses down at 20 milligrams per meter squared. We had seen some responses down here, admittedly only one down here, but at low doses you do tend to see responses. We have seen responses at 15. And so the question in CTCL is, how do we pick these particular dose levels and move on? But nonetheless, this never really got legs after this phase 1 experience. It was documented to have effect, but given the competitive and climate at the time, this kind of stopped there. I think the newer formulations we're making could be better, because we can give the drug less frequently with pretty good exposure. Now, this is another drug, and I don't know if you've heard about the CD47 targeted drugs, but this is one that we were also involved in back early in the day. And most of you are probably aware that tumor cells have a protein on the surface called CD47. And the way to think about CD47 is it's a do not eat me signal. It's a signal that tells the macrophage, don't digest me. So the ability to induce phagocytosis by a macrophage is actually inhibited by the expression of CD47. So CD47 on the tumor cell interacts with a protein on the macrophage called SERP-alpha. It's this interaction that instructs the tumor cell to not touch the tumor cell. It instructs the macrophage not to hit the tumor cell. Is that clear? And so what happened, so this target has been getting a lot of attention. There are now a number of drugs out there targeting CD47. There's the drug that was developed by the company 47 that was bought by Gilead, which is an antibody. But another way to therapeutically intervene here, which was the approach developed by Trillium, was to actually make the protein a SERP-alpha protein that would mimic the SERP-alpha on the macrophage, bind to the and block an anti-SERP-alpha on the macrophage that would blind the macrophage. And so this way they could actually intervene to induce the macrophage to phagocytose the tumor cells. Now, there have been a couple of ways, and early on when we did this phase 1 study, I'll show you the pictures, the patients that had some of the most dramatic responses were patients that had large cell transformation of their mycosis fungoides. Remember, I told you that was a pretty difficult clinical situation to manage. The other strategy was one that was adopted by Christiane Queerfield out at City of Hope. And she's a dermatologist that was interested in injecting the TTI 621, that's the SERP-alpha analog, into the tumor cells directly. Now, as a therapeutic strategy, you might think, well, that's going to be a pain in the neck if you have a lot of lesions on the skin. But she was looking to do some biology. She wanted to inject it and see if she could understand how the drug was working in the tumor microenvironment. So she developed an algorithm for treating patients at a function of these different doses. You can see the number of patients she treated here. She treated 15 patients with CTCL. She found 1 patient had a PR, 1 had a complete remission out of 6 evaluable patients. 2 responding patients were bridged to an allogeneic stem cell transplant. So between her intralesional experience and our systemic intravenous experience, it was clear that there is activity with these macrophage inhibiting, facilitating drugs. Now, this gives you an idea of the drug. This is the actual molecule, and you can see it has built into it, it's a fusion protein. So on this top end here, you have the CD47 binding domain, binds to the human SERP-alpha on the macrophage. This is the human IG domain here, and that is delivers an eat me signal to the tumor cell. Okay? So this is the actual intervention. And these are my patients. These are my actual patients. This is a very interesting confocal microscopy. If you can see, the tumor cells are in green, the macrophages in red. And when you treat with the drug, what you see is the tumor cells inside the macrophages. It's crazy, right? So first time I saw that, I was like, okay, I want to study this drug. That was super interesting. But this is an actual patient. And these are patients that have tumor stage mycosis fungoides. You may not be able to appreciate the third dimension, but this is a patient that had tumors all over their back. Now, this is not a patient you're going to take the time to intralesionally inject in a prescribed way. They got the systemic therapy. They had a huge regression, PET scan positive to negative. This is a patient that had tumor MF. It was eating a hole in his freaking neck. Look at that. These cases, you have to have a strong stomach, and you can't see them after or before lunch. These patients get very sick, and you could see here, basically holes from the tumor. And look at that. Basically healed over the entire lesion with the drug. So these patients had responses. They weren't short-lived. They were very long-lived responses. So this drug, there's new versions of it. This is a case from Christian, who did an intralesional injection. This is a guy that had it on the foot. You can see by week 4, a near eradication of all these tumors that were just invasively eating away the stroma of the skin. These are the cases here. So very, very dramatic responses. There is now second and third generations of the Trillium drug that are developed. I think Pfizer bought Trillium and is now put together their own program, but I think it's a pretty promising drug on the horizon. PD-1 continues to be a drug of interest in the T-cell malignancies. For me, it remains to be defined what the response rates for the checkpoint inhibitors are going to be. But here you can see a classic waterfall plot. So this is one experience looking at pembrolizumab in MF and Sézary syndrome. If you look at changes in the tumor, you see the spider graph here, some patients having marked reductions, some patients growing. But small patient experience of the 9 patients evaluable, you can see the waterfall plot. A lot of patients with PR, 1 with CR, a couple had progression. That overall response rate was 38%. The time to response was about 11 weeks. Median progression-free survival not reached. Response rate was higher in patients with MF than Sézary syndrome. With all that's happening in CTCL, it's not clear to me that pembrolizumab is going to be that drug on the horizon that's going to have a very clear role. If it does have a role, it may be reminiscent or similar to what I told you about with the combined epigenetic therapy, where you're stimulating the immune microenvironment to favor this response. If you ask Owen today, what do you see as the vision for epigenetic therapy? Somebody was asking me at lunch. I think as drugs by themselves, they're going to be okay drugs. But I think that the real value, the value as defined by people like Ari Melnick and people like Steve Balin at Hopkins, is they're very, very, very good drugs to prime the tumor cell and the tumor microenvironment. They make the tumor cell more sensitive to chemo, and they prime the tumor microenvironment to be responsive to immunologic therapies. And that's what we've seen in the lab, that's what we've seen in the clinic, and I think that's likely to be the future of epigenetic therapies. Now, another class of drugs that's gotten a lot of attention is duvelisib. Do you have PI3K inhibitors approved here? So you are all probably no doubt familiar with all of the luggage that goes with PI3K inhibitors, and I've been vested in this for a long time. In the United States, these drugs are under attack by the FDA. The FDA, as of last Friday, pulled the last one off the market. Idelalisib, duvelisib, just had a meeting before the Oncology Drug Advisory Committee at FDA, where there was a vote to actually pull it off the market. Many of the other PI3 inhibitors in development were stopped from filing their application, all because of this issue around the autoimmune toxicity seen with the PI3 inhibitors. And I can talk a lot about what the mechanism of that is and how I think we should approach it. But nonetheless, duvelisib is a drug that has demonstrated some activity in PTCL. And there are single-arm registrational studies looking to get it approved in the United States in PTCL. But I think those studies may have just died as of last Friday, because the FDA made it clear you cannot get a PI3K inhibitor approved in the United States in the absence of a randomized study. So any single-arm studies with these drugs, pay attention, are probably not going to meet the bar for approval. But nonetheless, if you look at all the T-cell lymphomas in this study, you see a response rate a little bit over 40%. You can see the progression-free survival, patients with PTCL versus CTCL. Again, you can see the overall survival where patients with PCCL and CTCL. So the overall survival not reached, single-arm study, hard to say. About 80% of patients were alive at 2 months, median progression-free survival for CTCL about 4 months. So given its activity by itself, I don't think this is going to be a home run drug. And
1 minute.
1 minute, got it. We've already talked about some of this data, but I'm just underscoring it. We talked about tolinapant. We talked a little bit about its complex mechanism of action. But again, just like I showed you, more patients, but only about a 30% response rate in CTCL. So it's another one of those sort of average drugs coming along, probably never going to have a role by itself. But it's possible, as I shared with you earlier, new data. You see all this red? This is a good thing if you study synergy in pharmacology. It's all unbelievable synergy. And even in CTCL, these are CTCL lines, anaplastic large cell lymphoma, profound synergy. And so now there's plans in CTCL to start tolinapant with decitabine. This is my own effort to tell you yet again how we're developing the nanoromidepsin in CTCL and PTCL, where I think this could be a very interesting model to develop, and we could think about putting drugs together. And the role of stem cell transplant. Really, the role of stem cell transplant here for patients with T-cell lymphoma is largely resigned to those patients that have evidence of large cell transformation. You can see here some of the data with respect to CTCL 5-year overall survival. So there is some benefit from transplantation. And you can see over here CTCL versus PTCL. So this tends to be really confined to 1 or 2 patients, 1 or 2 types of patients. So these are very heterogeneous disorders. You have to look at the clinical presentation to understand risk. A vast repertoire of new non-chemotherapy directed treatments are changing the landscape. Treatment focus is very different from that I talked about in PTCL. Systemic therapies have limited role for many patients. Transplant, limited restricted role. Referral to local regional centers is highly recommended. And with that, I'll put in a cheap plug for this book that Zinzani, Kim, and I put out. There's lots of chapters on CTCL, and this is the first textbook on T-cell lymphoma, both PTCL and CTCL. If you're interested in a copy, email me, and I'll email you back a discount to get the book.
Thank you so much.
Thank you.
Thank you for your presentation and your expertise. I think we've exceeded the time, so we can allow like 1 question or 2 questions.
Thank you so much. Excellent presentation, as always. I call it a complex disease in terms of the diagnosis and the response assessment, and to the choosing also the systemic therapy. And one of the uncertainty at each step in the management of mycosis of the CTCL is expected. With regard to the systemic therapy, I mean, apart from the maybe CD30 as a biomarker, is there any other biomarkers that could help either clinically or into the blood test into the choosing or sequencing the therapy into the systemic disease?
A great question, and one that gets asked all the time. And I think while CTCL is not the dominant part of my practice, it's a small part, there's really no, and I would say this is probably true for most of cancer, right? That there's no real biomarker to guide therapy, right? So that's the holy grail. That's what we're looking for in bladder cancer as well as T-cell lymphoma and B-cell lymphoma. Maybe the new classifications in DLBCL that Ship and Stout published in looking at, IRAK4 and other things may be down the road. But right now there's no obvious biomarker. CD30, CCR4, which is pretty universally expressed. Those would be 2 where the biomarker gives you insight. But as for all the other drugs that I talked about, CD25 is a feature of the disease. nothing for pralatrexate, nothing for tolinapant. I think it's still largely guided by the clinical prognostic presentation. And you're hit it spot on, right? Trying to evaluate the disease and confirm it, trying to figure out what's the stage of the disease and where you fit, and how do you assess response. It is a befuddling disease to take care of.
Thank you. So, without any delay, we will introduce our next speaker. Is well known to us. Is Dr. Mubarak Mansour. He is an adult medical oncologist and the chairman of Princess Noura Oncology Center, King Abdulaziz Medical City, Western Region, Ministry of National Guard. He's an associate dean, academic and student affairs, College of Medicine, Jeddah, King Saud bin Abdulaziz University for Health Sciences. We will be talking about the outcomes of high-dose methotrexate for CNS prophylaxis.
Shukran. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the organizers and thank you for the kind introduction. And it's difficult to talk maybe after Prof. O'Connor's. So hopefully I will keep you engaged with this talk. So the outcomes of the high-dose methotrexate for a CNS prophylaxis. And I think this is one of the talks that I think we could just start with the conclusion slide rather than just going and say there is no randomized clinical trial yet. But however, despite the debate and this topic still unfortunately have that dilemma of when to give, what to give, and is there also evidence into the efficacy of the methotrexate, especially the high dose. So I'll be talking about just giving introduction about the CNS relapse and diffuse large B-cell lymphoma, primarily about the predicting the risk, what are the models that we have to predict the risk of the CNS relapse, clinical markers and biomarkers, and also role of intrathecal and role of IV high dose methotrexate, timing of high dose methotrexate, and then we'll just go over our experience at Princess Noura Oncology Center. So the secondary CNS relapse in diffuse large B-cell lymphoma, and we are not talking about a synchronous CNS here, we are talking about a secondary diffuse large B-cell lymphoma with a CNS involvement. About on average 5% of patients with a diffuse large B-cell lymphoma, and that due to maybe the hematogenous route, about the direct infiltration sometimes from the masses, especially close to the CNS. It could be through the neurovascular axis, and it affects primarily about 70% or more the parenchyma, meninges, CSF, or the eyes. With exception of the primary testicular diffuse large B-cell lymphoma, the time to the CNS relapse is typically within 6 to 9 months, and that's why most of the people saying that this could be occult, a CNS involvement at the time of the presentation, and it's not a relapse disease. As you know, a poor prognosis for those patients who developed secondary CNS involvement post even intensified therapy. So what are the models that we are using to predict the risk of the CNS recurrence in a diffuse large B-cell lymphoma? This is a CNS IPI. This model was developed by the German group, non-Hodgkin lymphomas group, and was validated by the British Columbia Cancer Agency. And primarily, it says that risk factors which we are using for the IPI, for the diffuse large B-cell lymphoma, age more than 60, poor performance status, elevated LDH, advanced stage, and multiple extranodal involvement, and they added renal or adrenal involvement. And they stratifized the patient to low, intermediate, or high based into the 0 to 1, 2 to 3, or 4 to 6. And you can see here on the right side that both from the German group as well as from the British Columbia Cancer Agency, nice stratification of those with the high risk in a blue and intermediate green, and also in the low group with the CNS involvement according to those factors. However, one of the, this model was criticized at just only taking in account the IPI plus the renal or adrenal, but there are other things not counted in this as the other extranodal sites, especially testicular, breast, uterine, ovarian. Also, it was not taking in account also the other biomarkers or biological biomarkers like CMYC, BCL2, even in double or triple hit. So most of the positive predictive value for that model was about 12%. And you can imagine in your practice, without the renal adrenal, how many patients will be in that group of more than maybe I would say 2 factors just based into the age and poor performance status. And if you're going to give a prophylaxis for those patients, then you will end it by having a huge percentage of your patient receiving a high dose methotrexate. Other biomarkers also and other studies from Goya trial from the National Cancer Research Institution in UK also reported their experience with the high numbers of patients, more than 1,000, and you can see the average 2-year CNS relapse rate between 1.9 to 4%. That's in average. However, those with the low risk, it's less than 1%. Intermediate risk is into the 2 to 3 or to 3.5%, and those with the high risk 10 to 12% risk of CNS based into the factors. So what other clinical markers also studied or reported? Extranodal site more than 3. It says that the risk of the CNS involvement may be a 15% or more, even that will be in a 10% of patients with diffuse large B-cell lymphoma, kidney, testicular, uterine, breast, and you can see there is also a higher chance of the CNS relax just only by having a single maybe extranodal involvement. That's in addition maybe to the other IPI. Other also biomarkers is the CMYC, and we know into the double or triple hit that will reach about 50% CNS involvement. Also the ABC, diffuse large B-cell lymphoma, 7 to 9, and the other CD5 also studies about close to 13% risk of CNS involvement. However, we are not maybe doing this or involve that into the risk stratification of our patient to estimate the risk of the CNS. This is one of the study, and this is from the Goya study also. They included the CNS IPI with the ABC cell of origin, and those patients who have both high IPI and ABC cell of origin, the risk of a CNS involvement up to 15%. Intermediate, either one of them about 4.4, and those neither high CNS nor the ABC cell of origin is 0.5. So is there a rule for the CNS prophylaxis? And that's the question I think important, and I will start with the intrathecal chemotherapy. So until this time, just to again state it to what was mentioned earlier, there is no randomized clinical trial either for any methods of the high dose methotrexate versus intrathecal among those with the CNS IPI. Most of the studies will be presented today are either a retrospective, single studies, or maybe again underpowered studies. So intrathecal, it was largely extrapolated from the patients with the Burkitt's lymphoma and lymphoblastic lymphomas. There is a pooled analysis, and that was used between 1960 and 1970s, and a pooled analysis of almost 974 patients from a French group, mainly with the GILA and H9, 3, and 8, They used this French protocol, which is the ACVBP protocol. In those studies, they were testing 3 versus 4 or 2 versus 3 weeks. The CNS prophylaxis was the intrathecal 15 milligram in day 1 and 5 of the first cycle, and also in addition to 2 courses of intravenous methotrexate. The CNS relapse 2.2. So, however, that's a pooled analysis, and we don't know if this is due to the intensification of the upfront therapy? Is it because of the high dose methotrexate? We don't know what are the factors in that study. Another study reported at 259 with a diffuse large B-cell lymphoma, 20 persons received intrathecal methotrexate, and the risk was 1.1. So those are the studies people, they might say there is a benefit from the intrathecal chemotherapy. However, this is a systematic review on the efficacy of the central CNS prophylaxis with a standalone intrathecal chemotherapy in a diffuse large B-cell lymphoma. And this is a 3 post-hoc trial analysis from the landmarks as the Recover, R-CHOP 14 versus 21, and the Goya, and 1 prospective database and retrospective series. So they collected more than 7,300 patients, analyzed. Almost 12 persons received just only a standalone intrathecal methotrexate. And the cumulative CNS relapse ranged from 1.9 at 6.5 years to 8.4 at 5 years, and 73, which is very important, in the parenchymal. So, and that's usually the debate, is that intrathecal will maybe reach the parenchymal brain lesions. So none of those studies showed a reduction of a CNS relapse rate with intrathecal by a univariate or multivariate analysis. So despite some report into the prophylaxis and the benefit of intrathecal, it's very difficult due to the retrospective nature of those studies, variability into the target population, number and timing of the dosing, and the concomitant delivery of intravenous high-dose methotrexate. So it will be difficult to see if it's, yes, working or not. So what about the intravenous high-dose methotrexate? Widely used, conflicting data on its efficacy, and I will just go through few studies. However, there is no randomized clinical trial yet in a high-risk patient. Different front lines in those studies in terms of the R-CHOP, R-CHIOP, ACVP, R-CODEX-MR, even for diffuse large B-cell lymphoma. So we don't know exactly if that reduction in a CNS rate was due to a controlling of a systemic disease or because of the CNS penetrating region. So we'll go first through the study that reporting a benefit from the high-dose methotrexate. And this is one of the studies was reported in 2014 where the about more than 200 patients, the risk factors were the extranodal sites, elevated LDH, or other extranodal sites as the bone marrow, breast, kidney, adrenal, paranasal sinuses. Even as a small study, but those patients who received R-CHOP plus intrathecal only, 49 patients. The CNS relax was about CNS involvement, almost 18 persons with intrathecal. R-CHOP, intrathecal, and 2 doses of high-dose methotrexate in 125 patients, the risk was 6.9. Those who used upfront, like R-Hyper-CVAD or R-CODEX-MR containing intrathecal or high dose, the risk was 2.3. However, that was just a small part. But I think one of the studies and clinical trials is evidence into the high-dose methotrexate came from the International Extranodal Lymphoma Study Group trials. And that's primarily was into the testicular lymphoma favoring a high-dose methotrexate. The initial study by the group was initially on a 373 patient. That was a retrospective nature. In those patients, because the rituximab was not available at that time, they treated with a CHOP or the MACOP or the PROMACE. However, the CNS relapse in those patients was about 15 persons. They received just only intrathecal. And the next study was in the limited, and it was a prospective study with the same group, that's the IELSG10. They included 53 patients. They used R-CHOP with the contralateral radiotherapy to other testes, plus just only intrathecal methotrexate. That was time 4. However, the risk reduced to 6 persons. With the latest trial, which is the SG30, again, 54 patients. They included also advanced stages. They added here also the intrathecal cytarabine plus the high dose methotrexate, and the CNS relapse was 0. So this is one of the evidences. It says that the high dose methotrexate working into the CNS prophylaxis. However, I think the testicular lymphoma is maybe different in biology from other extranodal disease. It will be difficult to go through all the studies, but just summarized here. So we've seen here a lot of the retrospective single center included between 200 to 140 and 60 patients. It says here that the risk with the high dose methotrexate was reduced, as in this example, those patients who received the high dose methotrexate with or without intrathecal, there was no CNS relapse compared to those who did not receive. Also into the other study reported in 2017, they used the high dose methotrexate 3 gram, median follow-up was 65 months. The CNS relapse in a high risk was 0 out of 24 with the high dose methotrexate. Those who did not receive a high dose methotrexate, the risk was 20%. So again, too difficult to interpret those studies given the retrospective and single center experience. On the other hand, there are multiple studies that says that there is no benefit from a high dose methotrexate. One of them is an international retrospective study in a patient with aggressive B-cell lymphomas and a high dose methotrexate. It was collected about more than 2,300 patients retrospectively, and they aim to see if there is a CNS reduction from a 10% to a 5% with the high dose methotrexate. And can see the inclusion criteria here. They included diffuse large B-cell lymphoma with IPI 4 or 6, high-grade B-cell lymphomas, breast and other extranodal involvement, and they excluded the CNS involvement at the time of the diagnosis or previously treated. In that study, about 33 patients were missing data for them, so they ended by having more than 2,200 patients. The CNS IPI 4 to 6, about 91%, R-CHOP given in 93, and you can see those with no high dose methotrexate, the risk was 9% in those patients, and those who received the high dose methotrexate was almost 8%. So in that studies, it says there was no differences. However, in the absence of the definitive data and the decision to offer prophylaxis should be personalized based to the patient. That was the conclusion in that study. Again, multiple studies here showed when they compared to high dose versus no high dose, it showed there was no benefit from adding a high dose methotrexate to a certain patient of a group. However, we have to take in consideration that each single center, they are using their own criteria for a CNS definition of risk definition for the relapse. So other prospective trials also intensified frontline combination, because we have to make this distinction between controlling the systemic disease and isolated CNS involvement. Because if you have a systemic with a CNS involvement, it means that this is a failure of a systemic control rather than this is just only isolated CNS involvement. And in this study, you can see a CHIOP 14 with 6 intravenous high dose methotrexate. The risk was about 4.5% in this group. This is another study also including the R-CHIOP with the intrathecal liposomal ERA-C and also a high dose methotrexate, and the risk of the CNS progression 2.3%. This is another upfront protocol intensification using the SEP, that's the French protocol as mentioned previously, compared to the CHOP. So there is a reduction. So is that because of the upfront induction therapy, or this is because of the high dose methotrexate? The same for this is the last maybe studies was reported with this regard with the intensification by Macmillan and the CNS IPI score 3 to 5. They used the R-Codex MR. the risk was 3.6%. So what about the timing of a high-dose methotrexate delivery? This is reported and published this year in the Blood by Wilson, and I think that was presented in one of the ASH meeting in the 63rd ASH meeting, where they reported the experience of 1,384 patients retrospectively collected with a multi-center international, and they divided them to those who received a high-dose methotrexate during the chemotherapy. We call them intercalated or alternating with the high dose with the R-CHOP, or at the end of the therapy they received the 6 cycles R-CHOP and then they started to get a high-dose methotrexate and there was no differences. This is still, that gives maybe for those, because the concern usually with giving the high-dose methotrexate with the R-CHOP is the risk of toxicity and delay also of the R-CHOP, which is the upfront therapy. In that study, they found about a delay of 7 days or more of R-CHOP was in about 20 persons who received the intercalated high-dose methotrexate, during the R-CHOP chemotherapy. So challenges for evidence for CNS prophylaxis is the heterogeneity of the diffuse large B-cell lymphomas, variable risk assessment for CNS involvement, multiple methods of CNS prophylaxis, relative rarity of the CNS relapse, and numerous small and unpowered observational studies. Selection bias, also a patient receiving a CNS prophylaxis tend to be younger and different also from those with no CNS. And there is, I think this is a loss of aversion, which I think as a clinician, we are concerned or maybe an anxiety from losing that thing and comparing to a pleasure from again. What I mean is we received or we perceive that the risk of not treating a CNS relapse has often outweighed the lack of evidence regarding this, because still with all these data that we know, we still considering high-dose methotrexate, and I think I wouldn't say maybe you are treating ourselves, but it's a concern about having this maybe as a complication for those patients, knowing maybe the poor outcome. This is a proposed algorithm by Kerry Savage, was published in 2017. Those with the low risk group, no need to do a CNS screening or prophylaxis. With the intermediate also, no need, except with a certain extranodal involvement like testicular, adrenal, uterine, or those with the CMEC positive. Those with a high risk, it should undergo routine CNS diagnostic, and prophylaxis should be given for those patients. So this is just introduction about the CNS, where we are. That's a kind of introduction to our experience, and this is the outcome of high-dose methotrexate in our population. We just wanted to know how are we doing also compared to what was reported into the literature. So the aim was to determine the outcomes of a high-dose methotrexate CNS prophylaxis in the intermediate and high-risk people only. So we've excluded all the low-risk using a real-world data from our center. So this is done over a 10 years retrospective study. We included those with the biopsy confirmed diffuse large B-cell lymphoma. The definition of the adult in our country is 15 or more. That's why we are including a 15 years. Intermediate to high risk IPI only. We excluded double and triple hit Burkitt's lymphoma. We've excluded also those with the CNS involvement at the time of the diagnosis. So a high risk group in our patient was defined as those who had a testicular lymphomas, epidural disease, sinus involvement, bone marrow, renal and adrenal. Those are the patients we are usually considered to give them a high dose methotrexate if the CNS workup is negative. However, if it's positive with the MRI or flow cytometry in the CSF, we treat them as the CNS involvement. And the prophylaxis we are giving is the high dose methotrexate, 3.5 gram per meter square, and on a day 10 and 15 post R-CHOP, following a completion of chemotherapy for a 4 to 6 cycles. So we are giving it as intercalated for most of our patients. Try to give it after cycle 2 and 4, and to give maybe 2 more 2 to 4 more. Sometimes intrathecal was used, considered in a synchronous and early CNS relapse based into the physician discretion, but those patients were excluded, were not. So 358 patients meeting the criteria with just only intermediate and high risk according to the CNS IPI. And CNS prophylaxis was given to 32 patients, which is a small number, and 326 did not receive. If you see the maybe the differences into the baseline characteristics, you can see those who receive the CNS prophylaxis tend to be younger compared to the patient who did not. Also extranodal site, as you would expect, 93 compared to 64, because we are considering those testicular and other patients. And also the stage of the cancer was advanced stage in 90% compared to the non-high dose methotrexate, abnormal LDH also. And most of our patients here, like a 50-50, were a high, according to the CNS IPI, either high or intermediate. So a 10 CNS relapses only detected in that 358, which is lower compared to other series. But however, that's also comparable if you see the UK NCRI data for more than 2,000 patients. They have the same, maybe almost 2% of those patients. And interestingly, those patients who received the high dose methotrexate, they had more CNS relapse. So 12.5% compared to 1.8 in those with a non-CNS prophylaxis group. So is that because we are selecting a very high-risk patient? Is it that will put up also a question about the efficacy of a high-dose methotrexate? But in this thing, we don't have a comparative arm, especially in that group, saying those patients who high received high-dose methotrexate versus no high-dose methotrexate. So is that 12.5 reduced from a higher number, or this is seems that there is no benefit from the high-dose methotrexate? You can see here the differences into the relapse rate between the two groups was statistically significant between the patient who received the high-dose prophylaxis compared to those who did not receive. The 10 patients who had, in general, tend to be advanced stage. Non-GCP was in about 70%, high CNS IPI and 70%, and those are just the clinical characteristics. This is the overall survival post-CNS relapse, and that's also in alignment with what was reported. The median time to a CNS was 8.5. So it's also those patients who had a CNS relapse had it within the first 6 to 9 months, ours 8.5 months. The median overall survival post-CNS relapse was 8 months. So a very devastating complication for those patients. In any univariate and multivariate also analysis, the only factor was of a clinical significance is the systemic relapse into the univariate and multivariate, but the other as the CNS IPI and CNS relapse and stage of the disease did not have that significant or did not maintain the significant into the multivariate. So this is the overall survival for the whole group. Those are the patient no relapse, and you can see those who had relapse disease for sure, they will have a poorer overall survival compared to those with no relapse. Progression-free survival for the entire cohort, we have 59 patients, 20 persons, which considered to be good also as a failure from the systemic therapy. The median time to the systemic relapse was about 18 months, and you see the median progression-free survival was not reached. So strength and limitations. This is relatively a large sample size of 358, just only intermediate and high risk group. Limitations, it's for sure a retrospective design, lack of a comparative group to those received the high dose methotrexate, and lack of CNS assessment for all the patients at the time because they had this intermediate or high risk group. However, I think if I will take it in the positive way that now we had many patients intermediate and high risk they did not receive high dose methotrexate, which also concur with the with what was reported, that not everyone on CNS IPI, intermediate or high risk, they should receive a high dose methotrexate. So in a conclusion, a prospective data on a risk estimation and benefit of CNS prophylaxis are needed for sure. We have to focus on integrating a molecular like the APC, the clinical risk factors, including the extranodal, CNS IPI, to identify those with a high risk patient. Maybe expanding into the ultra-sensitive technology as the circulating DNA or the MYD mutation testing for the CSF to maybe detect initial occult CNS involvement. And there have been a few studies on this. A reduction of the CNS dissemination by using active agent against diffuse large B-cell lymphoma with a good CNS penetration. Also a reported experiences from different centers into the lenalidomide BTKs. A novel approach of management of the secondary CNS lymphomas as CAR T-cell that might also change the game. So that's why I was saying I wish I can start with the conclusion, because at the end we still, that question was not clearly answered and that chapter was not closed. Thank you so much.
Thank you, Dr. Mubarak. Great presentation on difficult area, with no agreement on the management or on CNS prophylaxis. So I think we can take first question.
Great job. Complicated topic. How do you approach a patient that has a high CNS IPI? Do you get an MRI and a lumbar puncture on any patients prior to starting systemic therapy, or do you just forego those sorts of workups? Do you tailor any CNS workup to patients you perceive to be at higher risk?
So if they have one of our criteria for the CNS risk definition, which is the testicular sinuses, we are doing MRI and CSF flow cytometry for all these patients. But I was saying in this study, because all intermediate and high risk, by a CNS IPI, we did not do it for all the patients. So just only those who are fitting or meeting the criteria for a CNS prophylaxis. But yes, we do it for all the patients.
So is it possible that those patients with intermediate to high risk may have some biomarker in the CSF or something detectable by MRI? In other words, how can you identify? Because even if you have high-risk disease, it's only maximal 15% chance risk.
Yeah.
And so is there something that you could look at in the CSF or the MRI in those patients beforehand that say, oh, these patients are at even higher risk because you found a clone, you found some gene, and in those patients when they have more minimal disease, you implement the CNS-directed therapy earlier.
Yeah.
And maybe thwart the possibility of relapse down the road.
Yeah, I think that's important. What we are doing the CNS workup initially for those patients, not to already the decision made that they will receive a high dose methotrexate is the question, 3.5 gram or 8 grams. But I think a step ahead of that should be, as you mentioned, do we have to give them that CNS prophylaxis if they have a negative CNS involvement by MRI or the flow cytometry in the CSF?
I'm also not sure that Aracene isn't a better drug. That we use a lot of methotrexate, but when I've had these complex cases with problems that fail methotrexate, I've seen really great results with Aracene. I know that in the CNS lymphoma world, combinations of methotrexate and Aracene, which there's potent basis for synergy, are probably better than other than alone.
Thank you very much, Dr. Mubarak. Now we'll go for our next speaker. He will be virtual. Professor John Ribbon. He's from Barts Cancer Institution, Queen Mary School of Medicine, University of London. So we are waiting when he will be online.
ما يكتب.
John Rebel, do you hear us?
Yes, I hear you. Thank you. Yes.
Let me introduce you to the audience. Prof. Rebel, he is a professor of Gordon Hamilton Fraley Chair of Medical Oncology in Parkes Cancer Institution, Queen Mary University of London. His doctorate was performed in the University of College of London as a recipient of College of Trust and Fellowship Award, as he continued his postdoctoral training at the College of Fellowship with Fogarty Fellowship in Dana-Farber Cancer Institution and Harvard Medical School. Thereafter, he was appointed to Faculty of Harvard Medical School, where he was associate professor of medicine and attending physician in Dana-Farber Cancer Institution in Brigham and Women's Health Hospital Unit. His primary research in MRD, lymphoma, leukemia, CAR T-cell, and identification of B-cell tumor antigen. He was also serves in executive board of EHA and past president was president of EHA from 2019 to 2021, and he has a founding member of CLL Research Consortium and was associate editor of Blood from 2007 and 2014. And his next talk today will be on current management of relapse and refractory CLL. Prof. John, welcome. And the mic is yours.
Thank you very much. Salam alaikum. Thank you for the invitation to be here. Sorry I can't be there in person, but this is modern life. So as you heard, I've been asked to talk about treatment of relapse and refractory CLL. Here are my disclosures. The key learning objectives are how do we, in the modern era, select the correct treatment for our patients with relapsed and refractory CLL. So we have guidelines on how we treat patients now frontline, which of course is not the topic of my session, but of course how we treat patients at the time of relapse entirely depends upon how we treat them in the front line. And what you'll see is in the modern guidelines, there is very little room for conventional chemoimmunotherapy, although many of our patients in the past will have had chemoimmunotherapy and then relapse. But you'll see nowadays our decision is between continuous therapy with a BTK inhibitor or a fixed duration therapy with ibrutinib and venetoclax largely. For those patients that have TP53 mutations, of course, who used to have a very poor prognosis, those patients invariably treated now with novel agents. The evidence for suggesting we use novel agents rather than using chemoimmunotherapy comes now from multiple phase 3 trials, all of which have demonstrated the advantages of here BTK inhibitors versus chemotherapy in frontline therapy. The Illuminate trial looks at ibrutinib and obinutuzumab compared to chlorambucil obinutuzumab. The Alliance trial looks at either ibrutinib or ibrutinib plus rituximab versus bendamustine rituximab. The ECOG trial compared ibrutinib plus rituximab with what had been our standard of care for patients, that is with FCR. And the Elevate trial compares chlorambucil obinutuzumab with either acalabrutinib alone or acalabrutinib plus obinutuzumab. And what you'll see in each of these studies is that there is a progression-free, and for several of these studies, notably the ECOG trial, and also an overall survival advantage for the use of these agents in frontline compared to chemoimmunotherapy. We, of course, have two approaches that we use in terms of using the novel agents. We can either use continuous therapy with BTK inhibitors, either ibrutinib or acalabrutinib, and increasingly now also we have access to zanubrutinib. Or we use fixed duration therapy with venetoclax plus an anti-CD20, or with now ibrutinib plus venetoclax, for which we now also have licensing approval to use this combination. I think it's important to always try to assess the optimal use of these approaches and how we can select the right treatment for the right patient, and that's what I want to spend a little bit of time talking about with you today. Now, we know very well in CLL we have a balance between proliferation, which is driven through the B-cell receptor signaling pathway, and which are targeted by BTK inhibitors and by PI3 kinase inhibitors. And we have this process in CLL of very high levels of BCL2, which leads to resistance to apoptosis, which of course are inhibited by BCL2 inhibitors, notably venetoclax. The benefits of BTK inhibitor therapy come from continuous therapy. And without going into the detail with you in detail, we see worse outcomes in those patients who have therapy breaks or early discontinuations. Now, we know now from having used these BTK inhibitors for more than 10 years that they do have acceptable side effect profile, although there are some side effects that do occur. But importantly, we do not see any increase in the side effect profile over time. So therefore, when I've got a patient with a BTK inhibitor, my main issue is to try to support the patient throughout their treatment and not to interrupt or change the therapy prematurely. So our ESMO guidelines for the treatment of relapsed and refractory CLL are, of course, in the majority of cases, we can continue to follow the patients until they become symptomatic. That is, when a patient relapses with CLL, it's not necessarily an indication for treatment. We would follow a watch and wait approach with the relapse disease in the same way we do with CLL in the front line. And again, we consider whether patients have TP53 mutations or not. And then the next thing we consider is how long was the duration of remission between their last therapy. And of course, the other factor we have to consider, as I already mentioned, is what was the frontline therapy that they had. And again, you'll see in this setting, almost all of these boxes are filled with novel agents and chemoimmunotherapy having a very limited, and I would argue now, no role to play in the management of relapsed refractory CLL, and I'll take you through that data now. So the selection of treatment for relapsed refractory CLL depends entirely on what was the treatment the patient received for in the past, what was the duration of response that they received, what are the side effect profile they had with the treatment, and what are the comorbidities that that patient has in terms of thinking of what other treatments they can have. We then have to consider the status of the disease. I'm talking now here about not only things like TP53 abnormalities, but also what I've mentioned before, which is watching and waiting these patients until they progress. Increasingly, it's important to consider the wish of the patient. In other words, what does the patient want to consider in terms of the various options you have available? Even, I have to say, in Saudi Arabia, you have to consider the financial considerations. These patients are going on potentially continuous long-term therapy with many of these agents which have financial considerations. We have to consider what are the agents which are approved locally for your own local. And then, of course, the last thing to consider is what is your own experience of using and handling these agents in terms of managing that patient you have in front of you in terms of considering their treatment now. So let's look now at what is the data we have in the setting of relapsed refractory CLL. Now here's the results from the RESONATE trial. This was the trial which led to the approval of ibrutinib in the setting of relapsed refractory CLL. And we've now got very long-term follow-up in this setting. And you'll see here that the progression-free survival of our patients with relapsed refractory CLL treated on the RESONATE trial is shown here with now follow-up going out beyond 6 years. And you'll see this is vastly superior to the comparator arm. The thing we also have to remember when we look at the RESONATE trial is that the median lines of therapy that were on this trial were 3 or more lines of therapy for the vast majority of patients. We have good data that tells us that the earlier we treat a patient with ibrutinib, the better the outcome would be. So nowadays, if we're talking about first relapse and we're considering using ibrutinib, I would consider we would achieve very much better outcomes that we're seeing here. The other feature which is very clear is that unlike chemotherapy, ibrutinib and acalabrutinib are able to overcome the poor prognostic feature associated with 17p deletions or TP53 mutations, which of course you'll be aware occur with increased frequency in the relapse refractory setting than we see compared to frontline patients with CLL. This is the issue that I mentioned before. We've now got very long-term follow-up on the RESONATE trial, giving us good information on the side effect profile. And what's not shown very clearly here is this is the side effects which occur each year in each subsequent year. And you'll see that the side effect profile is generally low, but there's, with the exception of hypertension, which has to be looked for, none of these side effect profiles increase over time. There are issues like atrial fibrillation and hemorrhage which have to be considered, but these are rarer side effects with these classes of drugs, but something that has to be remembered. But the important fact to remember is the side effect profile does not increase over time. Here's the data looking at acalabrutinib in the relapse refractory setting. I showed you earlier on the results in the frontline setting. This is using acalabrutinib compared to either BR chemotherapy or idelalisib rituximab. This is one of the few clinical trials which has compared head-to-head acalabrutinib compared to a PI3 kinase inhibitor, which you'll see leads to an improvement with a BTK inhibitor. But also we see here the very significant improvement in outcome receiving acalabrutinib compared to bendamustine rituximab. Again, for me, a good reason to believe that in the relapse setting, we would not use chemotherapy, but instead use a novel agent. There are now a number of studies which have looked at the outcome of ibrutinib compared to, in the ELEVATE study, compared to acalabrutinib, showing that basically these two agents are very equivalent in their activity. Some would argue that the side effect profile with acalabrutinib is slightly better. I would just say that the side effect profile is slightly different, but there are some side effects which appear to occur with a lower frequency with acalabrutinib, notably atrial fibrillation. Here's the data also on the head-to-head trial in the Alpine study of zanubrutinib compared to ibrutinib, demonstrating again that perhaps a slight improvement in outcome, but I'd point out the same thing happened with acalabrutinib earlier on, which then disappeared with longer follow-up, so that needs to be followed up. And again, the suggestion that zanubrutinib is at least equivalent to ibrutinib, but may be associated with a lower side effect profile. So what do we do, however, for those patients who have received ibrutinib or a BTK inhibitor as their frontline therapy? Well, then we're talking about moving on to using a venetoclax combination, and here in the relapse refractory setting, we have the Murano trial, which tells us what we can expect in this patient population. This was a multi-center phase 3 trial randomizing patients to receive either bendamustine rituximab or to receive venetoclax in combination with rituximab. Now, in this study, the venetoclax starts first with the ramp-up, then the introduction of rituximab, and that rituximab continues for 6 cycles. Then there's a 2-year fixed duration therapy, 18 months of which after we complete the rituximab, and then the patients stop and then go on to observation. We've now got quite long-term follow-up demonstrating a very significant progression-free survival for venetoclax rituximab compared to what had previously been our standard of care with bendamustine rituximab, and that is sustained from that timely endpoint. So here is the time at which the patients stop with venetoclax, and you'll see that in this analysis, the 3-year, 4-year, and 5-year estimates show very significant improvement in progression-free survival of this therapy, even though the patients are off therapy at this point, compared to what we see with chemoimmunotherapy. Again, part of my argument is why I no longer offer chemoimmunotherapy, because we have clear data that both venetoclax rituximab as well as acalabrutinib is associated with improved outcome compared to chemoimmunotherapy. That progression-free survival benefit, I'm sorry this slide is small and so busy, but the important thing is here, which is that there was no difference in any of the prior subgroups of the two groups here, demonstrating that in every subgroup that we look at, there is an improvement in outcome. I'm so sorry, I should have switched this phone off. This progression-free survival was maintained in patients who have TP53 mutations. We see that a slightly less good outcome for those patients with TP53 mutations using venetoclax rituximab compared to those that don't, but both arms very significantly improved over ER, and the same is true by the immunoglobulin mutational status. There is some data suggests now that those patients who have mutated immunoglobulin genes have better outcome in terms of the relapse refractory treatment compared to those who are unmutated, but again, both arms very significantly improved to that seen with chemoimmunotherapy. The important finding from the RANO trial, I think, in my mind, is an overall survival advantage. So for those people who thought that maybe I could give BR first and then follow it with venetoclax, rituximab, the data against this is that we see an overall survival advantage in this. That's maintained at that 2-year, 3-year, 4-year, and perhaps even wider at the 5-year estimate in terms of how we look at this patient population. And of course, when we do a randomized trial and we see an overall survival advantage, in my mind, this is the clearest evidence why we should be using a novel agent rather than chemoimmunotherapy in this setting. Now, the landmark analysis and of course how we're able to stop therapy is that we see that those patients who are MRD negative at the end of treatment have a very much better outcome than those who are MRD positive. And that's true in terms of progression-free survival and now also in true of overall survival. So whereas it's true to say that the patients who are MRD negative do better, where does that leave us in terms of what we do in those patients who are MRD positive? Well, I have to say that given that even some of the MRD positive patients can have quite a long progression-free survival, I continue to observe these patients off therapy and look to offer them salvage therapy at the time of progression of disease, again when they need next line therapy later. The side effect profile associated with the venetoclax rituximab was very favourable. There is a signal of neutropenia, but the neutropenia associated with venetoclax rituximab very different from the neutropenia that we see in patient populations receiving bendamustine rituximab, very sensitive and very responsive to the use of growth factors and not associated with any increased risk of febrile neutropenia. But what about other approaches we can have? Well, I've already mentioned we now have licensing approval for ibrutinib used in combination with ibrutinib. I'm showing you here the results of the Clarity trial, which is the trial that we did in the UK, looking at using this combination. Now, this particular academic trial uses MRD endpoints as the study end, but the design of the study is not too dissimilar from how we're using this by its license. That is, we start the patients on ibrutinib, which they receive for 2 months. Then we add in the venetoclax and continue that therapy. And in the GLOW study and in the licensing approval, at the end of that 1 year of fixed therapy, we stop. In this academic trial, we continued to monitor their MRD levels, and we continued the treatment based upon negative. And in this trial, we can see that by following the MRD, we see that those patients who have a rapid response and become MRD negative quickly are those patients who have the very best outcome. But even those patients who are MRD positive tend not to become MRD negative, but we can continue to see the levels of the disease continue to drop for a longer period of time also. The outcome we see in these sorts of combination trials appear really excellent for a relapsed refractory patient population. You'll see here the progression-free and overall survival. Now clearly this is only with 3-year follow-up and longer follow-up is required, but these are really outstanding results to see in our groups of patients. What do we think with CLL? Well, one is the use of pirtobrutinib, the LOXO 305 from the Bruin study. This is a novel PI3 kinase inhibitor, a BTK inhibitor, which works in a very different way from ibrutinib, acalabrutinib, and zanubrutinib. And what you'll see here is that we see very high response rates even in those patients who have been refractory to a previous BTK inhibitor, and even in those patients who progressed on BTK inhibitors. So what we do see here is that we know that pirtobrutinib is able to overcome the defects, the ability the inability of these patients to respond anymore to standard BTK inhibitors. We know that we have durable disease responses, and perhaps that's due to more of the B cells. We're looking at how ibrutinib can modulate immune responses. We see also that ibrutinib does have effects through ITK that, and can restore T cell function. So a feature that ibrutinib seems to be able to have is to restore that function, which of course leads us on to where I think we're going next in terms of relapse refractory CLL, which is CAR T cells. And we see in the lisocabtagene maraleucel studies, which I think is going to be the first product licensed and approved in CLL, that we do see very refractory patients able to respond. And we see that when we add in ibrutinib into being able to collect the CAR T cells, we look as if we're able to see even better outcomes. In summary, at the very last slide, I promise you, novel agents have replaced chemoimmunotherapy in the treatment. We have choices, continuous therapies, fixed duration antibodies, or fixed duration combinations. Ibrutinib modulates the impaired response. There are novel agents on the horizon. So if you have a patient who received a BTK inhibitor frontline, we move them to venetoclax. If you've got a patient who received frontline with venetoclax, we move them to ibrutinib. If they've had chemoimmunotherapy, you have choices. With that, I'd like to thank you very much for your attention, and sorry if I overran my time. Thank you.
We have questions now that are open for any places. Thank you, Dr. Griffin. Very nice presentation. Just I want to ask about if you start ibrutinib as a first line, how frequent do you see refractory cases to ibrutinib, and what you will do in this scenario?
Sure. So I think that's a very good question, the one I didn't have time to go into in the presentation itself. I think the majority of patients that we see coming off BTK inhibitors are coming off because of intolerance rather than true progression. In my experience, the number of true progressors on ibrutinib is quite small. We always look for the mechanism of resistance, and of course we do see the C418S mutation occurring in perhaps a minority of cases. But it is a special circumstance of a patient who progresses on not just ibrutinib, but any of the BTK inhibitors. What we know is if we stop the BTK inhibitor, these patients are likely to progress very, very rapidly. And whereas I mentioned before that most patients can be watched and waited, I think an exception is a patient who progresses on ibrutinib. My approach is to continue the ibrutinib, and then I look to start their venetoclax. I actually overlap the therapy of the ibrutinib with the venetoclax until I've got them onto the 400 milligram dose, and then I discontinue the ibrutinib. The reason for doing that is, as you mentioned, we see very rapid progression if we stop the ibrutinib in these refractory patients. The more disease they've got, the more we've got a risk of tumor lysis when we move to venetoclax. So that's my approach to handling an ibrutinib resistant patient.
Thank you.
Thank you for the nice presentation. Significant progression in CLL lead multiple options for the patient. I'd like to ask about the concept of curing CLL nowadays, where we are.
Yeah, it's a very, very good question. We tantalizingly close in some subgroups. I think I think where the cure is going to come from CLL, of course, is not going to be in the relapse refractory setting, perhaps, but in the looking at the frontline setting. Looking at that data, I think obviously we need very much longer term follow-up than we have. But mutated patients, I have and many other people have, patients who are now 20 years in remission and MRD negative following FCR chemotherapy in that subset, and I believe that some of those patients are already cured. The outcome of using venetoclax plus obinutuzumab in patients with mutated immunoglobulin genes is still incredibly high with the follow-up we have. We clearly need longer-term follow-up, but it's possible that some of those patients have had eradication of MRD disease and may well be cured, but we need longer follow-up. We're hoping very much that the use of the doublet or even the triplet combination, that is using a BTK inhibitor plus venetoclax plus or minus obinutuzumab, is going to lead to complete eradication of MRD and potentially cure in some of our patients. Now, I can't say that yet. We don't have sufficient follow-up from these studies to be able to say this, but studies like GLOW and Captivate have patients in whom we're now 3 and 4 years out from initial stopping their therapy, in whom these patients remain MRD negative, and time will tell whether any of these patients are cured. Similarly, I think CAR T cells do have the potential of inducing very long-term remissions. And of course, at UPenn, where they started this approach in Philadelphia, they've now got relapsed refractory patients almost 15 years from when they had their CAR T cells still in remission and still MRD negative, so suggesting that could be a potentially curative approach. Last, of course, we've got allogeneic stem cell transplant, which I didn't have time to go into talk about today, something we do less and less in CLL than we did in the past, but also potentially I've got patients that I did an allogeneic transplant on 30 or even 40 years ago now, who still in remission and whom we hope are potentially cured. So I think at the moment, I don't offer any therapy to my patients telling them that I hope it's with curative intent. I tell them we still don't know if we're able to do it, but I think things are getting tantalizingly close.
Thank you. Last question on the
Thank you very much for the lecture. Just have a question regarding MRD positivity. So, as we are all aware, there are multiple trials looking at tailoring therapy based on MRD positivity or the frontline relapse. But outside clinical trial, the clinical work, do you treat patients differently based on their MRD positivity? Do you tailor therapy at some other drugs on the combination?
Sure. I've got to say, I mean, again, excellent question. I am inside clinical trials. We do MRD monitoring on all of our trials, and we're looking to tailor the therapy. Outside of clinical trials, I often will perform the MRD analysis for the patient because I think it gives them prognostic information that's useful for them to have. But I am not treating patients on the basis of MRD positive disease outside the setting of a clinical trial for the moment. Not least because of course, for the combinations that we have that are able to get patients MRD negative, like venetoclax plus rituximab or venetoclax plus obinutuzumab, the licensing approval is to use it in fixed duration. So my approach remains to use this in a fixed duration way, and to stop the therapy, monitor the patients, and continue to monitor the patients without interrupting their therapy on the basis of their MRD analysis. So outside of a clinical trial, I am not treating MRD positive disease.
Thank you very much, Prof. Gribben, for this brief and conclusive, comprehensive lecture. And we hope to see you soon, hopefully here in Saudi Arabia. And welcome anytime.
Thank you very much. Okay, bye-bye.
Thank you, bye. Now, next speaker will be also virtual, will be Prof. Greg Moskowitz. Welcome to Prof. Greg.
Hi, good morning.
Yeah. Let me introduce you. Prof. Greg is Physician and Chief Oncologist Therapist, Line and Sister Comprehensive Cancer Center, Professor of Medicine, Division of Rheumatology, University of Miami Health System. He has been academic career in research and improving outcome of the patient with poor-risk Hodgkin lymphoma and diffuse large B-cell lymphoma. He's spent practice 26 years old at Memorial Solon Kettering Cancer Center in New York, and he was directed the division of hematology oncology and had independent chair of lymphoma research. And his talk will be today the approach of interim PET positivity in advanced stage of classical Hodgkin lymphoma. The mic is yours, Dr. Prof. Craig.
Well, thank you for having me. Let me just fix this. I'm going to take a little liberty with the title and talk about advanced stage disease and add a few additional information on relapsed patients. I think that here are my disclosures. I have research support from a number of companies, and I'm on the scientific advisory board on these that are listed. So questions I'll talk about are the 5-year Echelon 1 results convincing to consider BV-AVD the standard of care for advanced stage Hodgkin lymphoma? What's the optimal management of patients who are older than 60? And importantly, what is the impact of primary treatment as that changes on second-line therapy? So how do you treat advanced stage Hodgkin lymphoma? First, many of the studies include poor risk early stage disease, stage 2A and stage 2B. And I want to remind everybody that's not advanced stage Hodgkin lymphoma. As far as what I learned, it's stage 3 and 4 disease. For example, the Rathel study, 40% of the patients had early stage disease. So do you give ABVD times 6? Do you use escalated BIACOP? Do you give BV-AVD? Do you do PET-adapted therapy starting with ABVD? Or do you do PET-adapted therapy starting with escalated BIACOP? So I can't say that there's been significant updates in any of these studies. They may be at the Cologne meeting in a few weeks. But if you look at the starting with adapted treatment, in the U.S. intergroup study, in the Rathel study, early on at 2 and 3 year follow-up, about, let's give or take 80 to 85% of the patients have done well in the first curve. I will say that we updated the SWOG data, and pretty much that information is about 76 to 77% of patients are doing well. The numbers have come down. What is interesting, though, is that in patients with PET-avid disease, in general, with changing therapy to escalated BIACOP, give or take a few percentage points, about 62 to 63% of patients are doing well. So in patients, if you're going to do PET-adapted therapy and the PET scan has a Doble score of 4 or 5, it's not appropriate to continue ABVD. The plan, of course, would be to change to escalated BIACOP, and there's upwards of a 2 out of 3 chance that those patients will do well. I will say I don't do that anymore. A number of years ago, I was practicing that way. The French have done the flip, where they've started with escalated BIACOP for 2 cycles, and in patients with PET-avid that were PET negative, they crossed over to ABVD, and there's pretty long-term follow-up in this data set, and about 84 to 85% of the patients are doing well. I was doing this particular treatment for a number of years in patients with 3 to 7 risk factors. I've also stopped doing this treatment. I'm not a big fan of escalated BIACOP. I think everybody needs to get transfused. The patients are pretty miserable, and there are better treatments. People ask me all the time, should one give radiation therapy for patients with bulky stage 3 or 4 disease? There was never any evidence that that improves survival. I think this is an excellent paper from the Italian Lymphoma Study Group, where they looked at consolidative radiation therapy in patients with advanced stage disease. If you concentrate on the right panel here, everybody started with ABVD, and if the PET scan was negative after cycle 2, and negative after cycle 6, then it was a randomization for patients with a single nodal mass of at least 5 centimeters to no further therapy or to consolidative radiation therapy. And you can see that all the curves are the same based upon the size of the mass. So there is absolutely no role for radiation therapy in patients with advanced stage Hodgkin lymphoma who are PET negative after standard chemotherapy. So the dilemma in therapy for Hodgkin lymphoma, however, is that it's clear escalated BIACOP improves progression-free survival over ABVD, but is much more toxic. And BVAVD, which we'll discuss now, as far as toxicity, falls somewhere in the middle. Is BVAVD the standard therapy now in the US? First, I want to digress and say that in patients who are PET2 positive, when you start off with ABVD and switch to escalated BIACOP, there's absolutely no evidence that you should switch to either BVAVD, Pembro-AVD, or Nivolumab-AVD. No evidence. That is not something that should be done. If you're going to do PET-adapted therapy and you're starting with ABVD, and the PET scan is positive after cycle 2B, then patients should get escalated BIACOP. So this is the Echelon 1 study, well-designed study, not my favorite study, but well-designed. Everybody either got 6 cycles of BVAVD or 6 cycles of ABVD. There was a number of PET scans that were done. Scores 4 or 5 were considered positive. There's a lot of CAT scans and PET scans done for a number of years thereafter. And as you know, this was originally published in New England Journal of Medicine a few years ago and was most recently published again. It's a very well-balanced study, and you can see it's only for patients with stage 3 or 4 disease. So by definition, the results with ABVD are going to be probably not as good as they were in the Rathel study, because that study had more patients with early stage disease. What's also very interesting is that if you look at the PET2 status, less than 10% of the patients were PET2 positive. That's in contradistinction to a number of other studies where upwards of 15 to 20% of the patients are PET2 positive. And what has happened as we've moved along now at 6 years, and I will say that I was pretty shocked at this, there has an overall survival advantage with BVAVD over ABVD of about 4.5%. Now, quite frankly, there have been a lot of folks out there that were resistant to change from ABVD to BVAVD based upon endpoints that were either modified progression-free survival or progression-free survival. But at this particular point, I think the question is answered. There's almost no studies in Hodgkin lymphoma that I can think of, other than going back 25 years ago, comparing escalated BIACOP to COP ABVD, neither of which we're giving, that shows an overall survival advantage. So here we have one. And from my point of view, this is level 1 evidence that BVAVD should be used as standard of care in patients with stage 3 or 4 disease. There's a benefit in all groups based upon the forest plot. This is the progression-free survival curves. And what's very interesting here is if you look at the ABV arm, it's at 74.5%. Well, that's exactly the data which is in the SWOG U.S. intergroup study at 5 years. So remember, as when you're treating advanced stage disease, the results of ABVD will go down. As far as deaths on study, there are more deaths from lymphoma on the ABVD arm, and the side effect profile is about the same. As far as toxic death, of no surprise, in general, patients were able to be salvaged with either regimen. There were fewer secondary malignancies on the BV-ABD arm, but what's very interesting is that the most common malignancy in the ABVD arm is diffuse large B-cell lymphoma. Many people were concerned about pregnancies after BV-ABD, and whether you believe this data or not, it seems clear to me that both BV-ABD and ABVD at worst are the same as far as live births thereafter. Obviously, there's more peripheral neuropathy with BV-ABD. These are my conclusions of this program. Others may have different conclusions. It's the first regimen to show an overall survival advantage over classic ABVD. Despite, and surprisingly, with all of the salvage therapies that are available, there's still an overall survival advantage, even with checkpoint inhibitors. There's fewer second malignancies, stable pregnancies, peripheral neuropathy is improving, and I believe it should be standard of care. Now, we have some newer treatments out there. One is Nivo-AVD. This is the original phase 2 study, which was published in the JCO, which has never been updated, which was induction nivolumab for 4 cycles and followed by 6 cycles of Nivo-AVD. The curves are okay. They were coming down. I would have been interested to see if there were late relapses, but once again, not updated. This is the data from Emory and Northwestern, a very small study of Pembro-AVD, where there was induction pembrolizumab, followed by AVD with a PET, and then more AVD. And according to this group, all 30 patients are in stable remission. As you may or may not know, almost finishing is the United States intergroup study of BV-AVD versus nivolumab and AVD. We've put about 20 patients on this at Miami. All of our patients are doing well. As of last count, I think there were about 900 patients on the protocol. How do I treat advanced stage Hodgkin lymphoma? Well, I enroll patients on the national study. Off protocol, I give BV-AVD for stage 3B and 4 patients. I think for I think for patients with stage 3A disease, these patients have no IPI risk factors. I still like giving PET-adapted therapy. For patients older than 60, I'll show you some data in a minute. I do not give standard BV-AVD. And let's remember that even though the topic of today's conversation was what to do with PET-adapted therapy, we now have an overall survival advantage with a program that's not PET-adapted. So this was a recent update of the Pembro-AVD study with some correlatives, longer follow-up, just showing that this program has durable remissions. What I found very interesting, and I'm sure you know, I got pembrolizumab approved internationally for Hodgkin lymphoma, and in the relapsed and refractory setting, and we saw a 28% CR rate. This is the data looking at single agent pembrolizumab, 3 doses in the untreated setting, and one can clearly see that the CR rate is really very high in the untreated setting, based upon the plot on the left. And nearly every single patient responded. And there was responses also in patients with tumor bulk. And this is, of course, associated in advanced stage, as I'm sure most of you know, is enriched for the 9p24 genetic abnormality, which defines the role of checkpoint inhibition in Hodgkin lymphoma. Here's the updated information up to 3 years now in this study. I like this particular study. I don't know where it's going. I think there's an industry study being led by Merck comparing Pembro AVD to ABVD. Now, at this last ASH, there was a concurrent Pembro AVD study, not sequential, done by the Hutch. Somewhat of a complicated program, but suffice to say that everything was given combined. Well-balanced study. Unfortunately, had early stage patients here, which of course, as I said before, to me, do not count in advanced stage Hodgkin lymphoma. What was interesting is that, if we just go through the schema for time constraints, 29 out of the 30 patients did well. And as expected, I am a Pembro fan over nivolumab. But if you look at almost every single cancer that is where both pembrolizumab and nivolumab are approved, pembrolizumab is slightly better than nivolumab. Now, in patients older than 60, a study that we did when I was at Sloan Kettering is as such. So I think most people know that bleomycin in patients older than 60 is really fraught with difficulty. And if you look at ABVD versus Stanford 5, patients older than 60 are at the bottom curve here. And many of the events were without progression, just related to toxicity. 43% of the patients had bleomycin-induced lung toxicity. So there's been a number of studies that are looking at adding, starting off with single agents and adding new drugs. I personally don't think this is ethical. I'm older than 60 now, and I would like to be treated with curative treatment. I don't want to get BV alone. I don't want to get BV and bendamustine. I don't want to get BV and dacarbazine. So what I want to get is sequential BV-AVD. And what that is induction brentuximab vedotin, followed by a PET scan, followed by AVD, followed by some additional brentuximab vedotin. And the reason is that these results are almost identical to concomitant BV-AVD, and is very well tolerated. Much better tolerated than concomitant BV-AVD in patients that are older. So this is my favorite program with brentuximab. How do I treat advanced stage Hodgkin lymphoma? As I said here. So I want to just go for a second and present 3 short cases. And the reason I want to present them is that they're all relapse patients. They're all my patients. They're all treated differently because of different upfront treatment. The first patient is a 37-year-old internist who I'm taking care of now, presented with stage 4 disease, treated with 2 cycles of BV-AVD. The interim PET was Adovo 3. She got 4 more cycles of BV-AVD and had a residual lymph node in the neck with Adovo 4. I saw her at that time and recommended to repeat the PET scan in 10 weeks, which we did and showed progression. And I placed her in the Pembro GVD study that we have. This is the study which was published by Alison Moskowitz and myself in the JCO last year and will be updated at Cologne. 4 cycles of Pembro GVD, and that was followed by a stem cell transplant. The current study is no transplant if you're in remission and a year of Pembro maintenance. But suffice to say, and I've been studying relapsed Hodgkin lymphoma now since 1994, when I wrote the first ICE program. This particular study has the best results that we've ever seen in 30 years. In the 39 patients that we treated on this protocol, there's only been 1 event, which is why we thought maybe we're over-treating the patients and let's remove the transplant and give Pembro maintenance if patients are in remission. And that study is almost complete, and we presented at Cologne. Now, this lady is on study. She had 2 cycles of Pembro AVD. The PET scan was negative. She got 2 more cycles, continued to be negative. She had thyroiditis, as can be seen in this PET scan over here. And she just got dose 7 of pembro maintenance. Here's a second case. It's a 27-year-old medical student that I'm taking care of, who was treated with 2 cycles of ABVD. The interim PET scan has a Doval 3. Got 2 more cycles of ABVD at that time. PET scan 1 month later, Doval 4. Same scenario, repeated the PET scan 10 weeks later. Had disease progression. This patient never got brentuximab vedotin before, so we put the patient, we gave the patient BV-Nivo. And as you know, this is we've published this a number of times right now. The waterfall plot is negative, but I want to show you here on the right, on the top curve, in patients who have a complete response to BV-Nivo and then get a stem cell transplant, there's only been 1 event. And here's the last patient of a patient who had bulky stage 2 disease on ABVD. I saw in consultation at the time. He lived in California. It was going to be difficult for him to get treated by me, so I recommended that he get ICE chemotherapy. He got 2 cycles of ICE chemotherapy, had a complete response. We transplanted him, and we put him on the Athera study, which is sort of like falling out of favor these days. Did have an excellent response. Then he progressed with disease on the left. He put him, after BV maintenance, he progressed on this imaging study. The options were to give him a checkpoint inhibitor or radiate. We went up radiating him, and he was in remission, and then he wanted to go on a checkpoint inhibitor. So we put him on a checkpoint inhibitor based upon Philippe Armand's data, and he's doing well. So I know that that's a lot of information in a short period of time, but I'm happy to answer any questions. This is our group, and hopefully we can see each other in person soon. Thanks for your attention.
We open question for Prof. Gray. Yes, thank you, Prof. Musquis, for the nice presentation and overview of treatment and measurement of Hodgkin lymphoma. Question regarding the fertility. So the BV-EVD data, they showed similar fertility to EBVD. And we know from the Germans that EBVD patients, they had similar fertility as the normal population from the German data. So my question is, do you go for fertility preservation or oocyte preservation, sperm preservation for patients going to receive EBVD?
Yeah, so the sperm, that's a great question. I mean, sperm donation is easy. It's easy and it's quick. Of course, fertility preservation for women is a lot more complicated. That's a partnership with the physician and the patient. I think that if she wants to do fertility preservation, it's fine with me, and I think we do it fairly commonly. If this was a double-hit large cell lymphoma or a primary mediastinal large cell lymphoma with a 15-centimeter mass in the chest, I would not allow the patients to have fertility preservation unless they forced us into it. But for Hodgkin lymphoma, as you know, it doesn't grow. It takes a while for it to grow. If we're going to delay another 2 to 3 weeks, it's okay. So I'm perfectly comfortable doing it on almost every patient.
Okay. Are you comfortable not to do it for women? Can you hear me? Yes, Rob. Are you comfortable not doing it?
No, I do it on everybody. If they want it, it's okay with me.
Okay, thank you. Okay, next question from Dr. Ahmed.
Craig, thank you again for a great lecture and talk. Already, just to get this clear, let's say you have advanced stage Hodgkin lymphoma, stage 3 and 4. You started the usual first-line therapy. You do the PET scan after 2 cycles. whether you started with ABVD or you started with BVABD. After 2 cycles, it is still positive, you will 4, let's say. Do you switch, or do you escalate, or do you wait and repeat the PET scan after 4 cycles? What's your practice?
So for ABVD, and a Deauville score of 4 or 5 for advanced stage disease, I switched to BACOP. For BVABD, there's not much, the evidence is very, very limited to switch. So for BVABD, I'll give 2 more cycles and I'll repeat the PET scan again. And if it's still a Deauville 4 or 5, I'll do a biopsy at that particular point. If the biopsy is negative, I'll finish the BVABD. If the biopsy is positive, I'll cross the patients over to salvage therapy. But there was no, in the echelon 1, there was no switching. So, I mean, that's the practice that's how you're supposed to practice. In general, most patients have a Deauville 4. In somebody who has a Deauville 5 after 2 cycles of BVABD, then the question really should be for you is, are you comfortable continuing the treatment? A Deauville 5 could be nucleus disease, or you would just say a Deauville, or you have an SUV of like 8 or 9. Are you comfortable continuing that? And if you are, that's okay for 2 more cycles. If you're not, I would do a biopsy. There's no evidence that escalated BACOP salvages BVABD. Those studies have not been done. So if you are very concerned after cycle 2 with BVABD patients, I would do a biopsy. And if the biopsy is positive, I would go down a salvage route. That's extremely uncommon to have a Deauville 5 after 2 cycles of BVABD. I would bet that half the time those patients will have a large cell lymphoma when you do the biopsy.
Are you aware of any study using or adding BV to the ABD, I would say, after 2 cycles?
So there's no evidence out there that you should do that, or based upon research studies. There aren't studies in the U.S. doing that. I had heard that the Italians were doing a study like that. I don't know the results if that's ongoing, but there's no evidence, as far as I know, that in patients who get ABVD and a Deauville score of 4 or 5, and you want to change therapy, that changing to BVABD, nivolumab ABD, or pembro ABD is the right thing to do. The right thing to do is to follow what the literature suggested. If you change to escalated BACOP, you'll have a 2 out of 3 chance of being cured. That's what I would do. To add one of the newer programs at that particular point is you're making the assumption that that's going to salvage an ABVD failure, and we don't know that. So I wouldn't do that off of a clinical trial.
We have an ongoing study for recruitment. However, we're analyzing our data at the present time, and hopefully, we'll get some insight.
So that'll be a definite contribution to the literature.
Thank you, Prof. Regarding patients who relapsed post-auto transplant and responded to checkpoint inhibitors, we have many of them who responded well. I have, for example, just a young lady who is in CMR, 2 years on nivolumab, and she had a matched donor. So for this patient, what to do to continue checkpoint inhibitors until progression, to stop after sometimes, we need to consider allogeneic transplant for these patients.
So I wouldn't do an allogeneic transplant. I think that in patients who are in CR at 2 years after a checkpoint inhibitor, you can stop treatment and see what happens. I mean, probably a third of those patients who are in CR at that point will be cured. If the patients then progress, what I would do is I would add chemotherapy and a checkpoint inhibitor, because just giving a checkpoint inhibitor alone rarely puts the patient into remission. The patients will respond, but getting another CR is not as high. So I would add chemotherapy, usually something with an alkylating agent. CMOP I like. Those patients will probably go into a CR at that particular point, and then I would do an allogeneic transplant.
Thank you very much, Prof. Gray. We will reach to end of this session, and we hope to see you soon, inshallah.
Okay, I will try my best.
Thank you very much.
Bye, Mike. Bye-bye, guys.
To end of the session, we have a break for 5 minutes, and we should come back on 3:20. Thank you very much.
Welcome back. I think we will get started. My name is Zahrani. I'm a consultant hematologist from King Saud University Medical City in Riyadh. And I have my colleague with me also to moderate the session, Dr. Vivian Osman, consultant hematologist from King Faisal Special Hospital in Jeddah. So we will start this session welcoming Dr. Michael Williams from the States. He's a professor of medicine and pathology, physician lead oncology service line in University of Virginia, UVA. Dr. Williams' patient care and research interests include clinical trials, translational science for many types of lymphoma, including mantle cell lymphoma and other non-Hodgkin lymphoma, CLL, and with a focus on targeted agents as well as immunotherapies, including CAR T cells. And his talk will be on the use of CAR T cell therapy in diffuse large B-cell lymphoma, when and which. So we welcome Dr. Williams virtually to start the session.
Thank you very much for the invitation to take part. I've enjoyed listening to a couple of the talks that just completed. Let me try sharing my screen here. And are you seeing my full screen now?
Yes.
Wonderful. All right. Well, thanks again for the invitation. My topic today is CAR T therapy in diffuse large B-cell lymphoma. When do we use it? Which agent do we use? So I will walk through that with you. These are my disclosures. The other disclosure is that our stem cell transplant group here at the University of Virginia generally manages our CAR T administration. So I'm less of an expert than they might be in terms of the management through the initial CAR T transplant. But we're going to look at the data today for how we got CAR T cells available for this unmet need in relapsed refractory DLBCL. And then we'll talk about the more recent data comparing CAR T with auto transplant at essentially first relapse. So you're familiar with this, of course, in this transplant-oriented group. We collect T cells from eligible patients, expand those in the lab after they've been modified with the chimeric receptor that has a dual binding to CD19 on the tumor cells, and with the T cell link as well. We expand those and then reinfuse them into the patient. So I'll start with just a quick illustrative case from our own center. This was a 62-year-old man who was primarily refractory to his initial rituximab CHOP regimen. He was sent to us. T cells were collected. He had brief bridging therapy. We produced the CAR and infused them. And that was back in 2019. He was one of our earlier patients. You can see he had very extensive sites of disease following his induction chemo. And then here he is 60 days after completion of the CAR T with all the lymphoma sites in remission. And he remains in remission since 2019. Those of you who are noticing that there's an abnormality here at the bladder, it turned out that this persistent site was investigated and found to be a localized bladder cancer, which was subsequently managed as well. So CAR Ts were curative for this gentleman. So there are 3 CAR Ts approved in the US for diffuse large cell, and these are tisagenlecleucel or Tisa-cel, axicabtagene, ciloleucel, axicel, and lysocabtagene, which is Lysocel. You can see they all target CD19. Tisa-cel is also approved in younger patients with relapsed B-cell ALL, and axicel is approved in follicular lymphoma. They have different signaling molecules. Axicel uses CD28, whereas the other 2 use 4-1BB. That has potentially some relevance in terms of rapidity of T cell expansion in vivo, after infusion, 10 to 12 days for Axicel versus 3 to 4 weeks for the other two. There are also some potential relevance, there is potential relevance related to toxicity. So these were the pivotal trials that led to the FDA approval in relapse refractory. So these were patients who had had at least 2 lines of prior chemotherapy. They were given in these studies with curative intent. So if they did not get CARs and then an auto, these were managed CAR alone. You can see about 90 to 100 patients. Here's the overall response rates, which differed in part perhaps due to patient selection in these different studies, but you can see about 60 to 80% got a response and about 40 to 60% a complete remission. Here's the 3-month response rate. And you can see the duration of response was about 9 to 11 months, not reached at this point for the Tisa-cel study. Cytokine release syndrome, which I'll go over in a moment, also differed, and here may be the difference with a CD28 or 4-1BB in CRS as well as CNS toxicity. So when you're selecting patients for CAR T, this is, I'll just call your attention to this very recent review in Nature Reviews. We're looking at patients who have active progression during initial therapy or a salvage regimen or following prior treatment. Performance status 0 to 2, no severe organ dysfunction, active infections. Heavily pretreated patients may respond well, although you may have more difficulty collecting sufficient T cells in patients with extensive prior therapy. You can see responses even with secondary CNS, parenchymal or leptomeningeal involvement. Does not appear that a CAR administered to patients with CNS disease necessarily increases neurotoxicity, but it is known, as in the final bullet point here, that if you have a high disease burden going into the CAR, they do not do as well, probably because there's just less of the cellular immunotherapy effect, but also those patients tend to have more cytokine release syndrome and neurotoxicity. So what about the use of bridging therapy? That differed among the regimens. So one of the challenges with this procedure is that these patients with relapse refractory disease often have higher volume of disease and they progress rapidly, so that it can be difficult to bridge patients and control their disease sufficiently to allow the weeks that are required to get the patient in, get them evaluated, collect the cells, produce the CARs, and then get them administered. So what are the bridging therapy options? Well, you can use a typical salvage or second-line regimen such as rituximab ice. In general, it's much preferred to try to collect their T cells prior to chemotherapy. If the lymphoma happens to express CD30, you can use brentuximab vedotin. We most commonly use polatuzumab rituximab for our bridging. We try to avoid bendamustine, certainly before their apheresis. Bendamustine will impair T cell collection. There's newer data that was presented at ASH and ASCO in the past year. I'm sure we'll hear more of this at the upcoming ASH meeting, using bispecific antibodies as bridge. These are anti-CD20s, so they avoid the use of an anti-CD19 bispecific. The radiation therapy data is intriguing. If a patient has a localized site of disease causing symptoms, or it's bulky disease, radiating these patients may in fact release antigens and promote an immune response with subsequent immunotherapy, including CARs. So that's an area that is discussed in this article by Amini and colleagues, but very intriguing. So there's an unknown impact right now if you use an anti-CD19 therapeutic and how these patients will respond. So theoretically, if you've given an anti-CD19 binding antibody, then the CAR CD19 receptor will not be able to bind. And so therefore you may impair the CAR response. There's limited data that you can still see responses in about 50%, but I think for the time being, if you have other options, which typically you do, then we try to avoid using those. And this is just a schematic for your reference, again, with relating to the anti-CD19 approaches. You can see here the different options that we have. So what about toxicities? This is a concern with this therapy. We use lymphodepletion, typically cyclophosphamide and fludarabine, prior to administering the CAR. That essentially, by lymphodepleting the patient, it makes it more a more amenable environment for the CAR expansion. And I already mentioned CRS and neurotoxicity. So CRS can have hypotension, fever, capillary leak. And the toxicities here, again, just by way of a schematic, there can be disruptions in the blood-brain barrier, endothelial activation that can lead to neurotoxicity, which can include sort of sedation, delirium, aphasia is probably most common, leading potentially even to seizures and cerebral edema. Hemodynamic instability, so when you the CARs bind there and you get this intense immune activation, then you release a number of inflammatory cytokines, including interleukin-6, which can lead to complications listed on the right. So in more detail about CRS, you can see that it's an inflammatory response, as mentioned, with a supraphysiologic release of the cytokines listed here, but IL-6 is the most important player in this, and therefore it's a target for managing these patients. This occurs primarily via activation of lots of lymphocytes as well as myeloid cells, including macrophages and dendritic cells that release the cytokine storm. There's a grading scale for this. You can see that grade 1 is fever without hypotension or hypoxia. Grade 2 is some degree of hypotension but not requiring pressors, versus grade 3 and 4 where you do need vasopressors, and then varying degrees of hypoxia also give you a higher risk. So just to comment, I really managing the CAR T complications, including CRS and neurotox, is really outside the scope and time for this talk. But in general, if a patient has grade 2 CRS, we utilize dexamethasone or tocilizumab, the anti-IL-6 antibody, for 2 to 3 doses. Older patients, especially those over, say, 68, 70 years of age, even if they're having grade 1 with 3 or 4 days of fever, then our team and others will most often use a dose or 2 of toci in that setting as well. Now, what about neurotoxicity? So this is defined sort of generally, characterized by pathologic process with any immune therapy. So you can see this, as you know, with bispecific antibodies as well as CAR Ts. I mentioned already the spectrum of disease, including aphasia, which is the most common, varying degrees of encephalopathy, seizures, cerebral edema. The pathophysiology really isn't fully defined. We know there's disruption of the blood-brain barrier. You can get CAR Ts into the CSF. It can treat disease in those sites. So the interplay between the microenvironment and the neural tissues and this immune activation isn't completely clear. So all patients going on to a CAR therapy should have a baseline neuroconsult. We work closely with our neuro-oncology group, so any patient being considered for that has a formal consultation with our neuro group. They do testing as noted here. We also utilize, once the patient is admitted and the CARs are administered, once each shift, the nurses on our transplant unit go through this ICE scoring, and they document that in our electronic record with each shift. You can see the how the point scores that are allowed here. And so then the grading for neurotoxicity is founded on the ICE score. So if you have just minimal, perhaps cognition changes, then you're a 7 to 9, but none of the other abnormalities listed here. And then it advances from grade 2 through grade 4, where patients have very advanced neuro complications. And this can be a fatal event. So given the variance, it's often a real challenge with these therapies. Generally, these are managed even with certainly grade 2, but grade 1s we'll sometimes observe for a time, but if it's persisting, we'll go ahead and use dexamethasone, which is preferred over, say, solumetrol or prednisone because it has better CNS penetration. So that's an overview of CARs. Let's look at the recent data comparing CAR to auto transplant in relapse refractory. So now second line instead of after people have received a couple of other lines of therapy or after failing an auto. So to frame this, let's look, just as a reminder, this is actually the CORAL study was led by Dr. Moskowitz that you just heard from some years ago. So this looked at patients who had relapsed after initial treatment, whether primary refractory to it or a later relapse, and they were comparing rituximab plus DHAP versus Ritux ICE. And then patients who responded, if you had a CR/PR, they went to a beam conditioning, and then a second randomization to either observation or maintenance rituximab for a year. Patients who had progressive or stable disease went off study. So this is a large randomized multinational study, and they had about 400 patients. About at the time of this study was started, that not everyone, especially in some of the other countries, had rituximab. But what they found was that if you relapse within a year of completing initial therapy, especially if you had rituximab with your therapy, those patients did poorly. And there was really no difference for the two inductions. So either one that your center is used and comfortable using is appropriate. But you can see with prior rituximab exposure, only 20% event-free survival at 3 years. If you relapse within a year, especially, they did very poorly, and you can see that here graphically. So if you're chemosensitive and you were, especially more than a year out, you did, over 40% of those patients appear to be cured, but a rapid fall off if you failed early. So this data informed the 3 trials that I'm going to describe, looking at CAR-T for patients with this poor risk. So right now, if you relapse, high-dose therapy and an auto are the standard of care. But if they relapse early, they do poorly. So this study was a phase 3 comparing these early, either primary refractory or early progression within 12 months of finishing your induction R-CHOP or whatever immunochemotherapy you got. Then it compared CAR versus high-dose therapy in an auto. And in this study with Axicel, the ZUMA-7 trial, they did not allow bridging chemotherapy. So you could get corticosteroids, but this picks potentially a population of a little less advanced disease. These, you're not going to have patients with very rapid high volume progression in this study. So that's important as we compare to this other 2 that I'll share with you. So they enrolled 359 patients. 3/4 of these were patients who were primary refractory to their initial therapy. So a very poor risk group. 180 were randomized to Axicel, and 170, 90% of them ended up getting infused. In the standard arm, only a third of patients responded sufficiently to their salvage chemotherapy that they were able to go on and get a stem cell. So you can see the 2-year event-free survival significantly favored the CAR overall response and CR rate, much higher for CAR. Overall survival has not yet been reached for those who got the CAR therapy, and you can see the 2-year PFS is 40%. They did not have a crossover in this study, and you can see the rates of grade 3 to 4, CRS and neurotoxicity 6% and 21%. It's also worth noting that off trial, about 100 patients, so about a little over half the patients in the high dose arm did go off study and underwent a commercial CAR T administration. And at the top two curves here, you can see the event-free survival significantly favoring CAR T with, it's unclear yet where this plateau is going to be. There have been a few relapses going out to 2.5 years. And here's the overall survival. So again, not significant difference, but remember, many of these patients in the standard arm went on to a CAR off trial. And in the lower left are the subgroups where the forest plot, favors the CAR. So here's the summary. It was superior in all these patient subsets. They did better, or there was a lower CR if they had a high tumor burden and were in the standard arm. Toxicities were what we would expect. Very importantly here is that the CARs were produced quite rapidly, so 13 days on average to having the CAR ready for infusion. And so for these early progressing primary refractory patients, especially those that only need bridging with a corticosteroid, they did quite well with the CAR, and I think that becomes the recommended approach for this subset of relapsing refractory patients. Now here's a study that had a different outcome. This was also presented at ASH and also subsequently published in the New England Journal. So Tizacel, tisagenlecleucel, same design, high dose therapy, that same cohort of early relapse, primary refractory, same randomization in a phase 3. They did allow bridging therapy prior to CAR, so this was probably a sicker, more advanced and rapidly progressing population, and they allowed a crossover to Tizacel if they had an event at week 12 or later in the standard of care arm. Very different from the outcome with the other patients I showed you is that there was no difference in outcome for the two arms of the study. Virtually all patients got bridging therapy, but importantly, you can see the median time to getting their CAR infusion was 50 days after their leukapheresis. And a quarter of patients progressed before they got their CAR. They were still allowed to get it, even though they were having a progressing and higher burden of disease. Again, similar to the other trial, in the high-dose therapy arm, only a third of patients actually made it to a transplant, meaning that most did not get a sufficient response to their second-line chemoimmunotherapy. So the summary here, you can see there was lower grade 3 and 4 CRS and neurotox, felt to be related to the potentially the 4-1BB versus the CD28 signaling molecule. So it was not superior in this trial compared to high-dose therapy. So the comparison, I think the take-homes from this is sort of the post-ASH and sentiment, and this was reflected in an editorial that accompanied the New England Journal papers, is that patient selection is important. It's also, I'll emphasize again later, that these results don't apply to patients who have a late relapse. Let's say you get a good response to rituximab CHOP, and 2 years later you have a recurrence of your DLBCL. The standard of care there is still an auto transplant if they're chemosensitive to second-line therapy. Not chemosensitive, then I would go to a CAR. If you're able to get patients to the CAR without bridging chemo, then I think Axicel would be preferred. It's hard to compare these two studies because of the differences in patient population. I think the rapidity of CAR T is important. Having to wait several weeks instead of 2 weeks to get your CAR therapy is a concern. Now, here's a study that was published more recently. This is looking at the third CAR, so liso-cel. Again, patients with DLBCL relapsed to primary therapy early. One-to-one randomization. They allowed bridging therapy. And you can see the population here, about a third, 40% over 65 years of age, 73% with primary refractory disease. And here's the outcome. This was, again, a positive study. So the CAR T had an improved outcome over standard of care. And again, you can see the rapid progression in people who are largely chemo refractory. So that the 12-month EFS varied, was about 45% in the CAR T arm versus 23%, higher CR rate, and the 12-month overall survival also favored the CAR T therapy. These patients did, this study did also allow crossover to liso-cel, and so that also helped rescue some of those. But you can see even in that setting, you tend to lose some ground without going directly to the CAR. Here's the CRS. You can see grade 3 and 4, again, was quite low in this study. CRS only 1 grade 3 event, and there were 4 grade 4 neurotoxic events. So less of these complications with this 41BB CAR. So here's a comparison across the studies for second line with their numbers. I won't read through these again since we've already talked about them. But importantly, these early progressing patients, only a minority of them get enough of a response that they can go on to a standard auto transplant after that early progression. So conclusions. So axi-cel and liso-cel showed survival benefit over salvage chemo on an auto transplant for these patients with primary refractory or early progression. You didn't see that with Tiza-cel, and as I pointed out, these may have been sicker patients. There was also a longer time to get their cells. There's, maybe a more favorable population in the ZUMA-7 study for the reasons mentioned. So right now, I think for most of our patients at our center and others is that in patients with early progression, within a year of finishing their induction therapy or primary refractory, we take them to a CAR rather than an auto. I mentioned already about later relapsing patients. So with that, I will thank you again for the invitation. I'll be glad to take any questions.
Thank you very much. It was an excellent and elegant talk. We will open the floor for questions. Maybe just a comment before that. There was a recently published study, a large number of patients in the real world, patients using CAR T, comparing the different CAR T modalities and also doing a propensity score. It seems like axi-cel was superior compared to the other ones. Maybe because of the different, the features that you described, for example, the shorter duration of infusion, etc., preparation, and maybe not needing also bridging therapy, etc. Just a comment regarding that, and any questions?
Yeah, I think I'll just say I agree. That's very useful data, and I agree completely that there may be some difference in the biologic effect of the CD28 CAR, the axi-cel. The rapid turnaround of getting the cells into the patient, I think those are very relevant factors. So a little more toxicity, which generally we can manage well. I'd say just the approach we'll use at our center is in younger fit patients, we often will use axi-cel for the favorable reasons mentioned, including response. In older patients, where CRS and neurotox are more of a concern, we'll tend to use one of the other products.
In your current practice, do you bridge with other things other than steroid and axi-cel?
We try to, if we need bridging at all, then we do try to use corticosteroids alone. In other patients, we'll use, most of the time, we can get enough of disease control with Pola Retux. We have added sometimes bendamustine to that in poorer responders, but just so they don't get the benda before you collect the T cells, then we'll give them a cycle or two with a Pola BR while we're awaiting the CARs and to try to get some reasonable control of their disease.
We have one question that we have.
Thank you for your presentation. How would you manage patients who have CNS disease? And is it, we know that they have an increased risk of neurotoxicity and it's a contraindication for CAR T cells. But if they were to go into remission in their CNS, is it still an issue?
Well, so there's some suggestion that even with CNS involvement, the neurotoxicity is not necessarily increased. Those are difficult patients, and we now know from other work, including some from our own center, that that our standard therapies, including high-dose methotrexate and intrathecal methotrexate, don't necessarily do very well controlling CNS disease. So we'll include those patients with our CAR treatment. I can't say that there's a recommendation for one over another. Perhaps, Lysocell or Pisa-cell might have a little lower neurotoxicity, and so that could be considered for those patients. That's a tough cohort and still an unmet need. Just as an aside, I would say that one of the things that are being looked at is, as we've gotten better at defining molecular subtypes of DLBCL, there are some that tend to have a propensity for CNS involvement that have MYD88 mutation or activation of that pathway, and they may respond to ibrutinib or zanubrutinib that have CNS penetration. So that's still a rapidly evolving area that we need to understand much better, because those patients in general have poorer outcomes, as you know.
I have a question regarding elderly patients as well as those with poor performance status, like performance status of 3 or 4. I know some of the trials excluded patients, they only included ACOG grade 1, 2, and excluded 3 and 4. And I know in the clinical practice, many physicians are more liberal in terms of using CAR-T outside of the inclusion criteria and clinical trials. So can you tell us what is your experience in terms of those patients with comorbidities, poor performance status, elderly, if there's any age limit for that?
Yeah, that's a very important question. So in general, if a patient has a poor performance status related to being elderly, frail, comorbid disease, cardiac or renal disease, for example, generally they're not considered candidates for CAR therapy. Now, if they're in their 60s or early 70s and they have a poor performance status that's related to the fact that they've got very progressed disease, they've got a high burden of disease, and you can manage that, then, as everyone, listening in knows, that if you can get a good response to the lymphoma, those patients will often have a very gratifying improvement in their performance status, and therefore they can be eligible for it. But if it's poor performance due to patient conditions, not tumor-related conditions, then unfortunately they tend not to be appropriate candidates for CAR.
We'll close off this session with one last question. Our local experience in Saudi Arabia with CAR T cells, as you mentioned, people who have large volume of disease while going into CAR T cells, they don't seem to respond very well. But the product that we are using is Tysa-cel. So when you are bridging these patients, are you looking for a volume reduction or just stable disease before taking them into countries?
Yeah, it's a good question. So we want to see volume reduction. The lower the burden of disease going into the car, then A, there's less CRS and less neurotoxicity, and B, you tend to get a better immunotherapy effect if there's less of a burden of disease for these cells, the expanding CAR Ts to clear. So for both toxicity reasons and for response reasons, it's useful to have not just stable disease going in, but disease that is responding and decreased from the baseline burden.
As we'd like to conclude the session, I'd like to thank Prof. Williams for joining us and giving us this exciting talk. Thank you very much once again.
Thank you very much. I appreciate the opportunity to take part. Bye.
Okay, we'll move on to the next talk, and it's my pleasure to welcome Dr. Jesus Verdehan. He's the director of the Multiple Myeloma Research Cannon Research Institute. He's a partner in the Tennessee Oncology. After finishing medicine from Harvard and training in hematology with Johns Hopkins, he has been a clinical hematologist with focus on multiple myeloma. He's an active member of the International Myeloma Society, ASCO, ASH, and the International Myeloma Working Group. I would like him to start his talk regarding CAR T-cell therapy in myeloma, when and how effective.
Thank you so much for inviting me. I hope you can hear me because I don't want to give a talk for 25 minutes and no one can tell me that that's the case. So please stop me if you don't hear me.
We can hear you very well.
Excellent. Thank you. And I'm sorry I can't be there, but I'm there in spirit. So I know we're running behind, so I'll get started. So thank you very much for the invitation. Let's see, I'm trying to move my slides here. There. So these are my disclosures. So, myeloma, obviously, we've made lots of improvements. And as you can see on the left, with the addition of the quads now in first line, we have amazing responses in the first line of therapy. And that's translated to overall survival for our patients, but unfortunately, no cure just yet. But when you look at patients who've actually been treated with CD38 antibodies and they become refractory, we know from the Mammoth study that the overall survival is quite poor for these patients, and it's only 8 months. And it only worsens as you get more and more refractory. So as you become refractory to the PI, the IMiDs, and the anti-CD38s, that response continues to worsen. So this is where the BCMA treatments come in, and I think they fit very nicely in the post-CD38 space. And so BCMA is a great target. Obviously, you heard about CD19 CAR Ts, but CD19 is not really expressed in the majority of plasma cells. So we need another target. BCMA is that target. It is expressed basically in all plasma cells, and the expression increases as the cell becomes more malignant, and the expression is highest in myeloma. It is minimally expressed in other tissues, which of course makes it a great target. BCMA is actually a very important receptor for myeloma cells. It is a receptor for the TNF superfamily, a receptor for APRIL and BAFF, and it plays a key role in B-cell maturation and differentiation. So again, a very important target for therapies. We now have 2 FDA-approved BCMA-targeted CAR T cells. We have idacaptogene leqlucil, or ide-cel, and ciltacabtagene autoleucel, or cilta-cel. And these are both FDA-approved in the United States with the same indication for adults with relapsed refractory multiple myeloma after 4+ prior lines of therapy, which include an IMiD, PI, and an anti-CD38 antibody. In the EU, they have a little bit more lenient approval with just 3 prior lines of therapy, including a PI, IMiD, and anti-CD38 antibody. So how do we get these two FDA-approved CAR Ts? The first is ide-cel, and that was based on the phase 2 KARMA trial, which I'm showing you here. So I just remind you that ide-cel is a traditional second-generation CAR T cell with a single anti-BCMA single-chain variable binding domain that is linked to a 4-1BB co-stimulatory domain and a CD3 zeta signaling domain. Patients had to have 3 prior lines of therapy, and previous exposure to an IMiD-PI and anti-CD38 was required. As you can see here, patients were treated, 158 patients were screened, 140 leukapheresis, and 128 patients actually underwent treatment. And you can see there were 3 dose levels of 150, 300, and 450 million CAR T cells. This is the baseline demographics of the patients, very high-risk patients with a median of 6 prior lines of therapy, so very heavily pretreated. And as you can see at the bottom, their refractory status, the majority of patients, 94% were refractory to an anti-CD38 antibody, which fits that really refractory population. This is the overall response, and to the very right, you see that the overall response for the entire population was 73%, with a complete response rate of 33%. If you look on the left, you see that based on dose level, it appears that the higher the dose level, the better the response. So the 450 appeared to do best with an overall response rate of 82% and complete response rate of 39%. I'll remind you that in this population that is being tested, the expectation, and for the previously FDA-approved products, the overall response rate is in the range of 20 to 30% with CR rates of 1 to 2%. So clearly significant improvement from that. These are the PFS and overall survival curves. If you concentrate on the green curves, that's the entire population. So the median PFS was 8.6 for all patients, and the median overall survival was 24.8 months for all patients. Cell dose and depth of response matters. So on the left, you see the progression-free survival by target dose, and you see that the patients who received 450 million cells, which is the green curve on the top, you see that the median PFS is 12.1 months. And similarly, if you look to the right, in the patients that achieved complete remission or stringent complete remission, which is the light blue curve on the very top, you see that they did the best with a duration of response of 20.2 months. In terms of adverse events, hematotoxicity is very common, as was described previously, but it's important to note that it is true grade 3-4 hematotoxicity that can last. So about almost half the patients in the KARMA trial were still had grade 3-4 hematotoxicity even 2 months after the CAR T. So that I think is an important thing to remember and to keep in mind. Cytokine release syndrome was very common and was seen in 84% of the patients. The majority were grade 1-2, with only 5% of patients having grade 3 or higher. The median onset was quick. It was just 1 day. So that's important to compare to the next product that you will see. But it was very manageable. Neurotoxicity was seen in 18% of patients. Again, mostly grade 1-2, 4% had grade 3 or higher. The median onset was 2 days, so similar to the time around the timing of cytokine release syndrome. We now have some real-world data. So this product now has been out for about 1.5 years. So this is a group of academic centers showing what their real-world experiences, and you can see it's actually very nice to see that the median PFS in the real world was very similar to what we saw in the KARMA trial, as was the overall survival, granted a very short median follow-up. But what was very interesting with this real-world study was that 77% of the patients would not have been eligible for the KARMA study. And so again, showing us that we can sort of expand beyond the clinical trial population and do it safely with good results. So what about cilta-cel? So cilta-cel was studied in the CARTITUDE-1 study, and this was, I remind you that cilta-cel, it's a little bit different. It's the same structure as ide-cel, a second-generation CAR T, except that it has 2 BCMA binding domains. And we think that maybe the 2 binding domains confer avidity and perhaps make this a little more sensitive. So similar population, 3 prior lines of therapy, PI, IMiD, and anti-CD38 antibody. 113 patients were enrolled, 101 underwent lymphodepletion, and 97 patients ended up getting dosed. And I show you here in on the slide that the target dose was 0.75 times 10 to the 6 per kilogram, and the median administered dose was closer to that at 0.71 times 10 to the 6. This is a much lower dose than we saw with ide-cel. So this translates to about 50 million CAR T cells compared to 450 million CAR T cells with ide-cel. This is the demographics of the patients. And again, heavily pretreated population, very similar, also 6 million prior lines of therapy, and 88% triple refractory. You see at the bottom, 99% of the patients were refractory to anti-CD38 antibodies. Response rates were quite impressive, with overall response rate of 98% and stringent complete remissions of 82%. The median PFS and overall survival have not been reached. This is an update of 27 months, and the 27-month PFS is 54.9% for all patients. And at the top, you see the patients that achieved stringent complete remission. That's even better at 64.2%. And the median overall survival has not been reached. And the 27-month overall survival is 70.4%. So appears quite durable, which is nice to see in this population. In terms of safety, again, you see the cytopenias with many, a high percentage of grade 3/4 hematotoxicity. If you look over to the right in the cytokine release syndrome, you see that the majority of patients have cytokine release, but mostly grade 1/2 with 5% grade 3 or higher. But look at the median time to onset. This is, it was 7 days compared to ide-cel, which was 1 day. So it goes to show that it's really important to pay attention to the pharmacokinetics of the products, because they can differ quite a bit in terms of when to expect your toxicities. Now, neurotoxicity was another differentiator here compared to ide-cel. If you look at the total, there was 20% neurotoxicity with 10% grade 3 or higher. If we look at just ICANS, the traditional ICANS definition for CAR Ts, this was very similar to ide-cel, with 16% of patients having ICANS and 2% grade 3 or higher, with the median onset of 8 days around the time of cytokine release syndrome, which is what we saw with ide-cel. However, with cilta-cel, we did see 12 patients that had this other neurotoxicity that was high grade, with 9 of them having grade 3 or higher. Median onset was very late, of 27 days. And some of these, 5 of these 12 patients actually had what we call motor neurocognitive disorders, very Parkinsonian-like symptoms that did not respond very well to therapy. So an important toxicity to remember. Unfortunately, unlike what you saw with lymphoma, we're not really seeing a plateauing of the curves, and the majority of patients continue to relapse. There has been descriptions of patients relapsing with BCMA negative disease, and this is just a case report of a patient actually having biallelic BCMA loss. But luckily, this is very rare, and the majority of patients actually relapse with BCMA positive disease. So what can we do once, beyond sort of what we have now? Obviously, in myeloma, everything seems to work better when we do it earlier. So there are many trials now looking at earlier populations, including CARTITUDE-2 and KarMMa-2, which I'll show you in a second, some of the early results from CARTITUDE-2. KarMMa-3 is a randomized phase 3 trial of ide-cel versus standard of care with patients with 2 or 4 prior lines of therapy. And we just saw a press release that they have met the primary endpoint, which is progression-free survival. And so we hope to see that data at ASH. Frontline-wise, looking at patients with high-risk disease, there are studies ongoing looking at actually CAR T therapy, even in the frontline setting. So looking at the data that we actually do have, we have 2 cohorts from CARTITUDE-2, and this is with cilta-cel, of course. So cohort A is for patients who had 1 to 3 prior lines of therapy and they require that you be refractory to lenalidomide. Cohort B is for the functionally high-risk patients. So these are patients who progressed 12 months after starting their initial therapy or after stem cell transplantation. And so here, cilta-cel was used as second-line therapy. So if you look at cohort A, these are the patients that had a median of 2 prior lines of therapy and were lenalidomide refractory. You see that the overall response is 95%. So all but 1 patient responded with a complete response rate of 90%. with a median follow-up of 17.1 months, the 15-month progression-free survival of 70%. And the 16 patients that were MRD evaluable, all were MRD negative. So again, very deep responses. And so hopefully this will translate to prolonged responses. In terms of safety, very similar to what we saw with CARTITUDE-1. So hematotoxicity was important. Cytokine release was seen in 95% of patients, with 10% having grade 3 or higher. And the median time to CRS, 7 days. So again, similar to CARTITUDE-1. Neurotoxicity-wise, there was some neurotoxicity, but mostly grade 1, 2, median time to onset 8, so the more traditional ICANS, and they did not see any new cases of movement and neurocognitive neurotoxicity, which is reassuring. If you look at this cohort B, and this is the cohort that was functionally high risk, so patients who relapsed within 12 months of their initial therapy. So this was given a second line of therapy. You see that they have a 100% overall response rate with 90% complete response rates with a median follow-up of 13.4 months. The 12-month PFS is 89.5%, so that's looking quite good, right? These patients all only had 1 year of duration of response to their initial therapy. So maybe we're starting to cross that line, which is a good thing to see. They had 15 patients that were MRD evaluable and 93% were MRD negative at 10 to the minus 5. In terms of safety, again, very similar to what we saw with CARTITUDE-1. So hematotoxicity was the main toxicity. Cytokine release was seen in 84% of patients with grade 3 or higher of 5%, and median time onset of 8 days, again, similar to CARTITUDE-1. Neurotoxicity, the majority of patients who did have neurotoxicity were grade 1, 2 with grade 3 or higher of 5%, median time to onset of 11 days. But they did see one case of the movement neurocognitive AEs, and this was a patient that actually I spoke to the investigator that had this patient, and this was a patient that was had very high burden of disease, that had very refractory disease, and they could not get the disease under control with any bridging therapy. So they went into the treatment with rapidly progressive disease, and unfortunately, that is an increased risk of this late neurotoxicity. So what about, how can we make these better? One thing you could try and do is maybe increase the expression of BCMA. And so the group in University of Washington has done this with gamma secretase inhibitors. So gamma secretase actually cleaves BCMA on the surface of myeloma plasma cells. And so by using the inhibitor, you can increase the expression. And so they've used this by giving the gamma secretase inhibitor prior to a second generation CAR T cell. And so you can see here that on the left, they show very nicely that they can definitely increase the expression of BCMA. So you see the little blue bars compared to the orange. The blue is pre-GSI and the orange is post-GSI. So most every patient increased their expression or their BCMA surface density. And so on the right, you see the response rates, and you see that basically all but one patient has had a response, which is quite gratifying. And what's even more interesting is they actually have 4 patients who had prior BCMA CAR Ts, all actually had a response. So a nice sort of kind of proof of concept that perhaps you can augment the response to BCMA by using a gamma secretase inhibitor. One of the problems with this, at least early on, is that the gamma secretase inhibitor has some potential neurotoxicity. So it remains to be seen whether we can actually use that in combination with CAR T cells or the bispecifics. One of the problems with autologous CAR Ts, of course, is, in a disease like myeloma that's in the relapse refractory setting, is that these patients often are progressing and then have organ dysfunction. So perhaps an allogeneic CAR T would kind of do away with some of the problems of having to wait for the CAR T. And so we do now have some data from the ALLO-715 BCMA allogeneic CAR T, which uses a TALEN, so it has a traditional CAR, so second generation CAR infused, but then it uses TALEN technology to actually knock out the T cell receptor, which should minimize the risk of graft-versus-host disease. And actually, they have not seen any graft-versus-host disease. But the other thing they do is they actually knock out CD52. And so because of that, they're able to use an anti-CD52 antibody for lymphodepletion without hurting their CAR T cells. And so their lymphodepletion is a little bit different. They use fludarabine, cyclophosphamide, and the ALLO-647, which is this anti-CD52 antibody. And so the early data looks promising. One of the things that is more impressive is that 90% of the patients were able to get treatment within 5 days of enrolling on the study. So lightning speed, which is nice. So off-the-shelf therapy, and the early response rates look promising. But again, more to come, I think, from this therapy. The other potential is, well, maybe if BCMA therapy is failing, perhaps we should go to another target. And definitely the next target that is the most advanced at this point in myeloma is GPRC5D. And you'll see a lot of data. And actually, hopefully, we're close to an approval of a GPRC5D directed bispecific antibody. But this is data with a GPRC5D targeted CAR T from Memorial Sloan Kettering with MCAR-H109. And so this is, again, a second generation CAR T. It's just that instead of BCMA, it's GPRC5D as the target. And as you can see, it's a dose escalation trial. They started at 25, went all the way to 450 million cells, and are seeing responses and all. But I'll point you to the table on the right lower corner of the slide, where they looked at patients who had prior BCMA therapy, and they had 10 of those patients, and you see an overall response rate of 80, and they had 8 patients who had prior BCMA CAR Ts and had a response rate of 75%. So again, this is reassuring that perhaps we can use a different target if and when BCMA CAR T or therapy fails. And then finally, from a standpoint of sort of kind of other things, manipulations that we could look for is perhaps to trying to minimize escape after one target. Could we do dual targeting? And this data has been shown. So there's a Chinese group looking at FastCAR GCO12F, which is a dual targeting BCMA CD19 CAR T. And so these patients, the usual relapse refractory after at least 3 prior lines of therapy, the patients went through the usual lymphodepletion and received the cells. And again, you can see that so far, at least early on, 28 patients were seeing some impressive response rates in this population. The key here is going to be the durability in my mind. So, I think we're seeing the response rates are very high with a lot of these CAR Ts. The question is, are these manipulations going to be improve on the durability and hopefully eventually become curative? So the idea behind this dual CAR T is that even though CD19 is not really expressed in the majority of plasma cells, there is some data that perhaps CD19 is expressed in the plasma cell stem cell, and so the idea would be that BCMA would get you into remission, and maybe the CD19 CAR can prevent that relapse. And so again, only time will tell whether this will be a more durable response than with just a BCMA CAR. So to conclude, BCMA-directed CAR T therapies are now available for treatment of myeloma. The current indication is in the relapse refractory settings. So you have to have had at least 3 prior lines of therapy. You have to have progressed on a PI, an IMiD, and an anti-CD38 antibody. We're starting to see results of this use of these products in the earlier stages of disease. Obviously, we have CARTITUDE-2 with cohorts A and B that are showing some very impressive results. But here, of course, again, is the longer follow-up that will be important as to whether these can start challenging our current standard of care in the second line or third line. We do now know that KarMMa-3 has met its primary endpoint, and this, I remind you, is a randomized clinical trial of ide-cel versus standard of care. And presumably it has met its primary endpoint, which is progression-free survival. So we're hoping that hopefully we will see this data at ASH in December. I think the BCMA therapy is very nicely filled the post-CD38 space. And so I think it's, that's where they fit right now. But I think that they will start challenging sort of even the early lines of therapy in my mind. Unfortunately, relapses continue to occur. So at least at this point, these therapies do not seem curative. And I think the biggest problem still remains issues with making these therapies more accessible to all of our patients, not only even within the United States, but obviously throughout the world. And so with that, I will stop by just showing you sort of the Sarah Cannon team. We are spread out throughout the United States. And so I thank all of my collaborators, and I thank you for your attendance and attention.
Thank you, Dr. Bagdana, for the updates on the cases. It's indeed hopeful times for myeloma patients. So we'll take questions. Start with the question. These trials, were they looking at the persistence of CAR T cells? Or in other words, is a relapse happening because the CAR T cells disappear? And if so, I mean, is there other trials looking at whether we can give the CAR T cells again, with or without lymphodepletion?
Yeah, so that's an excellent question. So originally we felt that it was going to be important to have durability of the CAR T cells, and I think everyone was looking at perhaps that's the reason the patients are progressing. But I'll actually two things. So one is if you actually look at the persistence of the CAR Ts, the persistence is much longer with ide-cel. With cilta-cel, actually most patients lose detectable CAR Ts by 60 days, and yet the response seems to be going even longer. So that doesn't seem to be translating to duration of that response. The other thing is, if you look at ide-cel, the majority of patients that actually are progressing still have detectable CAR Ts. And so it really looks like these CAR T cells are just no longer functional. And so they're losing their function for whatever reason. And I think those are the things we have to tease out in terms of the mechanisms of response that are happening. With the KarMMa studies, they allowed retreatment in patients who had a response to ide-cel and then progressed. And I can tell you that hardly any patients responded, and if they did, it was very short duration. So at least retreatment does not seem to be helpful. Again, I think that the mechanism of resistance is still there, whether it is the cells or something that has happened in the microenvironment to the or resistance of the myeloma cells themselves make them now unable to respond to the same product. I hope that answered your question.
Yeah, another question. Thank you for the talk. I have two questions. The first one, has been there any analysis to look at, subgroup analysis to look at the ultra-high risk myeloma patients versus standard risk myeloma patients? Is there any difference in their response to CAR T cells? The second question is, if we look into the future, bispecific antibodies are coming. How are we going to sequence our therapies for myeloma patients? If you were to look, say, in 3, 4, 5 years' time, how do you see the myeloma paradigm shift be?
Yeah, so those are excellent questions. For your second question, I'll say stay tuned for my next talk, but I'll discuss briefly now. But the first question is a great question. So clearly, if you look at sort of the subset analyses of both KarMMa and CARTITUDE-1, you see that the patients who had revised ISS3 disease and high-risk disease, although they do well, they don't do as well as the rest of the population. So even with CAR Ts and even in the relapsed refractory setting, you can still parse out the patients who have high-risk features that still don't do as well. So unfortunately, the hope was that with these immunotherapies that should be agnostic to some of these sort of mechanisms of resistance that are internal to the cells, that you should get response rates. You do see the response rates, but the durability still is not there. So I think, in the high-risk population versus the standard, back to your question, I suspect that we're going to have to do some kind of maintenance therapy for these patients. Now, we may have to do it for everybody, but definitely in the high-risk patients, it does look like we still need to do sort of several points of attack. And so So I suspect that as we see some of the data coming from the high risk patients early on where they're getting CAR T therapy, I suspect that we're going to have to have continuous therapy. So the idea of one and done, I don't think will be the case for those high risk patients. I think for the standard risk patient early on, I think that still remains a very viable option. And I think that is the attraction of the CAR T, especially for myeloma patients, the idea of having one treatment with no maintenance and having several years of disease-free survival is actually quite significant for these patients. But yes, no, I agree with you. I think the high-risk patients are still going to be a challenge and will still need multimodality therapy. From a standpoint of how do they compare to the bispecifics, I think it's just like with every other disease. I think in lymphoma, you saw that CAR Ts are curable. So obviously you always have that potential and that makes that a very attractive therapy. In myeloma, as long as it's not curable and we have similar results with therapies that perhaps may be easier, like the bispecifics that are off the shelf and can be started right away, and which are showing amazing responses, I think there will be a significant challenge in terms of when to use what. I think you'll see some data later that there is a potential to sequence them. But for the most part, I think it's going to be choosing one or the other. And I think it's going to be very patient dependent and also very practitioner dependent in terms of what options you have. Some patients are scared by the CAR T. They don't think the durability is sufficient for that potential toxicity and would never get a CAR T. And would prefer the bispecific antibodies, which may be a gentler therapy. Some patients are just exploding so quickly or are not able to be bridged that the bispecific makes more sense because you can start right away. It's off the shelf. And then there's some patients that only want the CAR T. Again, that whole idea of getting one treatment and not having to come back to the clinic for continuous therapy is very attractive, and those patients will move towards that therapy.
I have one more question, Dr. Nadia. So it seems like at the current time, patients who receive the CAR T for myeloma are very heavily pretreated, many different lines of therapy before. So do you anticipate a problem with collecting the T cells for the CAR T? And also do you think the fact that they have received many therapy before that affects the T cell function and that may lead to relapses or dysfunction of T cells later on?
Yes, excellent points. Yes, these patients are very heavily pretreated, and definitely, I think it affects the T cell function. That's one of the questions about whether if we move these to earlier lines of therapy, whether we will see a better functioning T cell that will lead to better results, and also the appeal of the allogeneic CAR T cell as well, using normal donors, of course. There is some data actually from ide-cel. They looked at sort of factors that affect response and durability of response, and definitely the types of therapies used immediately prior or in proximity to the collection of T cells makes a difference. And so, as you heard in the earlier talk, you want to avoid the use of T cell depleting therapies, so the bendamustines of the world, but also the alkylators. So it looks like the platinums and the and Cytoxan may be having sort of an adverse effect on the T cell function. And so it is very important to determine or consider what therapies you're giving right before collecting your T cells. So I would definitely stay away from bendamustine, which we know has a very good response with myeloma, but also things like VD-PACE or high-dose Cytoxan. Those can be used as bridging, but not necessarily prior to the collection of T cells.
We'll wait for your next talk in half an hour's time, so move on to the next talk.
Thank you.
Hello. Good morning. I'm going to share my slides.
Welcome, Dr. Hill. I hope you can hear us.
Yes.
I'll just introduce you before your next talk. Dr. Brian Hill is the director of the Lymphoid Malignancies Program, Cleveland Clinic, Learner College of Medicine. His clinical and research focuses in CLL and lymphoma. He's the PI of multiple ongoing trials and the novel cell therapies. He serves as the chairman of the Pharmacy and Therapeutic Committee in the Department of Hematology. He's a co-director of the Lymphoid Malignancies Center of Excellence. He's in the editorial board of several peer-reviewed journals. He's an assistant professor of medicine of the Cleveland Clinic. So I welcome you to this meeting, and we are waiting to hear your talk on high-risk diffuse lymphoma via March.
Very good. Thank you for the introduction, and glad to be here virtually to present sort of an update on frontline management of diffuse large B-cell lymphoma and where we are in 2022 and where we're going. So as I'm sure everyone in the audience is very familiar, R-CHOP has been the sort of reigning champion for the last 20 years or so. And this, of course, is a multimodality treatment with monoclonal antibody, anthracycline, alkylating agent, vinca, and glucocorticoids. And together, this produces a durable response or cure in the majority of patients. Because not all patients are cured, there's always an interest in doing more. And this is sort of a view of a simple oncologist with a stethoscope here saying, you know, me like R-CHOP. And then there's always the question whether a bigger, stronger chemotherapy is better and a bigger stick. And so to do this, the EPOCH regimen has been widely studied. Instead of using R-CHOP, you now have an additional agent with etoposide, which is a topoisomerase inhibitor, of course, and you added this not just as another drug, but as a continuous infusion and with dose escalation to reach higher doses and more anti-neoplastic effects. There was a randomized trial published in 2019 from the Alliance US Cooperative Group, which studied R-CHOP versus dose-adjusted EPOCH for 6 cycles. And unfortunately, there was really no improvement in either progression-free survival or overall survival in this study, suggesting that for standard risk patients, R-CHOP is no worse and EPOCH is no better. However, as I'm sure everyone in the audience is quite aware, diffuse large B-cell lymphoma is not a single disease, but is has a certain degree of clinical heterogeneity. Much of this can be accounted for by simple clinical factors that are sort of codified in the International Prognostic Index, or IPI, as well as double hit status. And I'm sure you've seen the IPI scores and the outcomes depending on your age, performance status, stage, LDH level, and number of extranodal sites. You may have a very favorable or a less favorable overall survival. In addition, it's been recently recognized over the past 10 years or so that double hit lymphoma with translocations of MEK and BCL2 primarily have much worse outcomes than standard non-double hit lymphoma. And this is a large retrospective review of the outcomes of double hit lymphoma patients treated with either R-CHOP, or on the top here you can see more intensive induction regimens like dose-adjusted EPOCH or hyper-CBAT or others. And so the question really in 2022 is, should we use EPOCH, dose-adjusted EPOCH, or other intensive regimens for double hit lymphoma? And I would say in the United States, it is common. So if you have non-double hit lymphoma, the standard of care remains R-CHOP, or has remained R-CHOP. And if you have double hit lymphoma, which is really only about 10% of cases, our dose-adjusted EPOCH is frequently used, although other regimens may be employed. And so this is overall, you know, looking at lymphoma still as sort of one disease, or maybe two if you include double hit lymphoma. But we know now that biologic differences can impact the outcome. And this is seminal work that goes back again over the past 2 decades, which used gene expression profiling to demonstrate that diffuse large B-cell lymphoma that arises from a cell of origin in the germinal center actually has a much better outcome as opposed to diffuse large B-cell lymphoma that arises from a cell of origin that represents an activated B-cell gene expression profile. And you can see in yellow here the germinal center large B-cell lymphoma patients tend to have much better outcomes with standard R-CHOP therapy. And so if we go back to our sort of oncologist with a small club, now we're sort of asking the question, well, he still likes R-CHOP, and now we have the translational scientists who are telling us that, we're very primitive and we need to move beyond just treating this as one disease. And so if we look at this sort of idea that there's at least 2 different types of diffuse large B-cell lymphoma, and the activated B-cell subtype has activation signals arising from NF-kappa B, we know that proteasome inhibitors are particularly active in inhibiting this function. And so there were studies, single-arm studies of bortezomib when added to R-CHOP, in which the bortezomib, which was given on days 1 and 4, was combined with R-CHOP. And in this single-arm study, if you then look back at the patients who had germinal center or what's called non-germinal center, which is an approximation for ABC DLBCL, you see actually that the non-germinal center patients had equivalent outcomes, again, in a single-arm study. So this led to 3 randomized trials, one called Pyramid, one called Remodel, and another one through the Spanish group, which were randomized trials of R-CHOP with or without bortezomib. And probably the largest trial is in the middle here, over 940 patients. This was conducted in the UK. This is called the Remodel trial, and this was published in 2019, in which all patients underwent full gene expression profiling, and if they had germinal center diffuse large B-cell lymphoma, they received R-CHOP or R-CHOP with bortezomib. And what you can see here is that there was really no improvement for those patients. In the activated B-cell patients, the red line is the addition of bortezomib. There was a trend, although not statistically significantly different, for the addition of bortezomib to these patients. And in the unclassified group, this outcome was no different. And so as a whole, this was viewed as a negative trial because despite enormous amount of effort and technical skill in getting patients assigned by gene expression profiling, the use of bortezomib did not improve the ABC DLBCL patients in a significant way. Since that time, there's been other trials. We'll summarize them on this slide, which is over the past 5 to 10 years, we had many attempts to improve on R-CHOP. The top trial here was called the Goya trial, which attempted to substitute obinutuzumab for rituximab and was a negative trial. I have the next one here, the Alliance trial we talked about, which is R-CHOP versus dose-adjusted R-EPOCH, and again, this is a negative trial. It may be that patient selection leading to a relatively favorable outcome, patients with favorable outcomes were enrolled, leading to better than expected outcomes with R-CHOP in this study. And then at the bottom, we have the Remodel trial. And since then, there's been at least 2 other studies, including the Phoenix trial and 2 randomized trials with or without lenalidomide, which attempted to enroll patients with non-germinal center or ABC diffuse large B-cell lymphoma by gene expression profiling. And all of these trials, unfortunately, were negative. And so we've been left with the possibility that we may be sort of targeting the wrong patients with these drugs, and that maybe we need to be more precise in our approach. In the meantime, there has been significant interest in the use of antibody-drug conjugates for the treatment of B-cell malignancies. In particular, polatuzumab vedotin is an antibody-drug conjugate with a monomethyl ester E drug linked to an anti-CD79B monoclonal antibody. And as is common with all of these antibody-drug conjugates, the antibody drug conjugate is internalized intracellularly, and this then leads to release of the cytotoxic agent, which has anti-tubule properties. This drug has significant single-agent clinical activity far beyond just CD79 targeted monoclonal antibody without drug linked. And so this agent was tested in relapsed diffuse large B-cell lymphoma patients. This is a small randomized phase 2 trial in which bendamustine rituximab was given alone or in combination with polatuzumab vedotin. And as you can see on the right, there was a significant improvement in the progression-free survival by the addition of polatuzumab, with a median progression-free survival approaching 10 months as opposed to approximately 4 months with chemotherapy alone. And interestingly, this translated into an overall survival advantage as well, with the suggestion of a possible plateau on the curve, although longer follow-up would be needed. And again, these are relapsed patients. Somewhat provocatively, when we examine the subgroups of those with germinal center or ABC patients, as you can see, the numbers here are pretty small, but there seems to be a slight improvement in the response rates, at least the complete remission rates in the ABC patients. And if you look at the PFS, actually, the difference between BR with or without polatuzumab is non-existent for patients with germinal center diffuse large B-cell lymphoma. But on the bottom here, if you examine the outcomes of the, the top is ABC versus GC, and the bottom is ABC versus GC. And so the top is bendamustine rituximab, and the bottom is bendamustine rituximab with polatuzumab. And so what you can see is that there seems to be the suggestion of an improved outcome in the higher risk ABC patients by addition of polatuzumab. So this sort of set the stage for what was called the POLARIX trial. This is, again, going back to our what we call backbone of R-CHOP chemotherapy. By eliminating vinca alkaloid and substituting polatuzumab vedotin, you have the potential for higher concentrations of delivery of anti-tubule drug intracellularly. And so this POLARIX trial was a large international study of over 800 patients with treatment-naive diffuse large B-cell lymphoma. I'd like to highlight that the international prognostic score was 2 to 5. So low-risk patients were intentionally not enrolled, which provided the opportunity to perhaps see more signal of activity. This is a randomized study of R-CHOP versus R-CHOP with polatuzumab. And if you examine the baseline characteristics of the patients who are enrolled, the majority of the patients in both arms had advanced stage disease. And actually, the majority of patients had IPI scores of 3 to 5. There were about 30% of patients with activated B-cell subtype diffuse large B-cell lymphoma, and a relatively small number of patients with double or triple hit lymphoma. The adverse events in the outcomes of the patients are shown here. So there was some peripheral neuropathy, about half of the patients in both arms. But remember, in R-CHOP, you get peripheral neuropathy from vincristine, and a very small number have grade 3 or 4 peripheral neuropathy. Although you don't have vincristine in the polatuzumab containing arm, polatuzumab vedotin can cause neuropathy, and so you did see about half the patients, but these were not statistically or meaningfully different in the R-CHOP arm. Neutropenia was well balanced in both arms. The rates of febrile neutropenia were comparable. And if you look at the efficacy of this regimen, the addition of polatuzumab, or substitution, I should say, for vincristine in the R-CHOP backbone, led to a statistically significant improvement in the progression-free survival to 76% at 2 years from 70%. This was a p-value of 0.02. So if you sort of do a calculation where you ask the question, how many patients are needed to prevent one relapse, the number needed to treat is 16. There's no difference in overall survival in the treatment arms, suggesting that among those who relapse after R-CHOP, there are sufficient salvage regimens to achieve a similar overall survival. Subgroup analysis of the study is very interesting. There seems to be a higher benefit for the higher risk IPI patients. Those are with IPI scores of 3 to 5. And those patients who had non-bulky disease had more benefit. Particularly interesting and thought-provoking is the potential for a differential impact of cell of origin on the outcomes. Historically, you'll see in the R-CHOP arm that patients with ABC subtype have inferior outcomes, but there was an inversion of the outcomes such that the ABC patients actually had superior, numerically at least, 2-year progression-free survival of 84%, which is much higher than is seen with R-CHOP. There were not really enough patients with double hit or triple hit lymphoma to conclude whether there's benefit or not of this regimen. What were the treatments that patients received after polatuzumab or with RCHP versus R-CHOP? Well, those are shown here. And the numbers indicate that 99 patients who were started with polatuzumab required at least one subsequent anti-lymphoma treatment, whereas 133 of those assigned to R-CHOP required subsequent therapy. These include systemic treatments, stem cell transplant, and CAR T-cell therapy. So this is a primitive calculation. I've called it a back, we take an envelope and write some numbers down. And the question is, of course, about cost. So in US dollars, what is the cost to prevent one relapse? And we know that due to salvage treatment, there was really no overall survival advantage between the two arms. So if we simply tally up the costs for care and with available data, this is a very simple calculation. You can look at the cost of the polatuzumab. In the polatuzumab arm would be about $35 million. But there are more stem cell transplants in the patients who started with R-CHOP, and a rough cost of each transplant might be $100,000. CAR T-cell therapy is about $500,000 per patient. And so, you know, we get a total where there is a pretty significant imbalance with a higher cost. And so, at least by this calculation, you might say that it might cost about $1 million to prevent one relapse, which is a pretty high price tag and maybe calls into question the pharmacoeconomics of this, applying this treatment to all patients. So let's kind of look a little bit more towards the future and move past just treating all patients the same. As is probably familiar to the audience, there's been an explosion of next generation sequencing and other molecular techniques to query the molecular features of diffuse large B-cell lymphoma as well as other malignancies. This is the first paper published from investigators at Duke University Medical Center, which described the frequency of mutations across 1,000 patients with diffuse large B-cell lymphoma. Interestingly enough, it was noted early on that there was a differential sort of frequency of some of these mutations in patients with activated B-cell versus germinal center. In particular, the mutation in EZH2 was more commonly found in germinal center patients, whereas mutations in MYD88 and CD79B are more common in activated B-cell patients. Beyond this paper, there's now been two more integrated multi-omics studies. This is seminal work by investigators at the Dana-Farber Cancer Institute, led by Dr. Margaret Shep. And in this study, there was not only mutation analysis, but gene expression profiling and copy number alteration assessment to describe what's called clusters. You can see cluster 1, cluster 2, 3, 4, and 5, that all have some degree of similarity, molecular similarity. And what was noted actually is that the clinical outcomes of patients with germinal center diffuse large B-cell lymphoma can be subdivided into cluster 3, having higher risk disease than cluster 4. And similarly with ABC subtype, we can see that there's actually a favorable risk, which has the profile of cluster 1, whereas cluster 5 tends to have more unfavorable outcomes. And cluster 2 is also sort of a high-risk group of patients. This work was also largely mirrored by work through the National Cancer Institute, the NIH, led by Dr. Lou Stout. And similarly, this group described multiple groups with different nomenclature that have different clusters. What you can see is, again, in patients with germinal center diffuse large B-cell lymphoma, there are worse outcomes in those with the so-called EZB subtype. And in patients with activated B-cell subtype, we can see poor outcomes in the group called MCD, and other ABC subtypes have better outcomes. So if you're sitting there and worrying about the future and wondering how these all fit together, this might look, so how you view this. But it is reassuring to know that the work by Chapuis and Ship is actually very similar to the findings of the independent studies initially published by the Stout group. So cluster 4 has the mutation profiling listed here, and a better clinical outcome, and this is similar to the group called ST2. Similarly, the third cluster is high-risk germinal center patients with these EZH2 mutations and BCL2 translocations. And then if you go down to the activated B-cell subtype, we know now that cluster 1 tends to have better outcomes, whereas cluster 5 mirrors the poor outcomes of this MCD subgroup that has mutations in genes in the B-cell receptor signaling pathway. And then finally, cluster 2 is characterized by inactivation of the p53 gene, and these patients tend to have relatively sort of intermediate prognosis. So if we look toward the future, what has been put forth is the idea that not only is diffuse large B-cell lymphoma categorized as ABC or germinal center, but you could actually imagine a scenario in which a tumor biopsy is classified by using this algorithm called LymphGen. And then based on the subtype, you would then target individual pathways with specific pathway inhibitors such that the genetic subtype could aid in the development of rationally targeted therapy. This idea has some justification for it when examining the outcomes of patients on the Phoenix trial, which was the study of R-CHOP with or without the BTK inhibitor ibrutinib. Interestingly enough, you can see very favorable outcomes in the red lines here in those MCD patients. Those are the high-risk activated B-cell patients when treated with R-CHOP with a BTK inhibitor. And so that one of the concepts that's being developed in the U.S. cooperative groups is a lymphomatch trial in which we have molecular subtyping applied to biopsies from a large number of patients with diffuse large B-cell lymphoma. And depending on their cluster, they would ultimately be randomized to receive standard of care chemotherapy, which could be R-CHOP or R-CHP with polatuzumab, depending on various factors, and then adding various pathway inhibitors to test the selective benefit, if any, of adding these pathway inhibitors to standard treatment. So I'll summarize by saying that diffuse large B-cell lymphoma is not a single entity, but is unfortunately still largely approached this way clinically in 2022. while in general, germinal center-derived tumors have more favorable outcomes than those with activated B-cell subtype, there is definitely additional heterogeneity that can be explained. And we mentioned this cluster 3 or EZB subtype has inferior outcomes in the germinal center subtype. The MCD or cluster 5 has inferior outcomes in ABC subtype. And TP53 mutation is a negative prognostic indicator in all cells of origin. Clinical trials of targeted pathway inhibitors in large patient populations have largely been unsuccessful, but until recently, when the addition of the anti-CD79 antibody drug conjugate, polatuzumab vedotin, was used to substitute for vincristine in the R-CHOP backbone. And for patients with IPI scores of 2 to 5, we saw comparable toxicity with progression-free survival advantage without a overall survival difference. 2 randomized trials have suggested that ABC tumors may be more sensitive to polatuzumab, but it's really unclear if polatuzumab with RCHP is beneficial for double-hit lymphoma, or whether something like dose-adjusted EPOCH should remain the de facto standard. More sophisticated cost analysis than what I put forth is really needed to determine the cost effectiveness of uniform use of polatuzumab in the frontline setting. And in the future, frontline clinical trials will really require integration of multi-omic biomarkers to test precision medicine using specific pathway inhibitors for individual subtypes of diffuse large B-cell lymphoma. So with that, I'll conclude and thank you for your attention and take questions if there are any.
So thank you very much. It was a very enjoyable lecture. So diffuse large B-cell lymphoma is a very heterogeneous disease, as you have shown. I think one approach that we have done wrong over the many years with the negative trials comparing, additional drugs to R-CHOP, all of them have been negative, unfortunately, is that I think we're using this approach of one size fits all, which I think it's really wrong in the clinical trials. It may be right in the clinical practice until we show evidence in the trials, but I think that one approach that we should do from now on in the clinical trial is to have a subgroup analysis. For example, you have shown that Polar study is showing ABC showed benefit with adding Polar, and also the Phoenix trial putting it in younger patients. So I think the key is actually the subgroup kind of analysis and treating patients instead of one large group, it's into smaller groups and randomize them accordingly. And I think this should be the future.
Yeah, no, I agree. It's clearly the way the field is moving. The challenge, as you're probably aware, is that it's not a simple task to perform the subgroup molecular testing. At the time of diagnosis, frequently patients are need immediate treatment. So one idea is to give a cycle of R-CHOP or or maybe polatuzumab, RCHP, and then wait and then send the biopsy for this molecular testing, and then starting with the second cycle of treatment, then add or compare targeted agents. And so that's a strategy that would allow those high-risk patients to be enrolled, those who have aggressive disease that need immediate treatment. But I agree. I think the future really needs to be more precision medicine.
Let's questions.
Thank you, Brian, for the lecture and talk, overview of this topic. So my question, how about another strategy where you would introduce polatuzumab you would use, you use, for example, interim assessment with a PET or other modalities, and introduce Pola for those with suboptimal response and
Yeah. That's a really interesting idea. interim PET scan, as you know, is very commonly used in Hodgkin lymphoma, and it is appropriate to do some form of interim response assessment to make sure that your R-CHOP is, taking you in the right direction. And the idea that interim PET could then be used to risk stratify patients to show, maybe test adding a more targeted agent like polatuzumab to those who are having some suboptimal response is a really interesting idea, and I think would be definitely worth exploring that in a prospective setting.
One more question.
Thank you, Dr. Brian, for this presentation. My question, have you changed your practice from R-CHOP to R-CHOP? Do you think ABC time now is evident, they will benefit more based on the ER-POLA and R-CHOP POLA, it's duplicated result?
Yeah, so those are great questions. I'll repeat them. The first question was, have we changed our practice? And the second question was whether we would maybe use the polatuzumab only for the ABC patients. So to answer the first question, in the US, there has not yet been regulatory approval of this regimen to be FDA labeled. And so we have a system of reimbursement that requires something to be either approved or on certain guidelines before it will be widely covered by healthcare insurance. And so I would say hasn't been, we in most centers are not using this as frontline treatment, but that may change next year. I think using following the data and using it for the higher risk IPI score patients would make sense. That would be IPI 2 to 5. And while I'm very intrigued by the potential for a differential impact of polatuzumab in the ABC patients, the study wasn't really designed to answer that question. That was more of a subgroup analysis after the study was done. And so while it's very intriguing, it's a little tricky to use that clinically, and especially because the testing we have for germinal center or non-germinal center is called the Hans algorithm, where it's really just looking at your pathologist's interpretation of those stains. So it's a little, I think, tricky to then extrapolate and say, well, all of those non-germinal center patients really are ABC, and therefore they should get polatuzumab. But that certainly is something that could be tested prospectively.
I think we will conclude. So thank you very much, Dr. Brian, for this excellent talk. We will move to the last lecture in this session.
Thank you. Thank you for having me.
Yes, and hopefully to see you in present next time.
Thank you.
Okay, so the last lecture will be again welcoming Dr. Radia from the United States to talk about multiple myeloma, how to sequence new therapies. So we'll welcome back.
Well, thank you. I'm sorry if you were hoping for a different speaker, but I must have been cheap. I came 2 for 1. But thank you again for your attention. And these are my disclosures. I think we all can agree that there's been an explosion of therapies in myeloma. And so this is just a nice sort of kind of way to illustrate just what's happened since 2000. So on the top, you really see the stage dominated by the PI.
You may need to share your slides, Jesus.
Oh, I'm sorry.
Unless other people are seeing that.
That would be helpful, wouldn't it?
Yeah.
Sorry about that. Let's see. Can you see him now?
It's not shown yet.
Okay, let me try this one more time. Share my screen, share, and then start. See, this is why I had to have two talks, because I didn't figure it out the first time. Now can you see them?
Yes.
Okay. All right, so now you can see. Okay, so here, I'm showing you sort of what's been approved in myeloma since 2000, and it's really quite impressive, right? So on the top, you see it's all dominated by the PI and the IMiDs and the anti-CD38 antibodies, but really since in the last couple of years, you see that the BCMA-directed therapies are really taking center stage, with now 3 approved in the United States, and actually now in the EU 4, with teclistamab, the first BCMA bispecific antibody approved, and we're hoping that's coming to other countries as well. And so I showed you the slide before. Again, we've made lots of improvements in terms of response rates, and overall survival keeps improving, but the majority of patients continue to relapse. And one of the sobering things, I think these are still sort of appropriate here. On the left, you see that as patients relapse and they go to the next line of therapy, the expectation is that the median response duration continues to decrease. And then on the right, I think even more important, it shows the study from Britain showing that there's a significant attrition of patients moving from first line to second line to third line. So the majority of patients not necessarily being able to receive more than 2 lines of therapy. And so I think this is important in terms of using our best, putting our best foot forward and not reserving therapies for patients, in my opinion. So when we look at sort of the treatment landscape for myeloma, I think we can put a sort of a dotted line from the first, second, third line to fourth line and beyond. And so I don't have enough time to really talk about the sequencing of therapies in the early lines. I just sort of suffice to say that I think it's not unreasonable for us to be thinking of a PI and IMiD combination in first and even second line, with likely the addition of an anti-CD38 antibody, perhaps even, as you know, the quads coming in first line looking very strong. And then as we get sort of more towards the third line, we start sort of looking at next generation of PI and IMiDs with and without the anti-CD38 antibodies or other antibodies in our second and third lines. And there's a dozen or over a dozen studies now looking at triplets versus doublets, all showing an improvement to the triplets. So without a doubt, at least a triplet should always be considered or preferred over a doublet in the early lines of therapy. But I'm really going to concentrate on sort of the fourth line and beyond, where really the BCMA-directed therapies have taken center stage. So the first that was approved is belantamab mafodotin, and this is an antibody-drug conjugate against BCMA. So it's an antibody against BCMA that is bound to MMAF or monomethyl auristatin F. And as you saw before with polatuzumab, the idea here is that the antibody binds to BCMA, gets internalized, and MMAF gets released inside the cell. But this, what makes this different from other ADCs in the past in myeloma is that this antibody actually is functional. So you actually also have an anti-BCMA antibody that can elicit something, things like ADCC and ADC. So the DREAM-1 study was the original study looking at this ADC, and as you can see, there was a significant overall response rate of 60% with a median PFS of 12 months, and that looked quite impressive. But when you started looking at the patient population, you noticed that this study was mostly done in Canada, and in Canada at the time, the anti-CD38 antibodies were not approved. And so the DREAM-2 study really looked at the population of highest need, which was the patients who had prior IMiDs, PIs, and anti-CD38 antibodies. And so in this population, now you see a more attenuated response with overall response rates of 31 and 34%, depending on the dose, and a median PFS of 3 to 4 months. Based on sort of kind of duration of response and doses, the 2.5 milligram per kilogram dose was chosen to move forward. What's interesting is that even though the response rates don't look quite impressive, if you look at the actual duration of response in those patients that do respond, it's actually quite nice, and with a median duration response of 11 months and overall survival of 13.7 months. So this what got belantamab mafodotin approved after in the fourth line higher setting. In terms of toxicities, it's a very well-tolerated drug. The main toxicity that is new for us in myeloma is this keratopathy. So these corneal deposits that occur in actually the majority of patients, in over 2/3 of patients, with significant amounts of grade 3 and 4. And so it's an important toxicity to pay attention to. And because of this, It is recommended, and at least in the United States, it's approved with the caveat that a patient see an ophthalmologist or an optometrist before each dose of therapy. The good news is the majority of patients who did develop keratopathy had all the symptoms and all the deposits were reversible once you came off the treatment. The next type of therapy that for BCMA is, of course, the bispecific antibodies. And so here I just show you a cartoon of a bispecific antibody. You basically have an antibody that has two targets. One target binds to BCMA on the myeloma cell, and the other target binds to CD3 on the T cell, activates the T cell, redirects it to the myeloma cell, and kills it. So there are several BCMA CD3 bispecifics in myeloma, teclistamab, REGN 5458, ADV383, elrantamab, and AMG 701. I will not go through all of them. I am removing AMG 701. This is not moving forward, actually, so it's unfortunate, but I guess we've had a lot of competition. But teclistamab really has sort of kind of taken the lead, and is the one that I'm going to show you some clinical data on, and is very close to approval in the United States, and again, it's been approved in the EU. So teclistamab was approved based on the MajesTEC-1 trial. And so this was a phase 1/2 dose escalation. Patients had to have at least 3 prior lines of therapy. They did not allow prior BCMA targeted therapy, which I think is important. Patients were treated intravenous and sub-Q. Patients also underwent step-up dosing, so they got 2 to 3 small doses before getting the full dose. And so the recommended phase 2 dose from this trial turned out to be 1,500 micrograms per kilogram subcutaneous once a week. So just kind of summary of their efficacy data, you see that the overall response rate on the left is 63% with a complete remission rate of 39.4%, a VGPR rate of 59%, so quite impressive and deep responses. In the middle, you see the duration of response. The blue curve shows you the entire population with a median duration of response of 18.4 months. And in the patients who achieved a CR or better, the median duration response has not been reached. On the right, you see the progression-free survival. And here we saw the median progression-free survival of 11.3 months with a median overall survival of 18.3 months. So again, the expectation in this population is median overall survival of less than a year and PFS of about 3-4 months. So quite impressive results. In terms of the toxicity, it's manageable for the most part. There is some cytopenias, although in my experience, this tends to be very early on and likely more reflective of burden of disease in the bone marrow of myeloma. Patients who have very little burden disease often don't have significant cytopenias. And then the cytopenias taper off later as the patient responds. CRS is very common. You see 72% of patients with cytokine release syndrome, but very little grade 3/4, and much less in my mind compared to the CAR T cells. The CRS tends to occur during the step-up dosing and rarely beyond the first full dose. So again, it's interesting and I think reassuring that with subsequent dosing, you don't see CRS. And neurotoxicity equally was quite rare. What is important, though, to pay attention to is infections. So remember, you are continuously redirecting T cells with these therapies. So these patients are getting weekly dosing of the antibody. And so they saw 76% of infections and 45% grade 3 or higher. And we're starting to see some atypical infections or infections that are important, often seen sort of in the allo setting, kind of adenoviral pneumonias and CMV reactivations, et cetera. So, and PJP as well. So I think it's an important thing to remember as our patients continue on these therapies. Of course, I'm not going to show you the CAR T data again, but just to suffice that we also have 2 BCMA-directed CAR T cells, idecaptan Viclucel and ciltacabtagene autoleucel. And just a reminder of the efficacy data with overall response rates of 73 to 98%, depending on the product. So I'm showing you here sort of a high-level comparison of the BCMA therapies, the ADCs, the bispecific, and the CAR-T. So obviously we have at least one in each class that's approved for us. I think if I put them in order of sort of what the efficacy expectation is, I think we all can agree that the ADC has the less efficacious, and then the bispecific and the CAR-Ts, I think, have the more powerful quick efficacy. In terms of duration of response, I think they move in that direction as well. Although as the bispecific antibodies so far are showing some very durable responses, very reassuring. So it'll be interesting to see if that turns out to be even better than the CAR-Ts. Although I think the early indications is maybe the newer generation of the CAR-Ts will still be, at least in this patient population, will still be better, but remains to be seen. How it's given, I think it's important when you're trying to kind of decide between the different therapies. So remember, the ADC is given intravenous every 3 weeks until progression of disease. The bispecific is given intravenous or subcutaneous every 1 to 2 weeks until progression of disease. And the CAR-T cell is a one-time treatment with no maintenance, which, as we discussed before, oftentimes leads to preference from a patient standpoint. Where can these be given? The ADC can definitely be given at all centers, including community centers. Right now, I think the bispecifics and the CAR-T cells are still relegated to academic centers. The hope is the bispecific antibodies will be able to move into the community as well. But I think we need to sort of figure out a way to be prepared in how to mitigate sort of these initial toxicities in the first, and the dose escalation in the first cycle. But definitely, I think it has more potential to move into the to more centers than the CAR-Ts themselves. In terms of notable AEs, obviously the ADC, you have the keratopathy, which is thought to be due to the MMAF. And then, of course, with bispecifics and CAR-Ts, is cytokine release syndrome and neurotoxicity. Although I think if we go to CRS and neurotoxicity, I think the grade and sort of the intensity of the CRS and neurotoxicity is higher with CAR-T versus bispecific. And of course, in terms of availability, both the ADC and the bispecific are off the shelf, whereas the autologous CAR-T cell, you have to wait for the manufacturing wait time, and sometimes your patients cannot wait for 4 to 6 weeks before they get their treatment. So unfortunately, like I showed you before, most patients do relapse after BCMA. So the question is, can we sequence these therapies? And I mean, the short answer is we don't know. But we do now have some real world experience, and as well as some early data from clinical trials that are helping us hopefully understand this a little bit better. The first was the experience from UCSF, which was presented at the IMS this month, at the beginning of the month. In Los Angeles, they had 78 patients that were treated with BCMA CAR-T, and 42 of those patients relapsed. And so when they looked at sort of what the treatments these patients received after a BCMA CAR-T relapse, 8 patients received another BCMA CAR-T, and they saw an overall response rate of 75%. 5 patients received a BCMA bispecific with an overall response rate of 60%. And then 7 patients received belamaf with an overall response rate of 29%. So the response rates of the bispecific and belamaf are actually not too dissimilar from what we saw in the clinical trials. And the CAR-T actually also was impressive, although maybe not as high as we saw in the clinical trials. But still very reassuring that after BCMA CAR-T, you still can treat with other BCMA modalities. When we look at the real-world data from the multi-center trial data from IDACEL that I showed you earlier, they also looked at patients who had prior CAR-Ts, yes or no. So the blue curves are the patients who had prior BCMA therapy, and unfortunately, they did not see a similar to what they saw at UCSF. Here, actually, there was an adverse effect of having a prior BCMA therapy with the median PFS, for example, of 9 months versus 5.8 months, and overall survival not reached versus 7.4 months, which kind of goes. The question is, should we be using BCMA-directed therapies prior to CAR-T? It's unclear. So now we actually have some clinical trial data, although it's very early. So CARTITUDE-2, I showed you cohorts A and B before. This cohort C, they treated 20 patients who had prior BCMA therapy, and they received cilta-cel. And so you see the breakdown here of the 20 patients, 13 had prior ADCs and 7 had prior bispecific antibodies. They excluded patients with prior CAR T. So again, these were non-CAR T BCMA therapies. So if you look at the overall response rate, you see that in the patients that had prior ADCs, you had a 62% overall response, all of them VGPRs. In the prior bispecific antibodies, overall response of 57%, 43% VGPRs, with duration of responses that were actually quite good. But clearly, the response rates are not at all comparable to what we saw in CARTITUDE-1, where it was almost 100% or 98% response rate. So definitely the treatment with the prior BCMA does make a difference, even with something as powerful as cilta-cel. So again, this is very early data, so we'll have to kind of wait and see a little more patients enrolled and also longer follow-up. What about bispecifics after BCMA? So we actually have some data now from with teclistamab. So I told you that Majestic-1 excluded patients with BCMA, but they actually had a cohort C that was looking just at patients with prior BCMA. So these had 40 patients. And 70% of the patients had a prior ADC, and 37% of the patients had a prior BCMA CAR T. And so you see the overall response rate is 52% with a VGPR of 47%. In the ADC exposed, 55% overall response rate, in the CAR T, 53% response rate. So again, these are actually very nice numbers. The overall response rate in the entire population for teclistamab non-BCMA was about 63%. So still remains very active even after an ADC or BCMA. And we don't have a median duration of response just yet. And the safety profile was really no different than the entire population. So this maybe perhaps is telling us that we could use the bispecifics even after a CAR T or an ADC. Elranatamab, which is another BCMA CD3 bispecific, also had patients that allowed inclusion of patients post-BCMA. And so here they had 55 total patients, and 13 patients that had prior BCMA, 8 prior ADC, and 9 prior CAR T. And you see the overall response rate for all the patients was 64%, and the prior BCMA 54%. They did not break it down by type of prior BCMA, but again, showing that there are response rates in these patients. So in terms of sequencing BCMA-directed therapies, I think, the expression of BCMA, we know the expression of BCMA remains in the majority of patients who relapse. So we know we could use BCMA-directed therapies, and they technically can be sequenced. I think the early data shows us that sequencing is reasonable. Maybe the CAR T response rates are not as effective or not as good in patients with prior BCMAs. And I think that's a very important point from a standpoint of bridging therapy to your CAR T. I would definitely not use an ADC or any kind of BCMA-directed therapy prior to CAR T, given those results. The bispecifics appear to retain efficacy, and they may be better sort of as sort of the next line of therapy if the patient has had a prior BCMA instead of a CAR T. But I think ultimately, figuring out the mechanisms of resistance will be important to really help us determine the optimal sequencing. Just like before, obviously, maybe we don't have to sequence BCMA therapies because we have other targets coming in our path. And so these are the two sort of lead the way. There's bispecifics against both of these. So one is FcRH5, which is expressed really exclusively in B cells and myeloma cells. And so cevostamab is a bispecific against FcRH5 and CD3. And then on the right, you see talquetamab, which is a bispecific against GPRC5D. And GPRC5D is also mostly expressed in myeloma cells, although there is some limited expression in highly keratinized tissues and salivary glands, which you'll see predicts some of the toxicities. So if you look at cevostamab on the left, you see that the majority of patients, when you see all the treated patients, this is our phase 1 dose escalation, is overall response rate is 36%. But when you just look at the patients sort of in the higher doses, or think of the efficacious doses, you start seeing overall response rate now closer to 60% with VGPR of 33%. they actually had 33% of the patients had prior BCMA therapies, and the overall response rate for those patients was 63%. So again, showing us that there is significant activity even after BCMA therapy. The median duration of response is quite good at 11.5 months. And what's interesting with cevostamab, unlike the other bispecifics, is they had a limited duration of treatment. So patients stop treatment after 17 cycles. This is given intravenous every 3 weeks. So that's a year of therapy. And after a year, patients were stopped. And you'll see at ASH, actually this year, there'll be a presentation on what's happened to those patients, but we can tell you that patients maintain their response after stopping therapy. So that's actually quite encouraging. Perhaps we don't have to keep giving the bispecifics till progression. Similarly, for talquetamab, the Monumental 1 study has been reported several times and will be reported again at ASH this year. You see that they have 2 expansion doses. One is a 405 micrograms per kilogram subcutaneous weekly, and the other is 800 micrograms per kilogram subcutaneous every other week or every 2 weeks. And both doses are efficacious with response rate of 66 to 70% with a high rate of VGPR CR rates. 25% of patients have prior BCMA therapies, but they have not reported on these results, so we don't know what the activity is in these patients. The duration of response has not been reached, or the median duration of response has not been reached. The toxicity is very similar in terms of cytokine release as we've seen with the BCMA bispecifics and the FcRH5 bispecifics. But here you do start seeing some on-target off-tumor toxicities. And so many patients do develop dysgeusia, dry mouth, nail changes, and rash, which can be difficult for some patients. The good news is that those symptoms are hardest at the beginning, and with time, even on therapy, they continue to improve, but they don't always go completely away until you actually stop the therapy. I showed you this before with the GPRC targeted CAR T. So again, now CAR T is developed against other targets, very promising. And then if you look specifically at the prior BCMA treated patients, it looks very efficacious with response rates of 75 to 80%. So in summary, I think in general, for patients, we recommend that you treat to maximum response, balancing the toxicity. In the early lines of therapy, I think triplets for sure should be chosen over doublets. And I didn't really go through that data, but that's just a summary recommendation. And definitely quads in the frontline setting are very reasonable. I think in the post-IMiD-PI CD38 space, the BCMA therapies are definitely your go-to treatments, as they're sort of most efficacious at this point. And 3 classes are now approved or about to be approved. And so the question becomes, how do we sequence these? How do we choose between the 3? Which one do we use first? And I think, at least for now, until we know more, you really need to tailor your choice of therapy based on the availability, first of all, the disease characteristics, the patient comorbidities, and then ultimately the patient preference. In my mind, I think if a patient is a little more frail, I'm going to be probably leaning against from CAR T and maybe going more to the ADC and perhaps even the bispecific. But I think if you have a bispecific CAR T option, I would definitely choose that over the ADC. Again, except for that patient that may not be eligible for those 2. From a standpoint of how to choose between the bispecifics and the CAR Ts, I think both are excellent therapies. And again, I will come down to what's available and patient preferences. Like I said, I have patients that will only take a CAR T, they will take nothing else because they want to have that potential for treatment-free period. I think it behooves the bispecifics to actually start looking at durations of therapies that or treatment that does not continue to progression. We are starting to see that these after a limited number of cycles, we can see durable response rates. And so perhaps the bispecifics don't have to be given traditional way like other myeloma therapies. So I think more to come from that. And if that happens, I think that will really make them even more powerful in comparison to the CAR Ts from a standpoint of which to choose. I think, perhaps once you decide which one you choose, you don't have to think about another BCMA therapy because the non-BCMA targets are already underway, and it's intuitive that perhaps going to a different target makes more sense. And so definitely the GPRC5D and FCRH5 targets are leading the way, but there's many others that I didn't show you, which is wonderful, and because of that, I think the future of myeloma remains bright. And so with that, I'll stop and thank you for your attention.
Very exciting data about all these new options of treatment. Now, it seems like using BiTE, for example, like teclistamab after CAR-T works, but that maybe not the other way around so much. So would you say that you would, if you have the two options available, you would defer the BiTEs later on for a later relapse so that you would have two lines of therapy instead of using one of these lines? And also another part of this question is why is this difference there between the, the sequencing of these two options?
Right. No, I mean, those are great questions, and the short answer is I don't know, but I think I really do think that if CAR-T is an option for your patient, that at least in my mind, that's what should be pursued. Based on everything we've seen, they're very impressive and very deep remissions that can be induced and can be very durable. And as you know, a lot of our patients have been on treatment for years at a time, and they're tired of treatment. And that treatment-free period shouldn't be underestimated. I actually have a patient who was in the original trials of CRB401 with now ide-cel, and she's been in remission for 5 years, and she wouldn't trade it for the world. So she's like, when it comes back, I want a different CAR-T. I'm like, okay. So I think, and then we're seeing now that maybe if you kind of give a CAR-T after another BCMA therapy, maybe you don't get the same kind of durability and response. So I do think right now, if I had to, if you had both options equally, I would choose the CAR-T before the bispecific for that reason. But the truth is, right now, most people don't have access to the CAR-T, and we're in the United States, at least, we're seeing a lot of manufacturing failures and issues, and really the wait times are 6 months plus for patients. And as you know, most of these refractory patients can't wait that long. So I really do think that the bispecifics are going to take center stage from that standpoint, most because of availability. And so I think most people will be getting the bispecific instead of a CAR-T. But if you have the option between the two, I still would go with the CAR-T first and then the bispecific. And then I forget what you asked second.
Why is there a difference in terms of?
Oh, yeah. So I don't know. We don't really understand the mechanisms of resistance. The only thing I can think of is that, when you look at the CAR-T data, and we talked about ide-cel before, that patients are relapsing even in the presence of CAR-Ts. There clearly appears to be some exhaustion that happens with the CAR-Ts and are no longer effective. And so perhaps with the the bispecific antibodies, you are continuously redirecting new T cells, and so I think because of that, I think you have the potential to maybe sort of reinstigate that effect that you don't see with that one and done CAR-T. The other thing is, if you look at CAR-Ts and you give the same CAR-T, you don't really seem to get much of efficacy. But if you give another CAR-T or a different product, you do get a response. So again, going back to maybe the idea that perhaps sort of a different T cell is still beneficial from a standpoint of not reusing or keeping that same kind of group of T cells that have now become exhausted or ineffective. That's the only thing I can think of.
Any other question? Seems like we're at the end of this session, so we would like to thank you again for joining us, and hopefully want to see you next time.
Well, thank you again for inviting me. I know it's late.
So we have reached to the end of this session, and I would like to remind everyone to invite you to the evening satellite symposium that will start at 8 p.m. The venue is at the Brera Hotel in Nakhib. The moderator will be Dr. Ahmed. So thank you very much again.